So anahepatic phase is the most challenging phase because there is no liver, so there is no production of clotting factor, fibrin deficiency, which is worsens the coagulopathy. Progressive hypocalcemia because of absent in citrate metabolism, lactic acidosis, reduced gluconeogenesis, and therefore the patient are more vulnerable for the hypoglycemia and increase in the serum lactate level. New hepatic phase in which the graft is reperfused. In this, hepatic artery anastomosis and biliary reconstruction is done. Hypertension and further decrease in SVR is occur in this stage. It causes post-reperfusion syndrome where the mean arterial pressure decreases 30% in the first minute after for 1 minute after the first 5 minutes of a reperfusion. So, and there is a sudden preload increase at the reperfusion which causes the cardiac dysfunction. Abrupt increase in potassium at a reperfusion with a possible arrhythmias and cardiac arrest. So coagulation factor concentrate are used instead of the use of blood product in a liver transplant patient may worsen fluid overload, portal hypertension, and paradoxically increases bleeding during surgery. So allogenic blood product transfusion is associated with the increased morbidity in terms of respiratory complication and mortality. Prothrombic complex concentrate and fibrinogen concentrate are alternative to fresh frozen plasma with added benefit of reduced volume of transfusion, and their use did not cause higher incidence of thrombotic and ischemic complications. These are the prothrombic complex concentrate and fibrinogen concentrate. During anahepatic phase, IVC side clamping is better than the cross clamping with the following situation. When there is a creatinine is more than 1.5 times of time at a transplantation. During renal failure, more than 2 weeks preceding 2 months. GFR is less than 40 ml per minute. When a renal dysfunction requires dialysis in the preceding 6 months. And in case of medical renal disease with a proteinuria of 500 mg and indicative of nephropathy, diabetic or hypertensive. In a case of hepatorenal syndrome and acute kidney injury. Attempt to side clamping should be done in all cases except if a narrow IVC. The IVC side clamp is done side clamp is also done in those patients who are not tolerated the IVC test clamp. In case of all heart disease patient and acute liver failure. The analgesic option in liver transplant are short-acting opioids, paracetamol, and transverse abdominis and rectus sheath blocks. Extracorporeal membrane oxygenation can be used in a cardiorespiratory failure following liver transplant, but the cases are very few and outcomes are equivocal. Venovenous ECMO has a role in a persistent hypoxia due to hepatopulmonary syndrome following transplant. Renal replacement therapy is mainly used in context of acute or chronic liver disease and acute liver failure, which carries high risk of morbidity. Indication for renal replacement therapies are oliguria, acidosis, volume overload, hyperkalemia, hyperammonemia. A operative concern using RRT is a space for circuit, temperature maintenance of a dialysate fluid, and hypocalcemia and citrate toxicity. Enhanced recovery after surgery or fast tracking after liver transplant has a potential advantage to improve early graft blood flow due to negative intrathoracic pressure during the spontaneous ventilation. It reduces the ICU stay and decreases incidence of nosocomial infection. A selection for early extubation depends upon the duration of a surgery, amount of blood and blood product transfused, and preoperative status of the patient, ischemia time, and status of a graft. The safe operating room extubation after liver transplantation score is used, in which there has a major and minor criteria. The major criteria is more than 7 packed red cells used intraoperatively. End of surgery lactate is more than 3. Minor criteria when patients are admitted preoperatively in the hospital. Duration of surgery more than 5 hours and vasoactive drug infusion. The few complications of end-stage liver disease like hepatopulmonary syndrome and their management. So hepatopulmonary syndrome has a clinical triad of arterial deoxygenation, intrapulmonary vascular dilatation, and liver disorder. It has a prevalence of 4 to 32% and diagnosed by the microaggregated albumin scan and bubble echo. HPS criteria by definition is a PO2 less than 70 mm of Hg and alveolo-arterial venous gradient of 15 to 20 mm of Hg with the patient with supine position. Bubble echo suggestive of bubbles in the cardiac fourth or fifth beat of cardiac cycle. Evidence of liver disease in cirrhotic stage. So treatment strategy in HPS are like giving Trendelenburg position, which causes gravitational redistribution of a blood flow to the upper and mid zone and decreases blood flow to the intrapulmonary vasodilated vessels. Inhaled vasodilators like nitric oxide and epoprostenol are used, which causes preferential dilatation of a normal vessel and redistribution of a blood flow. IV methylene blue is used to, it causes a vasoconstriction of a dilated vessels and decreases the blood flow to IPVD. Then inhalational vasodilator and methylene blue has a synergistic effect. Embolization of a lower lobe vessels done generally preoperatively, it causes redistribution of blood of IPVD to mid and upper zone. Extracorporeal ECMO can be used. This is the chart we use. Hepatorenal syndrome and their implications, like intraoperatively we have to uses terlipressin plus albumin or and sometimes diuretics. Renal protective strategies are used, like bezisteximab at induction for immunosuppression, which delays the calcineurin inhibitor introduction. Dose of 20 mg is given in anapatic phase over a period of 30 minutes. POD1 and POD4 is a recommended dose. Side clamping is preferable in these cases. Avoiding a neurotoxic drugs and renal dosing modification of antibiotic. Intraoperative CRRT can be used. In patient with ALF, ALF is an emergency liver transplant, so patient may not get the ideal donor most of the situation, so high chances of marginal donor organ are used. Use of plasma exchange and CRRT in a preoperative period. Intraoperative use of may require CRRT because of lack of long-standing portal hypertension and portosystemic collateral. Side clamp of IVC and portocaval shunt are done in the anapatic phase. Cautious use of volatile anesthetics are used as it causes cerebral vasodilation. Non-invasive neuromuscular neuromonitoring is done with the help of EEG, optic nerve sheet diameter, and transcranial Doppler and BIS. Then these patients are more prone for hypoglycemia, so blood glucose is carefully monitored and corrected. NAC infusion has a role in ALF. In disease donor management and optimization, the aim of medical management is to optimize the quality of transplant organ. Donor optimization is the process that switches the focus from the treatment of that directed toward the recovery of injured brain to those of a focus on the resuscitation of potential transplantable solid organ. So medical management is the key success rate of organ transplantation in these cases. With the help of hemodynamic goals of maintaining euvolemia with a mean arterial pressure of 60 to 70 mm of Hg and central venous pressure of 6 to 10 mm of Hg, and urine output of 1 to 3 ml per kg per hour. Monitoring is done with the help of arterial line and central venous catheter. Blood pressure is maintained with the vasopressor. Vasopressin is the preferred line of first treatment. Volume replacement with the balanced crystalloid, and respiratory lung protective strategies are used. The metabolic goals are to keep serum sodium 135 to 145 millimoles, blood glucose less than 180 mg per dl, and hormonal replacement therapy is used with the glucocorticoid, thyroid hormone, and insulin. A patient generally has a diabetes insipidus, which is result in a large volume of diluted urine with the increased serum sodium. So use of desmopressin and vasopressin. General consideration are continue the liver donor management in the perioperative period using the organ till the organ is removed. A target HB concentration of more than 7 gram per dl. Role of anesthetics is the aim is to avoid the ischemia of a donor organ by maintaining the hemodynamic stability. Preliminary roles are like verify the brain dead certificate, consent from the family, and in a medical legal cases, proper authority should give a permission for the retrieval of organ. In anesthetic management, main aim is to maintain the hemodynamic stability. Long-acting non-depolarizing muscle relaxant are used for optimal exposure of intra-abdominal organ and to suppress the spinal reflex. Volatile anesthetic and narcotic to facilitate the hemodynamic stability. Ischemic precondition with the use of isoflurane and sevoflurane can improve the graft organ function by offering protection against the cold and warm ischemia. Prophylactic antibiotics should be given if not given in ICU. Hormonal replacement therapy can be given. Cardiac arrhythmia are managed with the correction of electrolyte imbalance, antiarrhythmic drug, internal DC cardioversion, and cardiopulmonary resuscitation. These are the parameter goal during the anesthetic management. In recent study, NAC has a role in improving the graft survival. After the dissection of abdomen organs, after the dissection is completed, donor are anticoagulated with the 300 to 500 unit per kg of heparin prior to the cannulation of aorta. Ventilation may be disconnected at the time of aortic cross clamping. At this time should be noted as this is the actual time of death. In living donor liver transplant management, the aim is there should be no harm done to donor and recipient get the best graft of the optimal outcome. Advantages are living donors are hemodynamically stable. They have excellent quality of a graft and it's a planned elective surgery. Cold ischemia time is reduced significantly, which causes lesser reperfusion injury. There is a significant reduction in the time spent on a waiting list. So donor evaluation protocol done in 4 phases. In the first phase, basic blood test with serological testing, then liver attenuation indexes and MRI resonance fat estimation. In a phase 2 is the triphasic computed tomography for abdominal whole volumetry of organ and vascular anatomy. In a phase 3, cardiopulmonary workup is done. Stress cardiography for the donor more than 35 years of age, and echocardiography and treadmill test for donor less than 35 years of age. For female, bilateral mammography, transvaginal ultrasound, and ultrasound pelvis is done. MRCP and donor more than 50 years, the calcium scoring and bilateral carotid vessel Doppler is done. In phase 4, we do the clearance from all the department. Preoperative consideration is the carbohydrate loading is recommended and patient fasting should not be exceed more than 6 hours for solid and 2 hours for liquid. Preoperative carbohydrate loading has a patient shows lesser perioperative insulin resistance, fewer symptoms like malaise, hunger, thirst, nausea, and anxiety. General anesthesia with the balanced anesthesia technique is used. Donor hepatectomy is divided into 3 stages, that is mobilization of liver and identification of vascular structure, transection of a liver, and hemostasis and closure. The method to reduce intraoperative blood loss is by decreasing the central venous pressure to 2 to 5 mm of Hg. Techniques are used as restriction of a fluid and use of diuretics, but it remains controversial. The risk of severe, with low CV, there is a risk of severe air embolism, renal hypoperfusion, and it is not an accurate surrogate marker for the hepatic vein and sinusoidal pressure. Other other severe issues are assessment of accurate CVP by tilt of operating table during transaction, positive pressure, positive end expiratory pressure, intrathoracic pressure, and use of surgical retractor and liver manipulation. Fluid management is mainly metabolic acidosis during transaction are due to lactic acidosis, which is because of decrease in hepatic blood flow and impaired hepatic function due to extensive hepatic resection. So balanced salt solution containing acetate are preferred. At the end of resection, 50 unit per kg of heparin is administered intravenously to prevent the clotting in the remaining liver following interruption of vasculature. Role of NAC in donor hepatectomy has been shown as a beneficial and in which 2 groups are divided. The study shows there is a serum lactate and INR value shows a significant reduction after 48 hours when in a group with the use of NAC than compared to the control group. all the patient living donor are extubated in the operating room. Pain management can be done with thoracic epidural or bilateral paravertebral block or intrathecal morphine. But nowadays we are going away from the epidural and intrathecal strategies. So use of USG guided facial blocks are upcoming thing. So transverse abdominis plane block, erector spinae plane block, or quadratus lumbar and rectus sheath block are used. Continuous wound infiltration catheter are placed. Multimodal analgesia regimes are essential component of enhanced recovery, which aim is to reduce the opioid consumption and their dose dependent side effect and that impairs recovery. Antithrombic prophylaxis with the low molecular weight heparin is given. So now the robotic approach has been used, which has the advantage of short hospital stay, less pain due to nerve sparing incision, decrease in blood loss and transfusion requirement, minimal scarring, fast recovery and quick return to normal activity. The challenges to anesthetics are patient positioning, that is 15 to 20 degree reverse Trendelenburg position, limiting the patient access after docking, central venous pressure management, then increased duration of, it increases duration of procedure, which causes hemodynamic and respiratory effect of pneumoperitoneum and occult blood loss. The complications of robotic donor hepatectomy are massive bleeding, in which the sore cannot be controlled adequately in timely fashion. So conversion to open procedure is required. Due to longer duration of surgery and prolonged pneumoperitoneum, there is result in hypercarbia, which should be corrected before extubation. Postoperative renal dysfunction and lactate clearance decreases secondary to the intraoperative hemodynamic and fluid management, surgical handling and blood loss, replacement fluids and impairment of remnant liver function. Prolonged reverse Trendelenburg position associated with the gas embolism, hemodynamic instability, peripheral neuropathy, corneal abrasion and vascular complication including compartment syndrome and thromboembolic diseases. Thank you.
Thank you, Dr. Kalpana, for a very extensive elaboration and presentation. Is there any question from the audience? Okay, so if there is no question, then I just ask one question to you. So, what do you think that how important it is, being an anesthesiologist, to communicate with the surgeon in the different phases of the transplantation?
So, with communication, we can know what the stage is going on. So we can pre-optimize patient, like if we can pre-optimize patient in anapatic phase. So for a IVC clamping, and if there is a IVC for gas embolism, air embolism, and blood loss, that way. Yeah.
Thank you. Any other question? Okay, thank you.
Thank you so much, ma'am. I request Dr. Vikram to felicitate Dr. Kalpana, ma'am. I request Dr. Sangeeta Shetty, ma'am, to come on the dais and felicitate our chairpersons. Good morning, ma'am. Dr. Premal. Dr. Vikram, sir. Dr. Swadeep, sir. Thank you so much, ma'am. So we move ahead with our next topic. I request the chairpersons to please take the dais. Dr. Sonali Saraf, ma'am, Senior Consultant, Jupiter Hospital, Anesthesia Department. Dr. Amay Sonavne, sir, Senior Consultant, Gastroenterology and Hepatology Department, Apollo Hospitals, Navi, Mumbai. And Dr. Surekha Patil, ma'am, Professor, D.Y. Patil Medical College and Hospital, Anesthesia Department. So our next speaker is Dr. Harshit Chaksota, sir, Senior Consultant, Anesthesia Department, Global Hospitals. We'll be taking all the questions at the end of this session. Dr. Harshit Chaksota, sir, is Consultant Liver and Multi-Organ Transplant Anesthesia, Glenius Hospitals, Mumbai. He has received gold medal from National Board of Examinations. He's later pursued his fellowship in liver transplant anesthesia and critical care and has experience of managing over 500 liver transplants. He has a special interest in pediatric liver transplant, bowel transplants, and in acute pain management services. I welcome sir to start with the next topic.
ये भी बिग स्क्रीन होगा क्या? ठीक, वो बंद करने को भी चलेगा, ये होगा. क्या हो गया? नहीं, इधर ये बिग स्क्रीन नहीं होगा ना? Good morning, everyone. Before I start, I want to thank the entire transplant anesthesia team in Apollo, entire anesthesia team in Apollo, to allow me to express my views on topic which is not so commonly done, at least in our country. This is a surgery which is not, or rather I should say very unusually performed surgery. And I'm very happy especially to deliver talk in this hospital where I spent more than 3 years of my life and started my journey in transplant field immediately after I passed my fellowship. So anesthesia for small bowel transplant or anesthesia for intestinal transplant, you can say, as I said, is not a very commonly performed surgery. If you just look at this data of 2021 and the second last line, which is of small bowel transplant, if you look at the numbers, in India, only 4 bowel transplants were done. And 172 were done globally, versus if you look at the final number of all the organ transplants, which were 144,000. That means 1,44,000 and 170 was the number for bowel transplant in 2021, which remained almost the same, 170 globally. And in our country, 3 transplants were done in 2022. I was fortunate that our unit had done all the bowel transplants in 2022 in the country, and I could not take the data of 2023, which is probably 9 or 10 transplant in the entire country as far as bowel transplant is concerned. Now, before we go ahead about the bowel transplant, I would want you to get introduced to this term called as intestinal failure, as it is with other organs like a chronic renal failure or a liver failure. There is something called as intestinal failure, which we need to aware before we go in the details of bowel transplantation. So intestinal failure is typically defined as whenever there is inability of the gut to maintain the homeostasis of protein energy or vitamins or minerals or fluid related due to mechanical or functional problems, resulting in the need of intravenous nutritional supplement to maintain the health. Now, typically in an adult, only 200 centimeters of functional good bowel is required to maintain the nutritional autonomy, which is around 20 centimeters in a pediatric age group. So you imagine whenever a person develops the intestinal failure, the length of the intestine is not even 200 centimeters. Who are these patients who present with intestinal failure? They are very typically in adults with the etiologies like short bowel syndrome, which results due to the resection of the bowel, like in a conditions like superior mesenteric artery or vein thrombosis, or due to trauma, there is extensive bowel resection. Crohn's disease, which leads to a functional variety of intestinal failure. There are tumors, volvulus, or in pediatric age group, intestinal atresia, gastroschisis, Crohn's disease, or pseudo obstruction, Hirschsprung's disease. So these are the common etiologies, but of course for all practical purposes, what we see in our day-to-day practice is short bowel syndrome, which again I'll come to in a minute or two. So this is the intestinal failure chart, which is due to intact, which can be due to intact absorptive area, which is kind of functional one due to dysmotility, congenital defect, or diseases associated with malabsorption, and loss of absorptive area when there is no bowel, which is called as short bowel syndrome. As you can see, there is no bowel due to the extensive bowel resection, either due to trauma or superior mesenteric artery or vein thrombosis, and practically only the large colon is large intestine is left behind. Most of the time, superior mesenteric artery or vein thrombosis requires extensive resection of the small bowel, and of course the ascending colon till mid-transverse colon. Now, intestinal failure is a syndrome of many signs and symptoms, or many components, which consist of the large volume or the enteral outputs from stoma or fistula, diarrhea, steatorrhea, electrolyte disturbances, chronic dehydration leading to renal insufficiency, vitamin D deficiency, gastric hyperacidity, micronutrient deficiency, this is more important, leading to electrolyte and other deficiencies, cholestasis. These are all the components. So now, those patients who present with intestinal failure, what are the modalities which can be offered to them? And a very well-known and easy modality of treatment is total parenteral nutrition, which we all are aware with. We initially started in 1969, and that was the era when it required hospitalization. But of course, now we can give home TPN also, and patients remain, or patients are alive on home TPN for many, many years. Typically, this is a Western data. 1 and 4 year survival on TPN is around 94 and 80% respectively, and 5 to 10% of the deaths which were reported were actually due to TPN. Rest of them were due to the progression of primary disease itself. Now, the success of TPN, it supplemented the then urgent need of finding the solutions for problem with intestinal transplantation, and TPN is still that standard of care for those patients who present with intestinal failure. But TPN, of course, is not a complication-free. It has its own complications and can endanger the life of the patient. So there was something over and above TPN that could be offered to these patients, which was intestinal transplantation. But before we go to that, there is something called as IFALD, which is intestinal failure associated liver disease. This is a terminology, or this is a condition in which even the liver gets affected for those patients who are on TPN for many, many years because of the fat content of the TPN, and that finally leads to fatty liver, steatohepatitis, fibrosis, and cirrhosis. So whenever we see those patients who are chronically on TPN for more than 1 or 2 years, we have to definitely look for this condition, and if they fall in this category, then they are the candidates for multivisceral transplantation also. So, as I told you, other than TPN, intestinal transplantation is something that can be offered to these set of patients. It was first attempted in 1980s. Intestinal transplant has the potential to restore digestive and absorptive function and liberate patients from long-term parenteral nutrition, thereby considerably improving the quality of life. Modern day approaches to immunosuppression and expertise in the surgical and the anesthesia side, there is improved long-term and the short-term survival of these patients who require intestinal transplantation. Most patients of intestinal transplants are free from TPN and enjoy an excellent quality of life. Compared with TPN, intestinal transplantation is cost-effective with 1 and 3 years of good graft survival. Of course, there is not much data, at least from our country, about the long-term survival. Now, when would you offer, or when a patient of intestinal failure is offered the intestinal transplantation? Whenever we see complications related to TPN. What complications? Typically recurrent septic infections, recurrent infections of the central lines, or whenever these are the patients who will require cannulations of the central venous. So whenever there is loss of central venous access, again they become the candidate for intestinal transplantation, and recurrent dehydration despite parenteral nutrition and the intravenous fluids. Other than that, of course, there are few more indications of liver transplantations, like liver cirrhosis with extensive portomesenteric venous thrombosis, which is not so common, but unresectable tumors in close proximity to mesenteric vessels, they also become the candidate for intestinal transplantation. And as for other organs, the contraindications are metastatic disease or malignancy not at the site of transplant, severe infections, and immunological deficiencies. These become the contraindications. Now, donor selection. Typically, these patients who undergo intestinal transplantations are from the cadaveric donors, and while selecting the cadavers for organ donation, generally we have to take care of a few things from the donor perspective. More often than not, these donors are young. Elderly grafts are not very much suitable for intestinal transplantation, and we also have to look at the donor size and donor body stature, because the intestine has to fit in a patient who's operated multiple times. There is no bowel, they have absolutely scaphoid abdomen. So if you give them a very large bowel, then there are chances that either you will end up keeping the bowel open, or you will end up having increased intra-abdominal pressure. So size of the donor has to be very carefully seen or assessed when we accept a particular cadaveric donor for the organ donation. The majority of the donors, as I told you, are a deceased donor, heart-beating deceased donors, and Again, very uncommonly done is living donor intestinal transplantations, especially for the pediatric patients, and as like we do for living donor kidney and liver transplantation, a part of bowel is given to the pediatric recipient. 1 and 3 year survival for living related donor patient, and the graft has been reported from the Western countries as around 80 and 75 respectively. Living related donation provides a potential future direction of intestinal transplantation by increasing the pool of donors, thereby reducing waiting times and waiting morbidity and mortality. Now, what are the goals of evaluation of the recipient who is supposed to undergo intestinal transplantation? Generally, how we assess for the other organ transplantation and other major laparotomies, we have to look for these points like comorbidities, any history of prolonged hospital stay, they must have undergone multiple surgeries, bowel resection, stoma, infections, re-exploration. So at least 2 or 3 surgeries they have undergone in the past, that we need to take care of. Cardiopulmonary fitness, we have to see. Vascular access needs to be ensured because they have multiple central line cannulations, and ultimately they end up having thrombosis of any of the major vessels. We have to rule out IFALD, as I told you, if we have any anticoagulation, especially because patients of short bowel syndrome or they have thrombophilia, so they are on one or the other form of the anticoagulation, which needs to be assessed and kept in mind. The investigations are routine investigations, routine blood tests, the cardiopulmonary assessment, ECG, echo, stress tests as and when indicated in an elderly patient with any history of coronary artery disease, or if any thing which is suggestive of IHD. Then from the pulmonary side, X-ray, HRCT, these are all the basic investigations that we do for all other transplant patients. And of course, as and when the IFALD suspected liver biopsy, to ensure there is no liver involvement due to the TPN. Now, what are the steps of the surgical steps of the intestinal transplantation? Typically, it is the dissection phase where the bowel is opened, and the abdomen is prepared for the new graft. If there is any colostomy, previous colostomy, which is also closed, then comes the implantation phase. Implantation phase is the phase where the new bowel is, the vascular anastomosis of the new bowel start, and of course, once the bowel is reperfused, then comes the post-reperfusion phase. I'll show you one by one so that you will understand. So on the left-hand side, as these patients have short bowel syndrome, the superior mesenteric artery and vein are gone, so we have to implant these vessels on the major vessels like aorta and all. So on left-hand side top, you will see that the aorta is side clamped or partially clamped. Aorta is opened up, and then the conduit is attached for it to get attached to the graft superior mesenteric artery. And on the second photograph shows that the conduit is ready, and now the clamp is placed on the conduit. So while the conduit is prepared, almost aorta, infrarenal aorta is either partially clamped or almost cross clamped. That is the point where we have to be very careful with systemic pressures and all, which I'll come to in later part of my presentation. So this is again the photo of IVC, which is almost clamped, and then conduit is being prepared for the venous drainage. This conduit is ready. So this is the dissection phase where all conduit are ready. And this comes the phase of implantation. You can see the bowel wrapped in a green cloth, and the conduit which was prepared is now being attached to the superior mesenteric artery of the graft. And now the vein is being anastomosed, and now there is opening of the bowel, and you can see the bowel which is nicely reperfused and pink in color. Now, what are the goals of our intraoperative monitoring? As for a major surgery, we require basic ECG, pulse oximeter, and NIBP two large bore venous access, peripheral venous access as well as central venous access is secured, you will definitely require cardiac output monitoring because there is significant hemodynamic instability, and viscoelastic monitoring like TEG is also essential. BIS and all, of course, if you have it is well and good. Position remains supine, and one more important thing is that transcutaneous defibrillator pads are always, you have to ensure that they are always attached because these patients can go into significant reperfusion at any point of time, and your thermoregulation devices must also be in place. Now generally general anesthesia is the preferred modality, and for epidural analgesia is the individual institutional protocol. There is no strict contraindication for it, but with the complications of infection, with the anticoagulation coming in the background, sepsis, generally we try and avoid the epidural and manage the postoperative pain and the intraoperative with opioids. Fluid management has to be goal directed with the balanced crystalloid. Hemodynamic instability occurs due to release of vasoactive endotoxins from the chronically infected abdominal tissues, which is even prior to the implantation, and use of vasopressors, noradrenaline, vasopressin to maintain the blood pressure. There can be significant bleeding due to the surgical reasons as the bowel is operated or the abdomen is operated 3 to 4 times previously. Blood transfusion is as and when required, or as and when the hemoglobin goal is dropped. Coagulopathy you can see, one due to the surgical loss, due to the ischemia reperfusion injury, and hemodilution, because these patients are chronically dehydrated. You will need to give them a lot of fluid. TEG guided transfusion of the blood products, but more often than not these patients are hypercoagulable, so that needs to be considered. More of you will end up using heparin or anticoagulation to these patients. Avoid excessive transfusion because you want to prevent the graft thrombosis, you want to keep the blood thin. So strictly you have to follow the hemoglobin maybe at around 7 that you can keep a target of, and anticipate significant electrolyte disturbances, hypernatremia, hyperkalemia due to the ischemia reperfusion injuries, potassium significant coming in from the bowel itself. As I told you that cross-clamping and slide clamping of the major vessels, especially when the aorta is side clamped, they need aorta to be very supple, so you have to keep the systemic pressures at around 70 for that period of 8 to 10 minutes. You will have to use significant vasodilators, NTG, propofol, beta blockers, labetalol, and at the same time, once they are done, you will have to slowly drift the pressures up so that the aortic sutures are not opened up immediately. And as a close communication with the surgeons during the clamping and unclamping of the major vessels is what required. Then comes the immunosuppression intraoperative. Generally ATG, what we use for kidney transplantation, is used along with the steroids, and a few institutes also prefer giving tacrolimus preoperatively. The most important stage of the surgery is reperfusion phase, as it is for kidney and liver transplantation. A significant hemodynamic changes can happen due to multiple reasons. ECG changes, typically due to hyperkalemia. We've seen significant PRS, including on-table cardiac arrest also during the bowel transplantation. The reasons for post-reperfusion syndrome are massive release of the inflammatory cytokines, free radicals, endotoxins, and there is significant capillary leak immediately after reperfusion into the bowel, and there is increase in the venous capacitance associated with due to the opening of the new mesenteric vessels or the bowel. As I told you, severe PRS can sometimes land up in cardiac arrest also. So before reperfusion, we need to significantly optimize the cardiovascular status, acid-base status, especially the potassium of these patients, and then allow the surgeons to unclamp the vessels. Post-operative management, generally these patients are extubated on table. Analgesia is through IV opioids intraoperatively as well as post-operatively. More often than not, they are on continuous IV PCA fentanyl for first 3 or 4 days, immunosuppression with tacrolimus, steroids, mycophenolate, and ATG as and when required. and monitoring of rejection is something what is very essential. That has to be done by surveillance biopsies or by routine endoscopies every weekly, and we have to take biopsy and then look for any early rejection or so. You have to continue with antibiotics and antifungals. Enteral feeds can be started early and volume can be increased depending on the Ng aspirate and the stoma output. Routine cultures are sent from all the lines as we see that there is a very thin line between the infection and the immunosuppression in these set of patients, as bowel is very full of all the bacteremic loads. So any over-suppression can land the patient in severe sepsis with immunosuppression. Now, what all complications do we anticipate? This is generally the acute rejection, which is seen by high output from the stoma. Patients will have other signs and symptoms of rejection. The biopsy remains the confirmatory test to diagnose whether there is rejection or no. Sometimes we've also used sentinel grafts. That means the free radial flap or the Achilles graft can also be implanted on the recipient for us to know whether the skin is getting rejected early or not. And if the skin is getting rejected, that means which indicates that the bowel is also getting rejected, which is called as sentinel grafts. That is also being practiced sometimes. And rejection, of course, is managed by steroid pulse doses and increasing the immunosuppression. Sometimes if there is a chronic rejection, evisceration, or that means the taking out bowel remains the only modality. I'll not go in these details. This is just one of our cases. Just to show you that there was a significant reperfusion on the second. You can see heart rate had significantly dropped to less than 20s. Last slide, intestinal transplant is an established treatment for irreversible intestinal failure with improved quality of life. Candidates require a detailed multidisciplinary evaluation at an intestinal transplant center. It is a complex operation with the potential for hemodynamic and metabolic instability, significant fluid shifts, major hemorrhage, and coagulopathy. Outcomes for the intestinal transplants are improving, but acute rejection and infection, these two are common post-operative complications. And what we see is in the Western countries, they have dedicated intestinal failure unit. I anticipate that in our country also, with increasing expertise and awareness, we also have intestinal failure units, and more awareness in our treating doctors who will take this intestinal failure to a different level. Thank you.
Thank you so much, sir. May I request Dr. Surekha Patil ma'am to felicitate Dr. Harshit, sir. May I request Dr. Rohan Chaudhary, sir, to please come on the dais and felicitate our chairpersons. Dr. Sonali Saraf, madam. Dr. Surekha Patil, madam. Dr. Amay Sonavne, sir. Can we have a group photo, please? Moving on for the next session, may I request our chairpersons to please come on the dais. Dr. Rohan Chaudhary, sir, Senior Consultant, Liver Transplant Anesthesia, Apollo Hospitals, Navi, Mumbai. Dr. Sangeeta Shetty, ma'am, Senior Consultant, Liver Transplant Anesthesia, Fortis Hospital, Mumbai. Dr. Anil Singh, sir, Senior Consultant, Liver Transplant Anesthesia, Max Nanavati Hospital, Mumbai. I request our speaker, Dr. Amay Panchwak, sir, to please come on the dais. Dr. Amay Panchwak, sir, is Consultant and Head Liver Transplant Anesthesia, HN Reliance Hospital. He is involved in the perioperative care of liver, kidney, pancreas, small bowel, hand, and multi-organ transplants over the last decade. And he has several publications in international and national journals. Requesting sir to start with the next topic.
Good morning, everyone, and thank you very much, Team Apollo and ACTA Mumbai, for. Do I have my slides? Yeah, okay. For inviting me to talk on this topic, which is. The slides are not moving here in my laptop. Moving there. No, but see, it's not moving here, but it's moving there. So, I'll be speaking on patient blood management in patients with end-stage liver disease and liver transplantation. So, I have no conflict of interest to declare, and I know that we are running short of time, so I'll just try to finish as quickly as possible, and we can have some questions if we need to discuss. So, what is PBM? PBM is just a fancy name for what we do every day. In the pre-op, intra-op and the post-op period, anything we do to optimize the hemostasis or minimize blood loss or reduce the blood transfusion, reduce the complications of transfusion. And this is all to improve the outcomes and reduce the mortality and the morbidity. So it is nothing but what we all do every day. And I'll be, so it's a very broad topic. I'll be speaking on 3 parts of it. So what is the status of coagulation in patients with end-stage liver disease? Second thing is, because we come across all these patients day in and day out, second thing is the utility and the need for viscoelastic testing in this setup, because now viscoelastic testing is available in all hospitals, but very underutilized outside of liver units. And recent advances, that is the use of factor concentrates and its utility in this setup. So firstly, the perception about patients with liver disease is that they are traditionally, we consider them to be auto-anticoagulated. They have, we have seen them bleeding spontaneously. They have raised INR, low platelets, and they bleed massively during surgeries. And usually we also prophylactically correct with them prior to any procedure or any surgery with FFP or platelets based on the standard lab test. And whenever they are bleeding, we also withhold the thromboprophylaxis for a majority of time. So our perception about these patients is they are like coagulopathic and auto-anticoagulated. But on the other side, we also see a lot of thrombotic events in these patients. That has been published since a long time. They have known to have portal vein thrombosis. They are known to have thrombosis everywhere else in the body, like deep vein thrombosis. And this perceived coagulopathy does not seem to protect them from all these thrombotic events. So what is the true status of coagulation in these patients? So nature is amazing, it rebalances everything. So if you look at primary hemostasis, what we see and we are scared of is they have thrombocytopenia. But on the other side, they have very high levels of von Willebrand factor, which increases the platelet aggregation, which is synthesized in the endothelium, and it is at very high levels. And if you see on the picture on the lower left side, the von Willebrand factor levels are very high, and they increase with the severity of disease. So in child C cirrhosis, you would see very high levels, and the increase in platelet aggregation will be much more. The second thing is liver also synthesizes one metalloprotease called as ADAMTS13, and the function of this is to cleave large multimers of von Willebrand factor. So we have very high levels of von Willebrand factor, plus we have large multimer, so there is a very big surface area for platelets to aggregate. And so this has been proven in studies that any platelet, be it normal or platelets patient from normal, platelets from normal patients or from cirrhotic patients, if they are put in cirrhotic plasma, you can see on the right side 2 panel that the aggregation is much more than in normal patients. So primary hemostasis is quite rebalanced. If you come to the coagulation pathways, we know the intrinsic pathway, the extrinsic pathway, they all converge to form a thrombin burst. And below that, there is substrate level so that the fibrin crosslinks to form fibrin clots. So the other concern is because all these factors are synthesized in the liver, we are always afraid that these patients will bleed a lot. But here also there is a lot of rebalance. So what we can see is low procoagulant fibers, factors, and low fibrinogen. That is all we know. But on the other side, it is rebalanced nicely by very high levels of factor VIII, which is a very potent driver of thrombin generation. If you can see again in the left lower panel, in child C cirrhosis, as the severity of disease increases, the factor VIII levels increase, and so it rebalances all the procoagulant factors which are low. The other thing which we tend to forget is the liver also synthesizes anticoagulant proteins. So they are also low in patients with end-stage liver disease. And like protein C, protein S, and antithrombin. So lower right side 2 panels, you can see that even protein C and antithrombin, the levels are very low, and they are lower with increasing severity of disease. So with increasing severity of disease, there is a large disparity in favor of procoagulant proteins. So the factor VIII levels will be quite high, and the antithrombin and protein C levels will be very low. So with increasing severity of disease, the patient will be more and more procoagulant. So that is why they get thrombos most of the times. And this has been proven time and again in all the tests. This is an article from 2005. Long back we knew that thrombin generation is not a problem because if you can see in the blue rectangles that the cirrhotics and the controls, they generated equivalent, or in fact the cirrhotics have generated more thrombin than the controls. So coming to the summary of rebalance, primary hemostasis is reasonably rebalanced unless the platelet counts are too low. So we won't need much of platelets. The enzymatic pathways, they are also rebalanced. Rebalance is very robust, so we usually won't need FFPs in these patients. And what is not rebalanced most of the times is the fibrinogen. So the requirement of products logically in these patients is like fibrinogen will be the highest, then platelets, and then FFPs. But in practice, what we do is we transfuse them exactly in the opposite way. So FFPs are given first, then platelets, and then fibrinogen. So then why do these patients bleed? So on the left side, you can see blood on face of the surgeon. That is hydrostatic bleeding, arterial bleed, or maybe hydrostatic venous bleed from anywhere. And when you see blood at the foot of the surgeon, that is mostly coagulopathic bleed. So we know now that these patients are not coagulopathic. It's not coagulopathic bleed. So they bleed most likely because of portal hypertension. And this has been proven in many studies that they rarely bleed outside of portal hypertension, and the standard lab test based hemostatic therapy will be overestimating the risk, and we would give wrong hemostatic therapy to these patients. So we need to approach these patients more rationally than knowing the physiology. So first thing I told you is FFP is not required because the thrombin generation is very nicely rebalanced. And second thing is, especially in patients with end-stage liver disease, you give 10 to 15 mils of FFP, that is around 600 to 900 for a 60-kilo patient. Volume load always will increase the portal hypertension, which is the primary cause of bleeding in these patients. So that has to be, we have to refrain from jumping and just correcting the INR giving FFPs. And in the setting of liver transplantation, it also increases the graft congestion and causes graft dysfunction. The third thing is, so FFPs are not required. They don't help much, and they may make things worse by increasing the portal pressure. So three things we should not use FFPs. You can see in this study very nicely that they gave FFP for correction of INR and looked at the thrombin generation in these patients. So in cirrhotics, the increase in thrombin generation was very low, and in fact in 1/3 of the patients the thrombin generation decreased because of dilution. So benefit of FFP transfusion in cirrhosis was just too modest, and it's not recommended to justify the use indiscriminately, but only when required. So problem with hemostatic therapy based on standard lab tests is we can see only a part of the picture. Like these blindfolded men who are trying to find out how the elephant looks like, we only know a part of the picture. And what we usually miss is low fibrinogen levels, which we can always do, but then other things which we cannot see or cannot measure is the high von Willebrand factor, factor 8 levels, low protein CS, low antithrombin levels, and other factors like the interaction between the cellular components and the plasma. So, and this study, of course, INR dominated the coagulation monitoring, which happens everywhere. But if you have to go by standard lab test, it is better that we bank upon fibrinogen levels and platelet count, which are better predictors of bleeding rather than the INR. Use of viscoelastic testing is essential. We can't bank upon the standard lab tests for managing these patients. Like you can see in this study, almost 77% of the patients were normal in coagulation by viscoelastic testing, whereas by standard testing, only 35%, 34.2 rather, were said to have normal coagulation. So as a thumb rule, only 1/3 of these patients are hypocoagulable. 1/3 will have normal coagulation, and 1/3 are usually hypercoagulable. So viscoelastic testing is the way forward. It's available everywhere. It gives a very robust assessment of coagulation status in general and especially in patients with end-stage liver disease. So utility wise, it gives a whole blood holistic view of all the components of blood. We have seen that platelet numbers are do not matter. The platelet function, which we can decipher by using the viscoelastic test. You won't come to know anything about fibrinolysis unless you use viscoelastic testing. Sometimes patients with end-stage liver disease have a lot of heparin-like effect, so which we can come to know only on viscoelastic testing. Clot firmness, which is a composite of platelet and fibrinogen function, we can easily come to know. We can precisely guide the hemostatic therapy, only give what is required and how much is required. We can monitor response to our treatment. It is point of care and very quick turnaround time. So we can reduce transfusion rates, mortality and morbidity. So we have coming to point of care testing, we have two major systems. First is the TEG, which has it has a graph which shows the R time, which is the enzymatic component. So if it is deranged, then we give FFPs, which I told you most of the times is not a problem. Then we have alpha angle, which is now we use functional fibrinogen levels to know the fibrinogen levels, and we can precisely guide the hemostatic therapy. And the MA is a composite of fibrinogen and platelets. So if the fibrinogen component is removed, we come to know how much is the platelet contribution to the MA, and we can guide and transfuse platelets. Importantly, we also come to know about fibrinolysis and guide therapy for the same. And the second thing, second important system available to us is the ROTEM system, which is more robust, very robust protocols. So we can now, based on the graphs are similar, but based on the amplitude of different variables at 5 minutes, we can come to know what hemostatic therapy we need to give. So because time is essence in bleeding, and earlier the better, we need to correct. So at 5 minutes, we can come to know what all hemostatic therapy needs to be given. So this is the ROTEM algorithm. I will not go in the detail for want of time, but I just want you to appreciate the sequence in which the correction is done very logically as per what we physiologically discussed. So first thing is look at the hyperfibrinolysis, give tranexamic acid. Second, optimize the clot firmness. First, give fibrinogen, which is not compensated very well. Then if the platelets are very low, we need to give platelets, and FFP, which we most of the times transfuse as the first agent, is to be given last. So that is what is the sequence, very important. And we have such protocols in cardiac surgery, in trauma. The sequence of correction remains the same. So we should be very rational about using products and use viscoelastic testing wherever possible. The new thing in this is use of coagulation factor concentrates, because we have seen that in transplants, in general, in any surgery or in end-stage liver disease, there is significant risk of blood transfusion. We all know the transfusion reactions, and of course, volume is a problem because it will increase the portal hypertension in patients with ESLD. Patients with ESLD have some special situations, like they are sometimes fluid overloaded, they have poor LV, you can't give volume, you can't give FFPs or any other products. Sometimes they may have hypoxemia, very commonly due to hepatopulmonary syndrome, and then you don't want them to have any acute lung injury, anything which would worsen the oxygenation further. Many of the patients will have hyponatremia to the tune of 120, 125. So if you transfuse products with a sodium, with allogenic products, they will have a normal sodium. So the sodium levels tend to rise very abruptly, and then there is risk of osmotic demyelination syndromes. And especially cryo cannot be given in patients who are very hemodynamically unstable, because it causes severe vasodilation and hypotension. So what all factor concentrates are available? First is recombinant factor 7. We used to use it like 10 years back as a last ditch stand in bleeding to optimize thrombin generation. Dose is like 90 mics per kilo. but it contains very supraphysiological concentrations of factor 7. So it is known to cause thrombotic, arterial and venous thrombotic complications, so no longer recommended in the context of liver surgery. We are moving now to more physiological factor concentrates. This is what we published in IJ last year. We have PCCs, which are replacement for FFPs. So we have 3-factor PCCs, which have a higher rate of thrombosis and lower rate of correction of the coagulopathy, which is replaced by 4-factor PCC, which are more physiological. They correct the coagulopathy much better, and they have anticoagulants as well, so the thrombotic events are lesser. Very easy to store, easy to reconstitute. You can keep it in the OT, just very small volume, 50 mils, which is like 1/10 of what you require in allogenic products. And you have fibrinogen concentrate likewise, which can be used depending on the viscoelastic testing. And there were always concerns of thrombotic events, but then they are quite safe, recommended by many expert consensus guidelines that they should be administered in patients with ESLD, and best to guide them with the use of viscoelastic testing. Even post-thrombin complex concentrates, very safe, no risk of thromboembolism. This is a study from Delhi, which they found that it reduced the PRBC transfusion, the hemorrhagic complications, and there were no thrombotic events over 2-year use. Similarly, in fibrinogen concentrate, they compared cryoprecipitate to the fibrinogen concentrate and found that there were no major thromboembolic events compared to cryoprecipitate in this subgroup of patients. So advantages: they are virally inactivated cryoprecipitate is withdrawn from many countries now because of risk of viral transmission. Very low volume, no antibodies, so no risk of lung injury, no immunomodulation. No blood group specificity required, so you can use in any patient. Rapid administration, you can just reconstitute in 5 minutes. No thawing required as for allogenic blood products. Very easy to store. You can transport it or carry it with you anywhere if you are going out for transplant or any other surgery, and no risk of hypotension as with cryoprecipitate. Disadvantages are they are quite costly at present. There are still concerns in some studies about thromboembolic complications. And most of the data is retrospective, no RCTs, so that is what is underway, and no very robust guidelines in end-stage liver disease. So take-home message, I would say that coagulation in end-stage liver disease is very rebalanced, and standard lab tests, especially INR, does not predict the risk of bleeding. Please go by platelet counts or the fibrinogen levels. FFP is the worst thing you can do to a patient. It should not be given as a knee-jerk reaction to raised INR. Viscoelastic test-based management is a very physiological approach, and factor concentrates are very promising, at least in a select subgroup of patients which we are using at present, but we are looking at many more guidelines to come. So thank you very much for your kind attention, and I'll be happy to take any questions.
Thank you, Dr. Amey. I have a question for you. What is your protocol for ABI incompatible transplants, and how is it different from the normal transplants?
Okay, so ABI incompatible, you don't need to give, you should refrain from giving products which have antibodies similar to what the graft blood group is. So there is a whole chart of what needs to be transfused. But especially with factor concentrates now, we don't need to worry about all these things. So factor concentrates are a better way. If you want to give plasma, you don't need to, if the patient has some rare blood group, you don't need to worry about antibodies in the plasma or what to give, what not to give. We are more moving towards factor concentrates rather than allogenic blood for ABI especially.
I have a question for you, Amey. So you have both cryo and say fibrinogen concentrate. So when do you use the concentrate, or do you start with cryo and then how do you decide that?
So most of the times we have shifted totally, entirely to not using cryoprecipitate versus and towards fibrinogen concentrate. The simple reason is our protocols are moving from A10, like we moving from A10 protocols to A5 protocols. So we need to know whatever we came to know in 10 minutes, we need to know in 5 minutes. And then if I know something in 5 minutes that I need to do this thing, and you have to wait for 45 minutes for the cryo to thaw. So that is something we lose time, we get in the vicious cycle of coagulopathy and bleeding. So we have totally moved towards fibrinogen concentrates. They are not very costly. You can justify the cost based on the better outcomes or avoidance of complications by their use. PCC we rarely use because these are very costly, and as I told, we don't need FFP, so there is no real indication for PCCs as well in this subgroup of patients.
Hi, Amir.
Hi, Anil.
Good to see you.
Yeah.
So, as always, informative, elaborate, everything covered. I would like to know, I think you've used both TEG and ROTEM both.
We have shifted to ROTEM altogether.
Yeah, but you have used TEG.
Lot, yes.
So you think ROTEM is better than TEG?
100%. No
What
doubt
are the
about it.
major, can you just tell what are the major differences?
So, first thing is the protocols. If you see the protocols, you can, for every millimeter rise in fibrogen or clot firmness, how much fibrogen or products we need to give, it's very protocolized and very precisely you can tailor giving products. Second thing, you can carry it everywhere. There is no motion artifact. Many times you see you keep a tag and there is some motion. The whole entire graph is lost. It is not motion with the machine is not a problem. The tests in ROTEM are much better than TEG. Like the functional fibrinogen, it overestimates the fibrinogen. So you would always, the TEG would suggest you to give more platelets, suggesting that the fibrinogen is higher, and that is because they use a platelet inhibitor. So the platelet inhibitor used in TEG does not inhibit all of the platelets. So that comes as a fibrinogen contribution to the clot. So you end up transfusing more platelets and more FFP. The protocol also for TEG, if you see, it is correction from left to right. So first you correct the R time. So you will end up transfusing more FFPs as well. Whereas with ROTEM, you will, only cryoprecipitate or fibrinogen concentrate would be sufficient. So definitely the tests also, they are variable. Many tests which are not there in TEG, like for example, the functional fibrinogen doesn't have a heparinase. So if your patient is heparinized, you won't come to know the contribution of fibrinogen or heparin. No. In TEG, no, heparinase TEG, I'm talking about functional fibrinogen. So if functional fibrinogen is a test to know the fibrin contribution to the clot firmness. If your patient is heparinized or you have a heparin-like effect, which happens in all patients after reperfusion, and you keep a functional fibrinogen, you won't know the low MA of the functional fibrinogen is because of the HLE or because of low fibrinogen. Whereas in ROTEM, the heparin, heparin is already there in the in the FIPTEM. So it precisely will tell you where your fibrinogen is. And the correlation of fibrinogen levels with FIPTEM is precise. So around 1 millimeter of FIPTEM amplitude is equivalent to around 15 milligrams %. We have done in lab tests also, so it precisely correlates.
You're absolutely right. The functional fibrinogen can be directly done with the ROTEM. But like you say, when we used to put in Medanta, you remember, we used to put a normal TEG and a heparinase TEG.
Yeah.
So that function of you saying that...
That is there. Heptem is there. I'm not...
Whenever you put a TEG, you should always put a normal TEG and a
absolutely.
heparinase TEG.
Absolutely.
Post-reperfusion.
Yeah.
So that is a different point. And regarding, so you said about ROTEM, right? Protocols, have they been validated? The protocols you're talking about, the TEG protocols and the ROTEM, are they both validated or none of them is validated?
So ROTEM protocols are more validated than TEG protocols. TEG protocols are just haywire. If you look at them, they are not physiological. You won't know. They are quite empirical. If you say, so if our time is prolonged to say 12 minutes, how much FFP would you give? it is very empirical. Someone would give 4, someone would give 2, I would give 1. There are different protocols. So ROTEM protocols are very precise. You can precisely guide how much of PCC if you're using to give, or how much of FFPs to use, how much milligrams of fibrinogen concentrate to use. So it is very refined. It's quite validated also.
FFP, I think I'll just take a call from the audience. FFP, I think we are clear, 10 to 15 ml per kg for any correction, correct? There is no confusion about that. There is nothing we can see in that FFP, so it is definitely clear, 10 to 15 ml per kg. Fibrinogen, yes, definitely. You can say that fibrinogen, exactly what I asked.
So Ameya, do you, in your ROTEM, do you do all the 4? Do you do a
No.
FEPTEM, EXTEM, HEPTEM?
We do only
or you
EXTEM and
just do
FIPTEM.
EXTEM and FIPTEM?
Only EXTEM and
So
15.
that's the normal
Unless
practice.
you have some
So when do
suspicion.
you decide to do the HEPTEM? Because like you said, post-reperfusion, there can always be some
Post-reperfusion.
heparinoids released.
Post-reperfusion.
So you would do a HEPTEM at that point?
Once in a while, but we know.
You
We know on the
normally don't,
intem
yeah.
itself that it
Exactly.
is. So if you look at the intem extem CT difference, you would come to know that the intem is because of the HLE and the other thing. So if the extem intem if the extem CT is normal, we don't do a heptem.
Yeah. So you don't have the sigma version, you are doing the...
You know, not yet.
Open to the audience, please. Any questions? No questions? Amya has explained everything. Done. Excellent, Amya. Done?
Thank you very much.
Thank you so much, sir, for such an interactive session. May I request Dr. Anil Singh, sir, to felicitate Amey, sir. Just wait for 1 minute. May I request Dr. Uday Gandhi, sir, to come on the dais and felicitate our chairpersons, please? Dr. Anil Singh, sir. Dr. Sangeeta Shetty, ma'am. Dr. Rohan Chaudhary, sir. So we'll just have a group photo and thank you so much, everyone. Anyone has any question for any of our 3 speakers or chairpersons? No? There is one question from Dr. Amey Sonavne, sir. He had to leave. It is directed to Harshit, sir. So regarding many patients who need intestinal transplants have a prothrombotic state, especially in Crohn's disease and SMA thrombosis. How do you manage coagulopathy intra-op in such patients?
Yeah, so I think, as you said, Crohn's disease and otherwise also there are short bowel syndrome, thrombophilia. More often than not, we start with heparin immediately after reperfusion. Initial dose is not too high. We just start at 200 units per hour. Which is close to 2 to 3 units per kg per hour, and then slowly escalate in the post-operative period once the surgical team is very sure about the hemostasis and all. So more often than not, we have to rely on heparin, as well as we give first dose of intraoperatively ecosprin also. Yeah.
Yes, yes. Do we have a mic? Yeah.
Ma'am, 6 hours is something which is acceptable. 4 hours is best. Lesser the better. But more often than not, almost all of our bowels which had come from Gujarat. So for us, it was between 4 to 6 hours. But 6 hours is fairly well acceptable. Same heparin immediate. Almost everyone, because we do ROTEM also, and majority of the cases are thrombophilic patients. We have to start with heparin. We ensure with ROTEM first that this is hypercoagulable, and then we do it.
What about the lines? Central line, yes. Arterial line, do you take?
Yes, arterial line from the beginning for all the no, radial. Because as I told you that it is going to require aortic clamping or cross clamping, you need to have systemic pressures very low. There is significant hemodynamic shifting. So arterial line, more often than not, we get radial, if not brachial. We generally don't use femoral. And venous access remains a concern. So what we do is a central line and a central venous access, either using sheath, or we have a device which is 5 French, which is a 5 lumen central line, which has 4 lumen central line, typical what we use, and a 5th one is a wide bore, which is 12 gauge or 7 French sheath sort of. So in one go, you can have all the accesses, which is by Vigon company, especially for bowel where there is, lot many times the central lines are cannulated. So we don't use 2 there, we just use 1. Infection and rejection. Infection, more often than not, we see CRP and everything going high. We have to almost escalate the antibiotics. And twice or thrice we've had rejections also, to an extent that we had to eviscerate the bowel also. Refractory rejections. So sentinel graft is something for us to know that the bowel is getting rejected or not, objectively, you have to do surveillance endoscopies, take the biopsy from the bowel, and then you can be sure. So surveillance graft is something that from the donor, you take a graft, either the abdominal graft or a free radial graft, which has the vascular access, and then you put it on the recipient, either on the abdomen, hand, or at the site of tendo Achilles. So if you see that skin is getting rejected, or there are any signs of rejection, either you can take a biopsy from that skin, or you can straight away take the signs of rejection on that skin that the bowel is also going to get rejected. So that acts as an early marker, or that can predict that your patient is going into rejection. So that is, we've used twice, and we've used biopsies also. One we used in a kid who was for living donor bowel transplant. And there the anterolateral graft from the anterolateral thigh was taken from the donor. I think I've answered.
Any more questions? Okay, thank you so much, sir. So we'll move on to the next session. Thanks a lot.
I request Garima to felicitate our moderator Pinky for the session.
Hello, good morning all. I'm Dr. Sheetal Shinde. I'm Senior Consultant in Department of Anesthesia, Apollo Hospitals, Navi, Mumbai. Now, after listening to all these informative lectures, I'm sure you all are full of knowledge. So let that information come out now. We have arranged a short and simple quiz for you. And I request all of you to participate in this quiz and make it interactive. So there are some rules. I'll read the question for you here. I'll give you 30 seconds to read and think. After that, whoever raised the hand first will get the chance to answer, and who gives the correct answer will get a gift. Okay, ready? Which of the following structure is not a part of portal triad in liver? Option A, portal vein. B, hepatic vein. C, hepatic. Sorry. Which of the following structure is a part of portal triad in liver? Sorry, my mistake. A, portal. Sorry. Which of the following structure is not a part of portal triad? Portal vein. Hepatic vein, hepatic artery, and bile duct. Sorry. Oh God.
Hepatic vein.
Yes, dear. Plasma half-time of which of the following drug is prolonged in patient with end-stage liver disease? Diazepam, pancuronium, alfentanil, all. Sorry. Next. Who wants to try?
All are prolonged.
All of the above, yes. Liver produces all of the following except von Willebrand factor, albumin, fibrin, cholesterol. Yes. Problems that may ensure with the post-reperfusion syndrome include all of the following except hypokalemia, air embolism, increase in pulmonary vascular resistance, release of vasoactive substances into the central circulation.
Hypokalemia?
Yes. It's hyperkalemia which occurs. Model of end-stage liver disease includes serum albumin, serum creatinine, transaminase, alkaline phosphatase. Which answer?
Serum albumin.
Sure? Sure? Yes. No, albumin is not included in MELD. During neohepatic stage, the anesthetic concern include all of the following except hypotension, decrease in systemic vascular resistance, decrease in preload, hyperkalemia.
Decrease in preload?
Yes. It's increase in preload. True regarding drugs with high hepatic clearance. Clearance decreases with the high hepatic blood flow. Clearance decreases with the low hepatic blood flow. Clearance does not change with high hepatic blood flow. All.
Clearance decreases with high hepatic blood flow.
So I think its clearance decreases with the low hepatic blood flow, right? What is the most common indication for liver transplant in children? Primary sclerosing cholangitis, biliary atresia, Indian childhood cirrhosis, inborn error of metabolism. Yes, biliary atresia. Which of the following is not a diagnostic criteria for portopulmonary hypertension? Clinical portal hypertension with or without significant chronic liver disease. Mean pulmonary artery pressure more than 25 mm of Hg at rest. Mean pulmonary capillary wedge pressure more than 15 mm of mercury. Pulmonary vascular resistance more than 240 dynes per second per centimeter raised to power minus 5. Yes, it should be less than 15. All are contraindication for intestinal transplantation except active infection, major psychiatric illness or non-compliant patient behavior, radiation-induced bowel injury, any comorbidity that would restrict life expectancy to less than 5 years. Anju? It's C, radiation-induced bowel injury. Okay, I'm done with my questions. Thank you.
May I request Dr. Rochana Bakshi ma'am to felicitate Dr. Sheetal Shinde. This is the time now to officially welcome you all on this remarkable occasion. So let us begin the inauguration ceremony. We are waiting for our DMS, sir. We'll just wait for 5 more minutes.
We had a wonderful liver session. I congratulate and thanks all my colleagues who have come for the liver session. We have got our Actor Secretary Dr. Vishwas Sati here. Thank you, sir, for coming. And we will be having an inauguration in 10 minutes. If you want, you can have a quick tea break and come. Also, you can remain seated or bring the tea inside also. Wait for 5 minutes, please.
So on an average, the median wait time is around 2.3 years, in which the patient is thoroughly evaluated, medically optimized. Thus, medical optimization is a priority on transplantation list. Coming on to chronic renal failure. So chronic renal failure and end-stage renal disease are functional diagnoses in which there is a progressive decrease in the glomerular filtration rate. So CRF occurs when the glomerular filtration rate is reduced to 10% of the normal function, that is when it drops below 29 ml per minute per 1.72 square meter of body surface area, and we term as end-stage renal disease when the GFR falls below 15 ml per minute. Now, what are the major causes of chronic renal failure? Diabetes mellitus topping the list, almost amounting to about 31%, followed by chronic glomerulonephritis, cystic kidney diseases like polycystic kidney. Hypertension again is a major cause leading to chronic renal failure. Interstitial nephritis, obstructive uropathy, lupus nephritis, and immunodeficient conditions are other reasons leading to chronic renal failure. So this is the classification of chronic kidney disease, in which we have 5 stages. Stage 1, in which the renal function is fairly maintained and the GFR is also normal. Stage 2, in which there is a mild impairment of the renal function and the GFR drops to 60 to 89 ml per minute. Stage 4, which we term as chronic renal failure, in which there is a severe impairment of the renal function and the GFR falls below 29 ml per minute. Stage 5, which we term as end-stage renal disease, in which the GFR falls below 15 ml per minute. Now coming on to the pathophysiological changes in chronic renal failure, as we know that renal failure affects all the systems of the body, majorly being the cardiovascular system. So in cardiovascular system, 25% patients of CKD have coronary artery disease, and therefore ischemic heart disease is the leading cause of morbidity and mortality in these patients. Almost 80% of these patients have hypertension, the main reasons being sodium water retention and altered renin-angiotensin-aldosterone system. Also, there is accelerated atherosclerosis because of decreased triglyceride clearance and also because of reduced lipolysis. This leads to coronary artery disease. Because of chronic hypertension and fluid overload, there is left ventricular hypertrophy and the patient can land up in left ventricular failure in the long term. Also, there is increased incidence of metastatic calcific deposits in the valves, and therefore these patients can present up with stenotic valvular lesions. Uremic pericarditis, which was very common initially, but nowadays with the advent of newer medical therapy and dialysis, it is not very commonly seen. Thus, various studies have shown that lowering BP helps in slowing the disease progression in CKD patients and also helps in reducing the cardiovascular morbidity. Individualized decisions for the pharmacological treatment to target the BP is very important. SPRINT study has reported a 25% reduction in the cardiovascular events if the target BP is kept around 120 or 130 by 90 millimeters of mercury. Now coming on to the pharmacotherapy of hypertension in patients with CKD. So it again depends upon whether the patient has proteinuria or there is no proteinuria. So usually the first line of drug is ACE inhibitors and the ARBs with or without calcium channel blockers and diuretics. If at all the patient is not controlled with this therapy, then alpha blockers and beta blockers are the next line of treatment. Thus, a thorough history and a functional status or knowing the metabolic equivalent or exercise tolerance of the patient helps in assessing the cardiovascular health of the patient. Physical examination has to be done thoroughly to identify any active cardiac condition like unstable coronary syndrome, severe valvular disease, decompensated heart disease, arrhythmias, etc. So the patient is subjected to various non-invasive cardiac tests like 2D echo, dobutamine stress test, myocardial perfusion test. If at all the patient is symptomatic, like if the patient has chest pain or has anginal symptoms or a low EF, then the patient might be subjected to invasive tests like coronary angiography. Thus, optimizing the cardiovascular health before transplantation becomes a priority. In electrolyte abnormalities, the commonest seen are hyponatremia, hypocalcemia, hyperkalemia, hyperchloremia, hypermagnesemia. Hypermagnesemia can lead to muscle weakness and can potentiate the non-depolarizing muscle relaxant action. Hyperkalemia is the most concerning electrolyte imbalance that we see, and these patients often have chronic hyperkalemia and they often come with potassium levels of as high as 6 milliequivalents per liter. ECG changes may not be present until the higher values are reached. The mainstay of treatment being soda bicarb, calcium gluconate, glucose insulin drip, and beta agonist to get the potassium levels less than 5.5 milliequivalents per liter. In case of resistant hyperkalemia, dialysis is the only option. Thus, fresh electrolytes done prior to surgery post-dialysis becomes important. In calcium and phosphate metabolism, because of impaired GFR, there is decreased phosphate excretion that leads to hyperphosphatemia. Also, there is decreased activation of vitamin D that leads to impaired calcium absorption from the gut, leading to hypocalcemia. And this hypocalcemia leads to increased PTH hormone release, leading to bone demineralization, leading to osteomalacia and osteitis fibrosa. Thus, these patients have hypocalcemia and hyperphosphatemia, and this can be easily treated with oral calcitrol, and even calcium carbonate can be used, which acts as a calcium supplement as well as a phosphate binder. Metabolic acidosis, again these patients present with chronic acidosis because of inability to excrete acid load. Initially it is a non-anion gap acidosis, but later on due to retained phosphates and sulfates, these patients develop high anion gap acidosis. Again, this can be corrected by hemodialysis. Coming on to hematological abnormalities, anemia is the most commonest feature that is seen. Anemia is normocytic, normochromic, and the main reasons for it being the decreased synthesis of erythropoietin, there is bone marrow suppression or depression, there is decreased survival of RBCs that leads to anemia. So the treatment would be supplementation with iron and folic acid. Even synthetic injectable erythropoietin is used, the main aim being getting the hemoglobin rise by 1 to 2 gram per deciliter per month, or getting the hematocrit to around 36%. So these patients often tolerate anemia they tolerate anemia in a good way because of the compensatory mechanisms which come into play. So because of anemia, there is increased cardiac output, there is decreased blood viscosity, increased 2,3 DPG levels that helps in better tissue oxygenation. Thus, the transfusion criteria or the transfusion trigger for these patients is often low, and the patient is not transfused unless and until the patient is hemodynamically unstable or the HB falls below 7 or 8 grams per deciliter. Also, another reason for avoiding transfusion is it can lead to graft rejection due to allosensitization. There can be hyperkalemia, cell lysis, and overload. In coagulopathy, so usually these patients might have normal platelet count, but the functionality of the platelets is affected. Thus, the patient has, the platelets have decreased adhesiveness and aggregation. Also, there is inadequate release of endothelial von Willebrand factor and factor VIII complex. And this is the reason why these patients have a greater tendency of bleeding. This can be again corrected by dialysis, giving cryoprecipitates and desmopressin. In pulmonary abnormalities, end-stage renal disease is very commonly present with a very high pulmonary pressure. So there is pulmonary hypertension. The main reasons behind being high cardiac output, even AV fistula with a high flow can lead to increased PA pressures and anemia. Because of chronic fluid overload, there is pulmonary congestion, hypoxemia, and hypercarbia in the long run. Pleural effusion is often a feature seen in these patients because of impaired fluid clearance and increased vascular permeability. There is impaired immunity, which leads to atelectasis and infection. In patients with chronic metabolic acidosis, there can be hyperventilation. So all these conditions can be treated to some extent by diuretics and dialysis preoperatively. If the pulmonary pressures are more than 35 or 40 millimeters of Hg, they are associated with a higher morbidity and mortality. So often patients with pressures of more than 45 millimeters of Hg might be started on vasodilator therapy. Also, it is seen that after 1 year of successful renal transplant, these PA pressures do come down to normal levels. Also, these patients, it is preferable that they receive grafts from living donors as compared to from cadaveric donors. In gastrointestinal system, nausea, vomiting, anorexia, hiccups due to uremia are the common symptoms. There is delayed gastric emptying and therefore increased risk of regurgitation and aspiration. In chronic diabetes mellitus, the patient might be having autonomic neuropathy. So preoperative treatment with a H2 blocker and metoclopramide is recommended. In central nervous system, the main things are the peripheral and the autonomic neuropathy, which leads to delayed gastric emptying, increased risk of aspiration, postural hypotension, and silent myocardial ischemia. It has been seen that both dialysis and renal transplant can help in improving the neuropathy. Immune system, there is inhibition of the cell-mediated immunity and humoral defense mechanisms, and therefore these patients are more prone for surgical infections at the catheter site and at the AV fistula site. Also, the wound healing is poor in these patients, and therefore strict aseptic precautions, especially while handling, while taking an IV line or handling the AV fistula, becomes very important. Coming on to the contraindications for recipients posted for renal transplant. So active infection, untreated malignancy, if the predicted patient survival is less than 5 years, if the risk of transplant, the graft loss is more than 50% at the end of 1 year, and if the patient is not able to comply with the immunosuppression post-transplant, these are few of the absolute contraindications for renal recipients. Coming on to the donor indications and contraindications. So the absolute contraindications being age less than 18 years of age, if the patient is not mentally sound to give a valid informed consent, if the patient has uncontrolled hypertension, diabetes with end-stage renal disease, with end organ damage, if the BMI is more than 35, and if there is active malignancy, these are few of the absolute contraindications for renal donors. So what are the goals of optimization? So main being optimizing the blood pressure and fluid balance becomes very important. Correcting underlying acidosis and hyperkalemia is important. So one has to identify all reversible causes like anemia, blood pressure, uncontrolled sugars in diabetes mellitus, thyroid, etc. Drugs excreted by the kidney should be used cautiously with dose adjustment. All nephrotoxic drugs have to be avoided. Incorporating ERAS protocol, again this is very important, especially in renal donors, wherein we have started minimally invasive surgery. So ERAS protocol can definitely be implemented for a better patient outcome. Dialysis, which becomes very important prior to surgery, and thus there's a multidisciplinary approach between the nephrologist, the anesthesiologist, the surgeon, and the intensivist, which helps in reducing the perioperative morbidity and mortality of the patient. Evaluation of potential living donors, so detailed medical assessment becomes important. Legal clearance or approval from the state and hospital authorization committee is important. Psychological assessment of the donor becomes very important, just to confirm that the patient is not being forced for surgery. Donor must be fit for surgery. There has to be no disease state that increases the risk of poor outcome either for the donor or for the recipient. Extremes of age is not a contraindication, though patients less than 18 years of age are absolute contraindication. But the biological age is more important than the chronological age, which means that even a 70-year-old patient with no comorbidities, who is otherwise fit, with all investigations being normal, can be a potential living donor. Thus, the patients are usually ASA 1, ASA grade 2 patients. Full preoperative assessment, including the CBC, the coagulation profile, the viral markers, LFTs, RFTs, the lipid profile, urine routine microscopy is done. Apart from these blood investigations, the patient has to undergo ABO, blood grouping, tissue typing, and leukocyte cross-match, which is mandatory before transplantation. If a donor is more than 20 years of age or has comorbidities, then 2D echo and stress test becomes mandatory. Systemic examinations are done in order to rule out any sort of infection in the patient. There are donors who are classified as complicated. So these are the ones who are elderly donors who have comorbidities but which is under control, obesity with BMI of more than 30, those who refuse blood products, and those who have certain vascular abnormalities which can make the surgery more challenging or demanding. There are few other tests that we do in renal donors, like which comes under renal protocol. So we do a DTPA scanning to know the renal functioning and the GFR of the patient. CT renal angiography to look for the vasculature of both the kidneys, which becomes very important from the surgical perspective. Helical CT scan to rule out cysts or tumors, and IV pylography to look for the structure of the kidney and the ureter. Now, coming on to the recipients, history taking becomes very important in these recipients. So basically, the cause of renal failure and the duration of surgery will help you in giving the chronicity of the disease. Secondly, the frequency of dialysis, that is how frequently the patient is getting dialyzed, will give you the severity of the condition, and also last dialysis when it was done prior to surgery. The daily urine output and fluid restrictions, if at all given by the nephrologist, has to be taken into account. Exercise tolerant, as already discussed, MET becomes very important to assess the cardiovascular health of the patient. Various medications have to be noted down. Blood pressure in sitting and standing position to rule out autonomic neuropathy. In systemic examination, there can be flow murmur in case of anemia, pericardial rub, if at all there is pericarditis, crepitations if the patient is in overload, and sacral or ankle edema if the patient has a right ventricular failure. In investigations, all the basic blood investigations, apart from this, the renal function test, the trend will help in giving you the progression of the disease. Creatinine clearance is important to calculate the doses. ECG, 2D echo, angiography if required, chest X-ray, CT chest to rule out pleural effusion pulmonary edema, ABG to find out any underlying acidosis, and LFTs. Now again, dialysis, as it's very important preoperatively, so usually an AV fistula is made for the long-term vascular access for hemodialysis, the common sites being radiocephalic and brachiocephalic. The maturation time is around 6 weeks. So basically, AV fistula is an arterialized venous channel which helps in increasing the diameter of the vein and for a higher blood flow. The arm which has AV fistula should always be marked, padded and wrapped. BP cuffs, venous cannulation and arterial lines have to be avoided on that arm. Most of the patients undergo hemodialysis, and that helps in optimizing the patient before surgery. So the ideal time is 12 to 24 hours prior to surgery. In case of emergencies, like in case of cadaveric transplants, hemodialysis can be done 4 to 6 hours prior to surgery, and heparin-free dialysis is done. Thus, dialysis becomes important to maintain the overall volumic status of the patient, to maintain the potassium levels and the acid-base status. Thus, preoperative dialysis helps in reducing the morbidity and mortality, and also helps in preventing the delayed graft function. Coming on to ABO incompatibility, as ABO incompatible transplants are on rise, so the main treatment is to reduce the antibodies in the recipients that can attack the donor kidney. So these patients undergo various tests in which the IgG, IgM titers of the patients are noted, and depending upon the titer, various treatment modalities are given like plasmapheresis, immunoadsorption, etc. If the plasma titer is very high, if the IgG and IgM titers are very high, then rituximab, which is an anticlonal antibody, is given as a single dose 2 weeks prior to surgery. And the titers are monitored, and when the titer comes down to 1:8 to 1:16, that window period, the renal transplant is planned. Tacrolimus is a immunosuppressant drug which is usually started a week prior to surgery, especially if the patient is ABO incompatible. Otherwise, it is started 2 to 3 days prior to surgery. Thus, the main aim of immunosuppression is to prevent graft rejection. It forms a vital part in the management of renal transplant patients. The immunosuppressive regimens differ from center to center, and the drugs which are used, it depends upon whether they are used for induction, for maintenance, what is the etiology of the disease, the graft condition, and whether the patient is compatible or incompatible. So there are various drugs which are used. Steroids still are the mainstay treatment in ABO incompatible patients. Calcineurin inhibitors, target of rapamycin inhibitors, polyclonal antibodies like anti-lymphocyte globulin, monoclonal antibodies like basiliximab, and purine synthesis inhibitors like azathioprine. So there are various therapies. So induction therapy is done just prior to surgery, and the main aim of induction therapy is to induce a potent state of immunosuppression at the time when the antigen presentation is maximum. That is when the risk of rejection is maximum. So the induction agents are usually with the help of steroids, thymoglobulin, or basiliximab, which is Simulect. The maintenance therapy is to prevent rejection for in the next 3 to 6 months to prevent acute graft rejection, and long-term therapy which the patient has to take for lifelong. So usually tacrolimus, that is biomus, and mycophenolate, that is myomif, is given to the patient. The patient is usually on these tablets for lifelong, and it is monitored by the TAC levels. Thus, the preoperative orders, anxiolysis, if at all the patient is anxious, midazolam can be used. Aspiration prophylaxis with the help of H2 blockers. Proper care of AV fistula, sepsis, very important. Continue all antihypertensive treatment except for ACE inhibitors and ARBs, which might cause hypotension at induction. If the patient is on antiplatelets, then it has to be stopped prior to surgery. Cardiac medications have to be continued till the day of surgery, and immunosuppressants according to the protocol. Antibiotic prophylaxis, and fresh post-dialysis renal function test before the surgery. So a good preoperative assessment on optimization goes a long way in reducing perioperative morbidity and mortality. Thank you.
Hello. Excellent presentation, Dr. Shwetali. If anyone has any questions.
I think we'll take questions at the end of the session, the kidney session. Thank you, Dr. Shweta, for explaining this basic yet extremely important topic in such a detail. I'm sure our students must have learnt a lot, because when they go for PSCs now, they know what they have to look for to reduce the perioperative risk. May I request Dr. Pallavi Vaghalkar ma'am to felicitate Dr. Shwetali Wadke. I request Dr. Pranali, Dr. Pallavi, and Dr. Aditya to chair the next session as well. I request you all to listen all these lectures very carefully, because at the end of the session we are going to have a quiz and hint to all those questions may be hidden in our speakers' lectures. So the breakthrough to the success of transplant program was a result of several significant discoveries involving improved surgical techniques, effective preservative solutions, suppression of cellular immunity, and so on. However, the advances alone could not have led to improved outcome without parallel advances in the field of anesthesia and critical care. Our next speaker, Dr. Kanchan Singh, will take us through the emerging trends in kidney transplant with best practices. I request Dr. Kanchan to come on the dais.
Hello everyone. Thank you for this opportunity. So renal transplantation is the most common solid organ transplant performed, and it is the treatment of choice for end-stage renal disease. These patients present a unique set of challenges to the anesthetist, who has a crucial role in the immediate success of the transplanted organ. In the last decade, transplant has become the choice for end-stage renal disease due to significant advances in surgical techniques, immunosuppression, and medical management of the transplant patients. So what are the current trends of renal transplant in India? In the year 2022, over 2 lakh patients warranted kidney transplant, but there were only 7,500 transplants conducted across 250 centers in the country. So at our center, Apollo Hospitals, Navi, Mumbai, we have conducted 343 renal transplants so far. I'll just give the outline of my presentation today. I will be speaking on anesthesia for laparoscopic donor nephrectomy, how we do it, pharmacokinetics of drugs in chronic kidney disease, anesthesia for renal recipient, and the emerging trends in renal recipients. So what are the likely sources of kidney for transplantation? It could be live-related donors, it could be live unrelated donors, or it could be diseased cadaveric donors. Donor nephrectomy can be conducted as an open procedure or laparoscopic and robotic surgeries. We usually conduct minimally invasive laparoscopic or robotic surgeries at our center. So the advantages of minimally invasive surgeries are, it causes minimal tissue injury, there's decreased blood loss, reduced requirement of analgesia, shorter hospitalization, and quicker recovery. And the challenges faced are the physiological effects caused due to pneumoperitoneum, the complex intraoperative position of the patient, the technical difficulty of the procedure, and unsuspected visceral or vascular injury. So how do we administer anesthesia for laparoscopic donor nephrectomy? Standard ASA monitors are attached. The choice of anesthesia is general anesthesia with cuffed endotracheal tube. Given the complexity of the intraoperative position and the physiological effects caused due to pneumoperitoneum, wide-bore IV access is important. We usually administer a combination of fentanyl, propofol, atracurium, and maintain with either Sevo or desflurane. Flotron pumps are attached. Fluid and blanket warmers are used. After induction, the patient is kept in lateral decubitus position with bed flex position to expose and arch the flank. Special precautions should be taken and adequate padding should be done to avoid any nerve injury, airway compromise, loss of venous access, or pressure source. So this is the intraoperative position during laparoscopic donor nephrectomy. So what are our intraoperative goals? We administer plasma light around 10 to 20 ml per kg per hour to maintain a good urine output of at least 2 ml per kg per hour, maintain good perfusion pressure and avoid hypotension. Normoxia, normocarbia, normothermia are essential, and mannitol is administered before renal artery clamping. A word about ischemia time. So what is warm ischemia time? It is the time from the renal artery ligation to flushing of the harvested kidney with preservative solution by the surgeon. It is usually 3 to 5 minutes. Cold ischemia time is the time from flushing of the kidney with preservative solution to reperfusion of the renal artery in the recipient. So for planned live donor nephrectomy, it is usually less than 50 to 60 minutes, but it can extend up to more than 24 hours in case of diseased cadaveric donations. These patients are usually extubated at the end of the surgery, and they are shifted to dedicated transplant ICU for at least 24 to 48 hours. Now, the post-op pain caused in open nephrectomy could be severe. because of the subcostal incision, which can be very well managed by using ultrasound-guided TAP, QL, or erector spiny plane blocks. Thoracic epidural also can be cited. IV fentanyl, paracetamol can be administered. In laparoscopic donor nephrectomy, the patient can experience pain because of the port site, ureteric colic, because of the lower abdominal incision, indwelling urinary catheter, and the diaphragmatic irritation because of the pneumoperitoneum. We need to continue adequate hydration and DVT prophylaxis post-operatively, and early immobilization is important. Moving on to pharmacokinetics in chronic kidney disease, we need to remember 3 things about pharmacokinetics in end-stage renal disease. There is decrease in the volume of distribution, there is impaired renal clearance, and there is decrease in the plasma protein binding because of albuminuria in these patients. I will discuss the range of anesthesia medications one by one. To start with, opioids. Fentanyl undergoes extensive hepatic metabolism. There is no active metabolite, but there is decrease in the plasma protein binding, which increases the free fraction of the drug, so titrated doses are important. Morphine is metabolized to morphine 3 and morphine 6-glucuronide, and morphine 6-glucuronide has analgesic properties. The elimination depends on renal function, which thereby prolongs the action in patients with chronic kidney disease. Tramadol, 30% is excreted unchanged in urine, and it has an active metabolite that is excreted by kidney and which prolongs the duration of action, so the dosing interval has to be increased. Propofol pharmacokinetics are unaltered by chronic kidney disease, can be used safely. Thiopentone, there is decrease in plasma protein binding, so increase free drug concentration. Again, titrated doses are important. Midazolam. Midazolam gets metabolized to 1-hydroxymetabolite, so single doses are okay, but when used in infusions, it can lead to prolonged sedative effects. Dexmedetomidine, pharmacokinetics are not influenced by renal impairment, but the sedative actions can be stronger due to decreased plasma protein binding. Regarding a neuromuscular blocking agent, succinylcholine can be used safely if the serum potassium level is less than 5.5 milliequivalents per liter, because single dose of scoline will increase the serum potassium level by 0.5 milliequivalents per liter. Of course, the amount of plasma cholinesterase is decreased in CKD. Atracurium and cisatracurium are the drugs of choice in such group of patients. They undergo Hoffman's elimination. Remember, laudanocin can accumulate with prolonged infusions, which can cause seizures. It was found to be neurotoxic. Rocuronium, 10 to 20% is excreted by the kidney. It does not have any active metabolite, can be used for RSIs. Vecuronium, around 40% is excreted by kidney, and its 3-hydroxy metabolite gets accumulated in chronic kidney disease, should be avoided. Reversal agent, neostigmine, renal excretion accounts for 50% of the plasma clearance, so the half-life is prolonged. Moving on to inhaled anesthesia agents. So what is the controversy of sevoflurane in CKD? Metabolism of sevoflurane can result in elevated inorganic fluoride levels, and levels above 50 micromoles per liter were associated with renal damage in animals, not in humans. Sevoflurane reacts with CO2 absorbents to form compound A, which has been found to be nephrotoxic again in rats and not in humans. So sevoflurane can be used in CKD, but some countries do have a fresh gas cutoff of more than 1 to 2 liters per minute. Desflurane and isoflurane are safe. Moving on to anesthesia for renal recipients. After wheeling in the patient, standard monitors are attached. You can see in this picture, we have to take care of the AV fistula. So the IV line and the BP cuff is on the opposite side. A word about vascular access. Good vascular access is very important, which may often be difficult because of chronic dialysis. We need to avoid IV line and NIBP cuff on the hand with AV fistula. Now, if there is an existing hemodialysis sheath, the use should be avoided except in emergency scenario. An ultrasound-guided central line is sited after induction. Word about invasive monitoring. CVP is monitored in every patient. It is used to guide fluid therapy and for administration of inotropes. Also for blood sampling, usually right IJV is preferred. Subclavian and femoral lines are avoided. Arterial line is cited only if the patient has significant cardiac or respiratory impairment. So general anesthesia is administered by using titrated dose of fentanyl, propofol and atracurium, and thromboprophylaxis and blanket warmers are used. Immunosuppressive agents are also administered as instructed by the nephrologist. So ATG is a polyclonal antibody obtained from equine or rabbit cell lines. It is usually given as an infusion over 6 hours. Around 75 to 100 milligrams is administered. It can lead to cytokine release syndrome, bronchospasm, hypotension, and tachycardia. Methylprednisolone is also administered, usually given prior to ATG. It helps us to decrease the cytokine release syndrome and hypotension caused because of administration of ATG. Simulect or basiliximab is a monoclonal antibody that competitively inhibits the alpha subunit of interleukin-2 receptor, and it is usually administered as a 20 milligram dose. Intra-op is maintained using oxygen, air. I prefer desflurane. Ventilation to maintain normal PO2 and PCO2. Top-ups or infusion of fentanyl and atracurium can be used. We need to maintain a MAP more than 100 millimeters of mercury to preserve any residual renal function and to prevent delayed graft function or need for post-op dialysis. Maintain blood sugar levels less than 180 to 200 milligrams per deciliter. So in this picture, you can see the donor allograft being placed in the right iliac fossa, the donor renal artery being anastomosed to the external iliac artery, and the donor renal vein getting anastomosed to the external iliac vein. And the sequence is the vein followed by artery, followed by reperfusion, and then the ureteric anastomosis. So at the end of the renal artery anastomosis, we need to prepare ourselves to deal with any ischemia reperfusion injury. So when the renal artery is clamped in the donor, there is ischemia in the allograft, which is because of the decrease in the oxidative metabolism, increase in nitric oxide, increased anaerobic glycolysis leading to increase in reactive oxygen species, decrease ATP causing tissue injury. So what happens after the break of ischemia and when there is reperfusion, there is increased blood supply, which leads to reoxygenation, again increase in reactive oxygen species, increased cytokine activation, complement activation, leading to leukocyte adhesion, capillary permeability is increased, capillary leakage happens, and again it leads to tissue injury in the recipient. So how do we manage hemodynamics during reperfusion? For best graft function, a CVP of 10 to 15 mm is optimum. Again, MAP more than 100 millimeters of mercury, as the allograft will be denervated with no autoregulation. Adequate hydration with plasmolite 30 ml per kg per hour is important during the period of anastomosis, and low dose noradrenaline can be used. Mannitol or Lasix can be used. Immediate urine output is seen in almost 90% of live donor and 50% of cadaveric donations. These patients are usually extubated at the end of the surgery and shifted to the ICU for post-operative care. A word about blood transfusion. Blood transfusion in renal recipient can cause alloimmunization and is not recommended. It is always better to correct anemia pre-operatively. These chronic kidney disease patients are usually able to tolerate anemia very well, and the transfusion trigger is 7 grams per deciliter. So now moving on to the last topic, emerging trends in renal transplant. So in the past, the first successful renal transplant in humans was conducted in 1954 between identical twins, and you won't believe me that the basic monitoring like ECG and NIBP was used, and it was conducted under spinal anesthesia. So we have come a long way with availability of advanced anesthesia monitors, which help us to provide better quality care and helps us in giving a better outcome for our patient. We use ultrasound for invasive lines and regional blocks. Previously, everything was done as a blind procedure or landmark guided techniques. Because of the availability of shorter acting agents like fentanyl, remifentanil, atracurium, propofol, etomidate, and desflurane, we can expect early recovery in our patients. Word about IV fluid and the emerging trends. In the past, 0.9% NS was used intraoperatively in renal transplant recipients. This review article, which studied the fluid management during kidney transplantation by the members of an American Society of Anaesthesiologists, concluded that balanced salt solutions have better metabolic profile compared to 0.9% saline and equal, if not lower, potassium levels compared to NS. So either plasmalite or ringalactate can be preferred. There is probably no benefit for routine use of albumin over crystalloids, and use of starches is not recommended. Again, as discussed earlier, we have good immunosuppressive drugs currently than in the past. So there is decreased amount of graft failure and decrease in delayed graft function. Moving on to the emerging trends in the preservative solution. Currently we use custodiol, which is histidine, tryptophan, alpha-ketoglutarate solution, which has lesser amount of potassium compared to urocolins and University of Wisconsin solution used in the past. It also has mannitol, histidine as a buffer, and tryptophan and alpha-ketoglutarate, which are free radical scavengers. Now, a word about vasoactive agents. So I will cite this study, which was published in September 2023 regarding catecholamine vasopressor exposure, which is found to be associated with early poor allograft function and adverse events in living donor kidney transplant recipients. So it is imperative that we minimize the use of vasoactive agents intraoperatively. So now regarding ERAs in kidney transplant, there are no given guidelines by the Society of ERAs regarding management of kidney transplant patients, but isolated studies have found that use of ERAs in kidney transplant patients can be helpful for decreasing the stay in the hospital and for better outcomes. So now in the past we did open nephrectomies, and now presently we are doing only minimally invasive surgical techniques like laparoscopy or robotic surgeries. This was a special issue which was published in the Journal of Clinical Medical Journal in July 2022, which studied multiple papers on newer advances in renal transplantation. I'll just cite a few papers. So Imamura et al. Performed a long-term multi-center study showing that everolimus decreases cancer incidence and improves patient and graft survival rates after kidney transplantation. Another paper regarding apheresis efficacy and tolerance in the setting of HLA incompatible patients was studied. An interesting article regarding intraoperative near-infrared spectroscopy monitoring of renal allograft reperfusion in kidney transplant recipient was done, and they concluded that this tool can be used intraoperatively to assess the degree of preservation reperfusion injury to predict early allograft function. Lastly, the future lies in xenotransplantation. So in the first, a genetically edited pig kidney was transplanted into the human. The procedure was conducted by Harvard Medical School physician, and believe that the first xenotransplant in humans was done in 1902, which was not successful. This patient is doing well. So to conclude, what are the best practices in renal transplant? Strong documentation and efficient planning is the key to success of the transplant program. Proper communication and collaboration between the anesthesia and surgical team is crucial. Drug dosages should be titrated to effect, and minimizing ischemia time, appropriate immunosuppression, and good mean arterial pressure with minimal use of inotropes are predictors for better graft function. To conclude, I would cite a beautiful quote from Sir Nelson Mandela: "It always seems impossible until it is done." Thank you.
Thank you, Dr. Kanchan. Excellent, well-delivered talk. Covered everything from basics to emerging trends. Very good.
Any expert comments?
Thank you, ma'am. I would request you to just enlighten us about how do you manage the blood pressure, considering that all our renal recipients are mostly hypertensive and extremely hypertensive.
Yes. So most of
200. How do you manage blood pressure intraoperatively?
Right. So most of our patients have hypertensive chronic kidney disease, and we do get patients, despite being on antihypertensive medications, who will have BP with as high as 200 millimeters of mercury. At induction or intraoperatively, it is always better to use shorter acting agents. You can use Xylocard during intubation. You can use short acting beta blockers like esmolol. Intraoperatively, I believe that you can use small doses of nitrous oxide because it is not a longer acting drug. Because if you give propofol, the MAP will fall and you will not be prepared for reperfusion. So the target should be to use titrated doses of nitrous oxide intraoperatively, which will settle the blood pressure and won't affect the patient. And you can cut down the nitrous oxide once the BP is settled.
Do you customize the map intraoperatively according to the preoperative BP, or do you have a standard map that you maintain for all patients?
Yes, so the preoperative map is important, but the target map, which I mentioned earlier, should be at least more than 95 to 100 millimeters of mercury. Many a times it exceeds 110, 120 also. Thank you.
Are the questions allowed or at the end? I just wanted to ask, what are the preoperative advice given to the donor?
Yes. So ERAS protocol, we try to follow ERAS protocol. The patient is fasted for 6 hours for solids. They can have water till 2 hours prior. They can continue antihypertensives preoperatively. We try and avoid AC inhibitors, which can cause exaggerated fall in blood pressure in these patients, and Pantodac can be administered.
And I think the donor also should be well hydrated so that the graft which is can be harvested.
So, we can allow them liquids till 2 hours prior, clear liquids till 2 hours prior, and they do have
do you give IV fluids or something?
Yes, yes. They come with an IV line in place with IV hydration preoperatively.
And with your experience, there was excellent presentation, Kanchan. But 343 cases of yours, you extubate all the patients, right?
We try and extubate most of our patients. Occasionally, we were not able to extubate because of
yeah, so I wanted to ask that only. Any experience where you have to shift
So
the
far, whatever cases I have done, I have been able to extubate all of those. But there were occasional patients who were very obese and they had difficulty in breathing, so they were electively ventilated in the post-op period. But with me, I have been able to extubate most of our patients. Thank you so much.
Thank you, Kanchan, for this informative and engaging talk. I'm sure your encouraging perspective will motivate youngsters to take up kidney transplant anesthesia, especially after knowing the constant development and the positive results. May I request Dr. Aditya Nayak to felicitate Kanchan. I request Dr. Leena Pawar to felicitate our honorable chairpersons. Dr. Pranali Patil. Dr. Pallavi Vaghalkar, ma'am. Dr. Aditya Nayak. Thank you all. Now I would like to invite our next chairperson, Dr. Amol Patil sir. He is a senior neurosurgeon in Apollo Hospital, renal transplant surgeon. Dr. Ashwati Haridas, she is a consultant nephrologist, and Dr. Sultana Sherman, a consultant anesthesiologist at Kenyatta University, teaching and referral Center at Kenya. In spite of all the advances, meticulous preoperative preparation and efficient intraoperative management of kidney recipient, post-transplant oliguria or anuria poses a challenge usually not readily resolved by conventional laboratory and clinical criteria. Our next speaker, Dr. Rochana Bakshi ma'am, will discuss this sensitive topic in detail. Dr. Rochana Bakshi ma'am, she is a professor at D.Y. Patil College. Thank you, ma'am.
A very good afternoon, one and all. At the outset, I would like to thank the organizers for having given me this opportunity. And I promise you, I won't keep you away from lunch for more than 15 minutes. So once a patient receives kidney transplant, critical attention needs to be paid to ensure his hemodynamic stability, side effects of new medications, preventing infections, so as not to jeopardize the allograft. The transplanted kidney mainly has to have two goals: adequate perfusion and adequate amounts of urine. The focus remains on preventing a delayed graft function with controlling for risk factors and trying to avoid intra and post-op hypovolemic states and hypotensive conditions. Now, the drop in output is multifactorial. And why this topic today? Because as we all know, there is a long-term association of the first day post-op output with short-term as well as long-term outcomes in graft patients, which is very well illustrated in this study that is published in 2024 in the Canadian Journal. Now, the long waiting list of patients awaiting kidney transplant and shortage of donors has necessitated accepting expanded criteria donors or donation after cardiac death donors. So the donor-specific risk factors in these particular set of patients is a donor age more than 60, cold ischemia times which exceed 15 hours, warm ischemia time exceeding 45 minutes, non-T-cell antibody induction, female gender, and obese donors. The recipient risk factors: maintenance hemodialysis before transplant, again a topic of debate, obesity, diabetes in the recipients, male gender, the African American race, small for size organ, prior immune sensitizing events such as blood transfusions, pregnancy, or previous transplant. Now, deceased donor transplants, mainly in the context of volume depletion due to ultrafiltration to dry weight in the dialysis session, use of dialysate with low sodium, low magnesium, and low calcium concentrations, acetate-based dialysate and higher dialysate temperatures, all these factors which could cause hypotension. So more and more again studies coming up which say that it is better to do a preemptive transplant as against a non-preemptive transplant. Again, this is one study published in 2023. So international guidelines are now recommending to do preemptive versus non-preemptive transplants. Autonomic dysfunction, let us quickly go through some perioperative factors. Autonomic dysfunction due to impaired cardiac baroreceptor sensitivity, which is common in CKD patients. My previous two speakers have given an excellent overview of the entire thing, so we'll quickly go through these slides. Decreased cardiac reserve, poor LV systolic function, The denervated kidney allograft impairs hemodynamic response to sympathomimetics and defense against extracellular fluid volume depletion. Overzealous use of antihypertensives, again international guidelines defer us from using ACE inhibitors on the day of surgery, but beta blockers may be continued. Use of anti-thymocyte globulin, one has to be careful. Tissue ischemia causes release of potent vasodilators, nitric oxide and adenosine, and hypotension finally inflicts hypoperfusion of the graft. So the resultant ischemia, switching of cells from oxidative metabolism to anaerobic glycolysis, again explained by Dr. Kanchan very well. So I move on. So what are the strategies? Avoid dialysis-related hypotension, reducing ultrafiltration, and keeping the patient at least 1 or 2 kilos above dry weight. That is what is recommended. Reviewing dialysate composition and temperature, carefully assessing and optimizing cardiac factors, antihypertensive drugs to be used cautiously, CVP, which is the conventional method done in most of our centers for volume infusion. But current evidence also points to individual therapy based on dynamic indices, especially if the patient is more morbid. Optimize pre, peri, and post-op hydration to improve renal graft function. Use balanced crystalloids and target-directed intraoperative hydration. Now, again, I would like to reiterate here, it was discussed in detail by Dr. Shweta, but determining the ABO blood group, the HLA types, A, B, C, and DR phenotypes to be done. Test both donor and recipient for HLA-DQ. And what is said by the European guidelines is that HLA-DP testing needs to be done in sensitized patients. So as anesthesiologists, I think we also need to know the surgical causes which could cause either oliguria or sudden anuria in the patient. In live-related renal transplants, immediate graft function is a rule rather than an exception. Sluggish graft function or delayed graft function is more common with a deceased donor. Now, sudden anuria in the first few hours after surgery, especially with prior immediate graft function, either could point to a hyperacute rejection, kinking of the renal artery, vascular thrombosis, urinary leaks, or ureteric obstructions. I'll just take you through 2 or 3 cases which I came across in literature. 36-year-old female end-stage renal disease, 1 haplomatch, donor being mother, no induction done, uretrovesical anastomosis done, with stent in situ. There was a good urine flow. Post-closure, suddenly anuria noticed. Doppler ultrasound shows an empty bladder, but good perfusion to the transplanted kidney. So decision to explore immediately done. Pink and turgid kidney. So what was seen is release of the ureteric anastomosis, which revealed a clot in the entire length of the transplanted ureter. But they could save the allograft after the exploration. 43-year-old male, live-related kidney transplant. The donor underwent an uneventful nephrectomy. 1 artery, 1 vein, good anastomosis, sudden stop in urine after closure of the surgical wound at the time of anesthesia reversal. Now, an urgent duplex ultrasound performed in the operating room, which showed no flow in the transplant renal artery. The allograft appeared blue, soft on palpation. So what was seen is a clot in the main renal artery extending to the upper polar branch, which compressed the other 2 branches and was compromising renal function. It also revealed, after release of the arterial anastomosis, a dissection of the transplanted renal artery. So they had to put in a saphenous vein graft. But they could save this kidney well. Now, an interesting phenomena, the Page kidney. Page kidney or Page phenomenon, a form of treatable secondary hypertension that is due to external compression of renal parenchyma, as seen by a subcapsular hematoma, a mass, fluid collection, which leads to activation of the renin-angiotensin-aldosterone system. Could be a challenging condition. Treatment options include antihypertensives, percutaneous drainage, surgical decot, laparoscopic intervention, or even, unfortunately, nephrectomy sometimes. A 56-year-old male had been on hemodialysis for 2 years, diabetic end-stage disease, pre-transplant induction treatment done for him, anastomosis successful, good renal perfusion, no bleed in the anastomotic area, or even renal parenchymal blood flow showing normal. After anastomosis, immediate diuresis was observed. Now, first day, patient had an average of 100 cc per hour. POD day 1, he just received his immunosuppressants, but urine volume had decreased to 29 cc per hour. Saline infusion and diuretics were given. There was no change in urine volume. Doppler ultrasound showed the renal cortex being compressed by a 28 mm deep subcapsular hematoma. There was no evidence of rejection, renal vein thrombosis, or anastomotic stenosis. POD day 2, urine output further decreased to 8 cc per hour. There was still no change in the size of the hematoma. And now, but surprisingly, the Page phenomena didn't have, he did not have any BP surge, or he did not have any allograft pain complaint. So that's the reason why they were conserving. And then he ultimately underwent hemodialysis that day and an emergency surgery. So what was found is 75% of the entire kidney surface area was covered by this subcapsular hematoma. Capsulotomy and hematoma removal were done, but the hematoma was partially removed, not entirely. But from day 4 to day 7, patient drastically improved, and at discharge, his creat was 0.98. Now, urine leakage, again, one of the common early post-op surgical complications due to ischemic necrosis of the distal urethral segment. Clinically, patient may have pain, swelling in the transplant area, rising creatinine, oliguria, and signs of systemic infection. Immediate post-op, there could be urine leak through drains, through wounds, can translocate into the retroperitoneal area, presacral area, or scrotal area. Urethral catheterization should be the primary approach. Probably our surgeons could later on talk about it. Ureteric stenting and percutaneous nephrostomy with urethral catheterization is supposed to be the definitive management. Now, one very interesting, the last part of my talk, what I came across, is something called as the retroperitoneal compartment syndrome, again seen in this article. Now, what is this retroperitoneal compartment syndrome? The tight muscle closure, which may lead to renal transplant compartment syndrome, either due to compression of the renal parenchyma or kinking of the renal vessels, may cause kinking of the transplant kidney ureter. It could be seen in pediatric recipients receiving adult kidneys, or small adult recipients receiving large kidneys, where there is diffuse renal parenchymal compression, kinking of renal veins within a tight compartment, and ultimately the end result is a drop in the plasma, renal plasma flow, GFR, and outflow obstruction. Doppler findings are variable here. It could be an adequate arterial and generally an adequate arterial and venous flow, but maybe decreased diastolic flow within the intrarenal arteries, or sometimes elevated systolic velocity seen. So this again warrants an emergency exploration. Sometimes just opening up of the abdomen helps, or repositioning the kidney into the peritoneum may reverse the process and salvage the transplant. So to summarize, optimum perioperative management of recipients with emphasis on avoiding hypotension, adequate hydration, judicious use of antihypertensives, reduced postoperative urine output following kidney transplant is associated with an increased risk of kidney replacement therapy, delayed graft function, prolonged length of hospital stay, and the impact of perioperative factors is seen not just short-term but also on long-term graft function. Surgical causes should be considered in the differential diagnosis of sudden or abrupt anuria or oliguria. Thank you all.
No, we weren't here. Okay, sorry. So I said oliguria or anuria, all the three people are involved in this: anesthetist, nephrologist, and the surgeon. And if you divide the percentage of the factors, 30% anesthetist, again then 60% or 40% you can say nephrologist and 50%, 60%. But there's again crossover. If you see, what happens is hypotension, as he has said already, hypotension and any other cause, we can immediately after the reperfusion, if there is a sudden hypotension, then also initially the kidney makes urine and the kidney starts slowly reducing, the urine output starts reducing. So this is the point where we have to be, that's why in all the other speakers also they basically focus more on hypotension thing. Okay. So this is what the surgeon is worried about. Second thing, what the anesthetist will say, ATG they want to put intraop only. So intraop ATG causes hypotension. Intraop ATG causes hypotension, hypotension causes what surgeon is all the time seeing at the time of reperfusion at the monitor. We want more BP, more BP, more BP, ATG already. So they fantastic anesthesia team in our hospital. They actually sense us what they want, and at that time before the clamp release they normally start noradrenaline if required if the BP is too low, and then we definitely manage to prevent that hypotension. Second thing is now renal causes, immunological, Dr. Ashwati will talk on. If there is a sudden means good amount of urine output, then later on becoming kidney blue or something like that, then chances of hyperacute rejection. We have seen very rarely we see out of 1,000 transplants to 2-3 patients, but we have seen one patient. Then post surgery, what madam has said, in that clot causing obstruction to the ureter, definitely. More than that, commonest what we see is immediately after closure we are seeing there is a abdominal compartment syndrome like thing which happens, there is a kinking of the vessels, and then there will be decreased flow to the kidney and reduced output. Other thing she has also pointed out about the urinary leaks, which are not very common in the immediate period, but they are seen in 6th or 7th day. There is no urine output drop, but actually the creatinine is also normal, but there is an output drop as such in the from the bladder, but there will be urine accumulating in the abdomen. So about the hyperacute,
That was an excellent talk, ma'am. And one of the points that you mentioned, after a live-related transplant, brisk diuresis is always the rule rather than the exception. And it is very important to be vigilant for these events because as you've shown, in most of these cases, they were reversible. So detecting vascular thrombosis, detecting a kink, detecting urinary leak. So if it is done in a timely fashion, we can actually save the allograft. And non-surgical causes are usually, at least in the immediate post-transplant period, in a live-related transplant, hyperacute rejection is something that is seen very occasionally now because of very good induction and very good immunosuppression. And in hyperacute rejection, unfortunately, the only thing that you can do is a graft nephrectomy. But at least when it comes to these surgical causes, in most cases they are reversible if they are picked up on time. And the other thing is in patients, at least in the first 3 to 4 days post-transplant, we don't really need to wait for the patient to become anuric. Even if there is a reduction in 50% of urine output from the last hour for at least 2 to 3 hours, it becomes an indication to at least do a Doppler and then evaluate the patient.
in the subcapsular hematoma, which they would have intervened early, you would have seen here we never saw any subcapsular hematoma, but in one of the near the hospital where I operate, I have to do twice exploration for the subcapsular hematoma. So once I explored, it's a small subcapsular hematoma. I did a capsulotomy and I just left. Next day morning, patient immediately urine started coming, everything was fine. Next day morning, again Doppler was done, Doppler was showing again subcapsular hematoma. So here liberal capsulotomy is very important surgically. Sometimes you have to remove entire capsule if required. There will be oozing from the parenchymal surface, but then that oozing can be prevented. Subcapsular hematoma causing page kidney and reducing the output is very dangerous.
Yeah, and here they kept waiting because he did not have any vital signs, didn't change at all. So they kept, that's what is written in that case report, that they wanted to observe on day 1 and then day 2 again a Doppler they did when the urine really dropped.
Usually these patients become hypertensive.
Yes.
Like it becomes
So
very difficult to control.
He did not
their blood
present
pressure.
typically as a page patient. So that's why they waited. That is why I picked up this case to present.
Any more questions? For all 3 sessions, any more questions? For the first session as well?
Sonia, one question. Just give the mic.
Nice. Ishma mic lena.
Thank you. Thank you very much for those wonderful and very informative presentations. My name is Dr. Njogu. I'm a nephrologist from Kenya. 3 questions. One, do you notice any difference in the urine output from the Africans compared to the local population here? Number 2, do you notice any differences in the control of the blood pressure post-operatively for the Africans? Because from my experience in my country, a lot of the patients tend to be hypertensive and their BPs tend to be very high even post-operatively. I have observed several transplants here in Apollo and their blood pressures tend to be quite good, not so high, like we find a lot of 170, systolics of 180, despite being on several antihypertensives. Thirdly, is there any options for this retroperitoneal compartment syndrome? Because sometimes we have observed that in our country whereby the kidney and the graft seems to be struggling to be fitting in that space. Are there options for the surgeons of expanding the space or placing the kidney somewhere else? Thank you.
About the third question I will take. So you said you are worried about the abdominal compartment. Sometimes we can put the kidney into the peritoneum. We can open the peritoneum and there is no harm. Only small window of peritoneum closure at the lower pole we can make, and the upper pole and the medial side of the aspects can be kept open to the peritoneum. Why to keep the lower part of the kidney on the lateral aspect closed by the peritoneum whenever any further intervention is required, so that bowel will not come into a way to do any biopsy and all these things. So we can do that in children. Sometimes we have to put a kidney intraperitonealized, not like nowadays you are seeing we do extraperitoneal only here, but we can put it into intraperitoneal aspect also.
So I'll address the first 2 questions. So when it comes to diuresis in the immediate post-transplant patients, we have not noticed any difference when it comes to Indian patients and patients who come from other countries. So that is nearly the same. I mean, there's absolutely no difference when it comes to the early graft outcomes. But the second point, usually patients who come from African countries, they tend to have higher blood pressures, not only in the immediate post-transplant period, but also when they are on dialysis. So usually they have very difficult to control blood pressures.
Good thing is that we have an opportunity to see one patient who is being operated yesterday from your country, so you can follow up also.
Any more questions? I have one question for Dr. Shwetali. Many a times we face conflicting situation where we feel that patients are a bit under optimized, and we may take a liberty and request surgeon to optimize them a bit. And so I just wanted to know, are there any situations where we can delay transplant electively, not emergency, not a deceased donor I'm saying, but electively?
So basically we need to weigh the risks and the benefits. So sometimes a patient might be in a cardiac overload. So in that patient we might have to ask for one more session of dialysis before the patient is taken up for surgery. So we had one patient operated few months back in which the patient had recurrent developing pleural effusion. And the basic pathology was the reason for that pleural effusion. The patient was investigated for the same. So this patient was posted once, cancelled, but then the second time, because we couldn't optimize the patient, we had put on pre-operatively ICD and then taken up the patient for surgery, and the patient did very well post-operatively. So yes, definitely we have to weigh the risks and the benefits. These renal patients, because of the underlying complex pathology, often cannot be optimized to the best, but whatever we can, we have to.
And one point to notice, live-related transplants are always elective procedures.
Right.
Most of the times it doesn't matter if you postpone it by a day or so.
Right.
I mean, it's always safety first.
True.
Yeah, totally agree. Sometimes uremic pleural effusion, once it is proved that it is pleural effusion is not any infective or something, it is secondary to CKD related uremia. That's why in 1 or 2 cases this has happened. But we are very confident about our anesthetists that because they are doing a transplant at the EF of 10% and they have brought the patient out. That's why we are very confident. That's why we are putting the patients like this.
Yeah, I don't recollect any episode where we had to postpone our transplant.
Thank you so much for the inputs. Any more questions? There is one question. Mike.
Hello. Yeah, so this is Dr. Rishikesh from Satya Sai Sanjeevani Center for Child Heart Care. My question is related to the doctor's question from Nigeria. So is there a concept of tissue banking or biobanking as far as the renal transplants are concerned? And what is the scope of genomic and genetic testing to know the differences for the need of the transplant?
Tissue banking has been, tissue preservation has been started. Like many of the times we keep on our vessels like how they do in liver transplant and all. About the tissue genomics, now the pig kidney transplant has come long way. So there is definitely focus on that now in Indian this thing also. We'll be definitely focusing on how there is a genomic difference in the Indian subcontinent or the African subcontinent or something like that. So there's a scope, but still not anything started like that. We'll be definitely in next. That about the tissue banking, as you said, we are keeping the vessels, the same blood group and all. We thaw them and keep them into this thing. Many of time we need extra vessels, like in liver transplant also they keep. So we also keep. About the genomic this thing, it's a long way. It's definitely going to come and it is going to help us.
Thank you.
Any more questions? So thank you all speakers. Thank you Rochna ma'am for such a complex topic, simplifying so well. And certainly, I didn't know that reduced urine output has, multifactorial pathophysiology. So one has to be really vigilant and be in constant communication with the surgical team for early identification of oliguria or anuria, so that we can revise it again immediately. So now I would like to ask Dr. Amol Patil sir to felicitate Rochna Bakshi ma'am. I request Dr. Kiran Shingote, CEO and Unit Head, Apollo Hospital, Navi, Mumbai, to felicitate Dr. Amol Patil, sir. I request Dr. Sanjita Umbarkar, Madam, President ACTA. She's a professor and head of department, CVTS, KEM Hospital. Madam, Dr. Sanjita Umbarkar, Madam, may I invite you on the dais and felicitate Dr. Ashwati Ramdas. May I invite Dr. Vikram Vagalkar, sir, Senior Consultant, Apollo Hospital, Navi, Mumbai, to felicitate Dr. Dr. Sultana Sherman, Consultant Anesthesiologist from Kenya. This was indeed a wonderful session, full of knowledge. So I would like to conclude this session, but before that, we are going to have a very short quiz of 10 questions. I hope you all were attentive during the sessions. So Thank you, ma'am. Thank you, sir. Hands up there.
It's my pleasure to invite Dr. Kiran and Dr. Sanjita madam. I would like Dr. Kiran to just speak few words. Both madam and sir were invited for inauguration, but we have to finish it before. Dr. Kiran will just speak few words about our transplant program at Apollo Hospital.
Thank you. I think I'm disturbing this flow already going on. Excellent clinical discussion. I don't know what I'm going to add that specifically clinically. But let me talk about our transplant program here. We have more than 550 transplant done, and as we are seeing our Kenya counterparts also, so we have a lot of affiliation not only in city, outside Maharashtra, outside India, where we are conducting transplant program. Anaesthesiology, which is today taking lead to get the knowledge and sharing this kind of program, is really proud to us. We'll continue having such program here on. Thank you very much for being here, and hope our hospitality from hospital is good and you're comfortable. Thank you.
Under the able leadership of Dr. Sanjita madam, our president ACTA, we are conducting lots of academic activities. Last Sunday only we had a transplant ECMO workshop and heart transplant program at KM Hospital. I would like Dr. Sanjita madam to come and dais and brief about our ACTA programs, and please give a big applause for her.
Good afternoon. I would have loved to say good morning, but anyway. So on behalf of ACTA Mumbai, I am presenting here. I am very much thankful to Apollo Hospitals Mumbai and Dr. Saurabh Tiwari to conduct such an academic feast, which will be followed by the gastronomic feast today. So I will not take much time. ACTA Mumbai being a very active academically as well as a social branch, I will say, because we conduct the various academic activity every yearly, minimum 12 to 20 activities we conduct. Even during COVID times, it was online sessions were conducted, and then they were very useful. Regarding today's CME about the various organ transplant, I just heard about the discussion going on regarding renal transplant. I enjoyed that. Even at our institute at KEM, Dr. Pallavi and team, they conduct renal transplant, and sooner we also are going to conduct heart transplant, which was way back in maybe more than 50 years back. The first heart transplant was done at KEM Hospital. So we will restart the program. And I congratulate Dr. Saurabh and his team to conduct this CME. And in future also, we'll like to have your academic support as well. Special thanks to Dr. Murli Krishna, all the way you have come here, and we are eager to listen to your talk. And that was one of the most attraction of this CME. So let me tell you that, because all our students, they will listen from YouTube because they are on call, they could not. And thanks Dr. Uday Gande and Dr. Vishwas for being here and boosting this academic program. Thank you, Apollo Hospital. Thanks.
All right, so tighten your seat belts. We are moving to the quiz on kidney transplant. Just a minute. Wait. Kidney ka karke de. Hang ho gaya re. All right. I don't want you to see that. So this is a time to display your knowledge. I will be reading out the question to you all, and you will get 30 seconds to think, and whoever raises hand will get an opportunity to answer first. The first question is, regarding pharmacology of anesthetic agents in renal failure patients, which of the following option is false? Remember, false. Excretion of water-soluble drugs and their metabolites will be enhanced. Rocuronium and mivacurium are relatively safe to use. Metabolites of morphine and pethidine may accumulate after repeated doses. And lastly, inhalational agents with fluoride ion as its metabolite can increase renal toxicity. So you have to find out the false option. All are true. Yes, she has raised the hand.
Is it option B?
Yes, absolutely right. So it's reduced. The excretion of water-soluble drugs is reduced. Yes. She said B. Oh, sorry, I heard A. B is rocuronium and mivacurium are mainly metabolized in the liver. D, the inhalational agents which has fluoride ions like methoxyfluorine, enfluorine. Sevoflurane is controversial, we can use it. But these three agents have fluoride ions and they are not safe for kidney. Moving to the next question. Which of the following drugs does not cause hyperkalemia? AC inhibitors, tacrolimus, alpha-2 agonist, and heparin. There is only one right answer, yes?
C.
Let's see if you're correct. Yes. Congratulations. The next question is, regarding post-operative pain management in live donor nephrectomy, which of the following option is false? You have to find out the false option. IV fentanyl PCA is most commonly used technique today. Paravertebral blocks or abdominal field block is a good complementary analgesia with least side effect. Indwelling catheters in wound site delivering local anesthetic is gaining popularity nowadays. And lastly, epidural analgesia is most preferred choice of pain relief. Which one is false? Let's see.
C.
Oh, sorry. Next one. No. The answer is D. Rochana, I think Rochana ma'am was thinking of this answer. This is because, especially our surgical friends would agree with this because they don't want any hypotension. If local anesthetics are given epidurally, then there can be hypoperfusion, renal hypoperfusion. So we can give opioids, but all three options are perfect, and this is little controversial. So this is the answer. In lateral positioned with loin raised, which of the following is true? Functional residual capacity remains unchanged. Venous return is increased. The use of PEEP is contraindicated, and damage to the common perineal nerve may occur. It's a very simple question. Which one is true? Time up. Yes. Behind you.
Damage to common perineal nerve.
Yes, it's very obvious answer. In lateral position, there can be damage to common perineal. These are little twisted options to awaken you. The next question is, which of the following immunosuppressant agent enhance the effect of muscle relaxant? Tacrolimus, mycophenolate mofetil, cyclosporine, and prednisolone. Yes? Who gave the right? Yes, cyclosporine is the right answer. Enhance the effect of muscle relaxant. So you have to cut down on the dose of muscle relaxant. With regard to renal function, which of the following is false? This is related to the renal physiology. Serum creatinine gives an accurate indication of glomerular function. Creatinine clearance increases with age. Serum electrolytes become deranged with mild renal impairment. Severe renal failure results in metabolic acidosis. Ma'am is saying A. Rochana ma'am is saying C. Let us see which is the correct answer. C. Rochana ma'am gets one more pen. Next question. Regarding management of deceased organ donor, all are true except. So you have to find out wrong answer, false. Like noradrenaline is the first choice of vasopressor agent. Maintain urine output 1 to 3 ml per kg per hour. Target hemoglobin should be more than 7 grams per deciliter and maintain mean arterial pressure up to 60 to 70 millimeters of mercury. Who said A? Mona madam. No. Okay. Let's see. A. So vasopressor is the first choice of agent. Prathamesh? Acha, Prathamesh, please, our DNB student who passed DNB in first attempt, a round of applause for him. Next. What is false regarding pulmonary hypertension in end-stage renal disease? Listen carefully. What is false regarding pulmonary hypertension in end-stage renal disease? Flow and duration of AV fistula has no direct effect on the severity of pulmonary hypertension. Pulmonary artery pressure reduces significantly 1 year after kidney transplant. Living donors are preferred in kidney recipients with pulmonary hypertension to minimize the risk of early graft dysfunction. End-stage renal disease patients have 2 to 8 times higher risk of developing pulmonary hypertension. This is little hi-fi, yes, our Canadian friend? Yes, absolutely right. The correct answer is A. The patients who have long-standing AV fistula have hyperdynamic circulation and flow overload, and they can get the pulmonary hypertension early, that to a very severe one. With regard to organ retrieval, all are true except heart and lung are retrieved first, cornea are retrieved last. Cold ischemia time for kidney is more than 24 hours. Donor warm ischemia starts from asystole in the donor, deceased donor, until cold perfusion starts. And D is brain death is declared after first apnea test.
B.
Who said B? What is the answer? D for dog?
Ball.
B is a wrong answer. Rochana madam is right. Rochana madam already. Anybody else? Anju, our DNB student who is exam going, she's saying D and she is right. So this is very obvious. We wait for the second apnea test before we declare and we take the organ for donation. Madam will take away all our pains, madam. With regard to use of local anesthetic agent in end-stage renal disease, maximum doses of local anesthetic should be reduced by 25%. Maximum dose of local anesthetic should be increased by 25%. No change in the dosage of local anesthetics, and the clearance of local anesthetic is reduced in end-stage renal disease. This is the last question. I give you 1 minute to think. Who said A? Kalpana. Kalpana gets the prize. The correct answer is A. Because local anesthetics are highly protein bound in end-stage renal disease, free levels of the drugs are increased and therefore there are increased chances of toxicity. On the other hand, the clearance of local anesthetist remains unchanged because they are mainly metabolized in the liver or by in the plasma. So this is the end of the session. Thank you so much for your patient hearing. I think we will have a lunch break now, and we will meet again after lunch break. Yeah, Garima has to say something.
So hello everyone. Just before lunch break, this is very exciting, energetic session. I would like to invite Dr. Amol Patil to felicitate Dr. Sonia Mahale. I know everybody is hungry. Nobody wants to stay. Just for a few seconds. So amazing lunch is waiting for you outside. Please help yourself. Thank you so much. And it's a 30-minute break. We will all assemble here after 30 minutes. Thank you so much.
Okay, shall we start? Okay, so having heard about so much of, no? This lighting is on. Hello? Yeah, okay. So, we have heard so much about kidney and liver transplant since morning, gain insight regarding the management, intra-op, post-op, pre-op. One thing everyone must have noticed is the hemodynamics. And when we talk about hemodynamics, the only organ that comes to our mind is heart. Hence, to move on to the next session, we have the session on heart and lung transplant. And for that, I would like to invite the chairpersons, Dr. Uday Gande. Sir is the senior cardiac anesthetist from Mumbai, and he's my guru. I am because of him actually. He encouraged me to do cardiac anesthesia. So, and the next chairperson for this session is Dr. Tala Mariviran. He is a cardiologist from HN, and he specializes in heart failure. And the third chairperson we have today is Dr. Sanjita Umbarkar ma'am. She's the president director and cardiac anesthesia department head at KM Hospital. Over to you, sir.
Good afternoon. Thank you very much for this organizing this CME on the heart transplant. We are starting with the heart transplant session now. In the morning we have done liver and kidney. So as long as this heart is beating, we can do other organ transplants. So it's being an important session, and we have a guest speaker, Dr. Mulli Krishnan, who has come from MGM Chennai. We have been seeing him for so many years now. A dedicated team of anesthesiologists, surgeons, intensivists, doing so many heart transplant, ECMOs, LVADs, RVADs, everything at MGM. It's a center to go and learn. I keep sending my fellows there all the time. And I've seen Murli, such a dedicated person. I remember when we have called him once for a Goa conference, his lecture was next day morning, and they had some emergency transplant. He rushed back from Goa to Chennai, did a transplant overnight, came back and gave a lecture to go in Goa. So that is his dedication. And over to Murli. We are waiting to hear you.
Good afternoon, everyone. I'm Dr. Murli. My sincere thanks to chairpersons, Dr. Saurabh, Apollo team, and ACTA Mumbai for this opportunity. I work as a senior consultant in MGM in cardiac anesthesia and critical care. Over the next 20 minutes, we'll see what's the role of echo in a patient who is coming for a heart transplant. When we talk of a patient coming for a heart transplant, we are presuming that this particular patient is already a case of an end-stage heart disease, has been somewhere diagnosed, already managed, and when you find them refractory to therapies, you refer them to a heart transplant institute. So what and how we are going to proceed once this particular patient comes to a heart transplant institute. This again, we can broadly classify into two. One, what do we do in the preoperative period? And second, the postoperative, the intraoperative and postoperative. Along with that, let us see what role it has to play in the donor, which is equally important because that's the heart that's going to work in the postoperative period. So let's look at the preoperative. If you look at the preoperative, again, this you can divide into three phases. Three phases of phase one, the patient when he walks into your hospital, what do you do? The initial assessment, what do you do with this patient? Then next comes the decision making, like what are you going to do? Are you going to transplant? Are you going to continue on medical management? And finally, the decompensation. When you mean decompensation, your patient might have registered for transplant, but unlike your kidney and liver, you have only cadaver donor. The waiting time may be long. In this waiting time, if your patient deteriorates, what are we going to do? In all these three levels, how does your echo helps you? So let's start first with the initial assessment. So why this is important and how do we go with it? So these are all your common diagnoses for a patient who comes for a heart transplant in India. The one you see here is a dilated cardiomyopathy, whether that can be an ischemic or a non-ischemic. You have hypertrophic cardiomyopathies, you have restrictive cardiomyopathies, you have ARVDs, non-compaction, apart from that congenital heart diseases. What is clear is when they come to your center, already the disease would have progressed, systolic or diastolic heart failure beyond one level. Your echo initial assessment, of course, confirms the diagnosis, confirms the severity, but also acts like a baseline echo for you to understand how this patient is going to progress or to compare at a later date when you really want to. You look at the severity parameters pertaining to that disease. How is this patient faring? So then next in the same setting, you try to do a basic hemodynamic assessment. What is the basic hemodynamic assessment? You assess the pressures, the filling pressures. How is the IVC, how is the RA pressure, what you can estimate. Similarly, try to estimate an LA pressure, the left atrial pressure. See how is the pulmonary artery pressure. So with this, what are we trying to do? We are trying to identify whether your particular patient, how much can be possible RA pressure, LA pressure, PA pressure, whether he is decompensated and sick or whether he is stable. So why does this matter? This matter for two different reasons. One, of course, you have to stabilize your patient, make him symptomatically better. The second reason it matters is the next phase we are going to do a very important test which determines whether this patient can go for which therapy. So before we do that test, we have to get the patient in an optimum status. In the sense, we cannot have falsely high numbers there. So for that reason, this becomes very important. Get a baseline assessment. Along with that, look whether your patient is having any decompensation. You put your echo probe and try to see whether there are any pericardial effusions, whether there are any pleural effusions, or is there an ascites. If you have any of this, or high filling pressures, high PA pressures, you try to treat your patient. Your treatment may include going upon your medical therapy, starting more diuretics, or starting some inodilator, or if required something more than that, and you try to optimize. As you're doing this optimization, you keep repeating your echo at regular intervals, maybe once in 2 days, 3 days. See whether what you're doing is working out. If it is not working out, see what else you need to do to make this patient better. So this is what you do in your initial assessment. Along with that, you always look out for this, a possible clots. The blood flow will be so slow that they'll have intracardiac clots, and they're really important. If you have something on left side like this, there's a very high risk of stroke. If you have right side, there's a high risk of pulmonary embolism, which will trouble as in a post-transplant RV dysfunction in the new heart. So you look for clots. If they are there, you put them on some anticoagulants. To put it again, in the initial assessment, of course, you look at your diagnosis, look at your severity indices, see how is the hemodynamic calculations, if it's decompensated or not, see whether you can optimize your therapy further. Keep a tab on that, whether he's really improving with this or not. Then look for any clots and try to put them on anticoagulation if needed. So next comes your process of decision making. So what is the decision making for a heart failure? So if you look at decision making, end-stage heart failure that comes refractory to medical therapy, you have only three options. One, medical management if it is further possible, or a transplant or a VAD. So this decision of patient for which is based upon multiple parameters, But couple of things which are very important that will decide this is a right heart hemodynamic study or a CAT study, what we call it. The second one is echocardiography. These both are the ones that will tell you which patient is for which of these therapies. So what is the right heart hemodynamic study and how an echo per se directly and indirectly through right heart hemodynamic will help you. Let us look at that. This is right heart hemodynamic study. Basically, you try to measure the pressures in all chambers of the heart. You float a PA catheter, RA, RV, PA, get an PCWP, which is a reflection of your LA pressure, get your cardiac output, then make a chart of what these are. Based on that, then you again calculate PVR, SVR, and this is what determines the further course of action in this particular patient. So this can be done either in the cath lab or in the ICU. We prefer to do it in ICU because you have more time to optimize a particular patient, whereas in cath lab you are bound by the time. So how echo will help you in this entire process? The first thing, as we have seen before, appropriate timing. That is extremely important because what the numbers you get here will determine the fate of the patient. So if a patient is in active failure or in pulmonary edema, getting the numbers may not be the right one. So the appropriate timing is the first one which the echo will tell you, optimization and take it. The next thing is your procedure. What are the chances of arrhythmias? As you see here, this patient is a case of an ARV where unless you see it on the echo before, if you go and you float a PA catheter, there is very high risk that this patient can have ventricular tachycardia or VF as you're doing the procedure there. So whether there is a risk of arrhythmias, if there is a risk, you'll be prepared to handle, or you try to go the other way, directly measure the LVDP in the cath lab. The next is, can we float the PA? At times it can happen, a lot of these patients can have a severe TR, where the tricuspid wall will not even be coapting at all. Similar will be the pulmonary wall. If you start floating the PA catheter, because of the TR, it will never go to the RV. Or even if it goes to the RV, it can very well, the trace will all be same. You won't be able to identify the trace typically like the textbook description of RA, PA, or RV pressures there. So what is the way to identify where is it is going or not going is by the echo. As you're doing, you put your echo probe and see whether it is going in or not. So can we float or not? That we'll get to know. So once we float, if you are not able to wedge, what is the other way? Very often, especially in severe PAH patients, you will not be able to wedge the PA catheter. So there, the other way is to get your calculations by the echo LA pressure, or you take them to the cath lab and directly measure the LVEDP in this patient. So it guides in your right heart cath procedure. Then it also confirms or aids your right heart cath data. So once you get your right heart cath data, what you do is you sit with the data and compare it with the echo, whether these both are correlating or not correlating. So why is it important? Like you see, in some situations, you may be having a falsely different wedge pressure. The wedge may not be appropriate. Your number may not be the true wedge pressure. That you will identify only if you correlate with your echo. Similarly, the patient can be having a MR, severe MR. In that, you may not get a typical wedge trace there. You will have something like a PA pressure trace. So that again, you identify only by the echo. Along with that, let us look at this clinical scenario where you have a patient whose mean pulmonary arterial pressure is 25, the wedge pressure is 20, and the TPG looks very good, a 5 TPG with a reasonable cardiac output, the PVR is low. This numbers alone tells you that the PVR is low and this particular patient is good for a heart transplant. But unless you correlate the same case with echo, this can be any of this, the same case scenario. It can be the one on that upside there, where you have a very bad LV with a reasonable RV, which can very well be reflected in these numbers. You have a low TPG and a reasonable RV function. On the other side, when your RV is very badly affected, it may not have adequate power there to pump and lead to adequate PA pressures. So this kind of situation also can cause a falsely low TPG and a falsely low PVR. You will be able to identify this, differentiate between this and this only if you do the echo. Otherwise, this particular patient, you still think it as a low PVR and register, whereas this particular lung would have already had an irreversible pulmonary hypertension in that case. So this you can identify only by the echo. Then next comes this CAT study and echo, or the tools which will finally decide what are you going to do with your patient. So your right heart cath along with your clinical and end organ plus echo. Finally, if you look at these two options, your CAT study may tell you, fine, you can do an LVAD in this particular patient, but if your echo has findings like this, the cavity size is very small. What the large one you're looking down is a atrium. The small one you're looking there is a ventricle. This is a restrictive cardiomyopathy there. So if your cavity size is small, so small, even if your cath is favorable, you cannot do an LVAD in this patient. Similarly, like this, if you have an aortic regurgitation there, you cannot do an LVAD there. Similarly, if your right ventricular dysfunction is there, you cannot do an LVAD. So it is not just the CAT study, Echo in collaboration with CAT study, a detailed study will help you in decide what this particular patient needs. Is it a transplant? Is it a VAD? Is this both of it or only one of it there kind of thing. Then you need to follow up. As all cardiac donors obviously has to come from a deceased donor, the waiting time varies. Some of them will be few weeks, some may go up to few months. In this time, especially the ones with the borderline pressure, they try to deteriorate or they deteriorate. At that point, the numbers what we have got in the initial study may be totally different from what you have subsequently. If you don't follow this patient and take them to the theater, you may have surprises there. So you keep a follow on them, do go at regular intervals, say once in a week or 2 weeks, see whether these numbers are same or they are deteriorating. Typically, if you go with the guidelines, they say once in 3 months you are supposed to repeat the cath, but that may not be the same with all the patients. Some of them may even deteriorate even well before that. So echo follow-up will help you in identifying the patient in whom you need to repeat the cath and identify the one who are deteriorating. Then finally, in the pediatric patient, if you have a small pediatric recipient, there what we can do, most of the times you won't be able to do the CAT study there. A lot of institutions don't even do CAT because of the risk and the unavailability of the appropriate catheters. So what the calculations are made are totally based upon the echo. How much is the PA pressure, LA pressure, or what is the possible PVR there. So it's only purely based on echo that is decided whether this patient takes a lung or a heart lung there. Similarly, if you have pediatric patient who is borderline, let us say this is a 12-year-old girl. In this, if you get a 25-year-old donor, whether this particular heart can fit into this recipient or not. How do we know? You calculate the exact cavity sizes in the recipient and keep it as a form there. And you compare this particular one with the donor on the day you get a donor. And if these both are fitting in, then yes, you can take that particular organ, even if it is an adult organ, to this pediatric recipient. Otherwise, you cannot take it. That may be a size mismatch there in that particular patient. So when it comes to decision making, your echo will help you in appropriate timing of your right heart cath. It aids the entire procedure. It confirms your findings. And if there is any disparity, you need to correlate it clinically. And it is a deciding tool what your patient needs. And in pediatric patients, this is the only way or the major way that will decide the size and the need of a transplant there. So that is how it helps in decision making. Let us see how it is useful in the next, that is the decompensation. A lot of these patients, while they are waiting for the transplant, that may often extend to weeks to months, they will deteriorate and come back to hospital with the symptoms. So how do we use echo in handling the decompensation episodes with them? So first and foremost is a lot of times what we see decompensation can very well be a septic episode. It can be a combination or something separate also. What all you may see only an infection there. So how do we identify whether this particular patient is decompensating? Apart from clinical, your echo and a comparison with the previous echo, what you have in this patient is the one that will tell you. All these patients will have all the extremes of signs. If you're looking at comparing your AVC, all of them may have IVC 24, 25 right from the beginning. But what tells you is comparison. Go back and look at your previous echo and see whether this is a decompensation or this particular patient may not be a decompensation, which tells you this is a possible sepsis there. That's one. Then once you identify that there is a decompensation, your choice of your therapies. So before all this, you do a full hemodynamic calculation. What is a hemodynamic calculation? As we have seen before, measuring the right atrial pressure, left atrial pressure, PA pressure, and cardiac output based on ECMO. This is an essential crux which will help you in managing your patient in the entire perioperative, right from the time they come to the time they get discharged or even at the latter point of time. So you do this in all the patients who come with a possible decompensation to identify whether this is a low cardiac output or not. If it is a low cardiac output, then comes your choice, what does this patient need based upon scenario, an inotrope or an inodilator. And if they have given that, is the patient improving? You have clinical parameters, but well before your clinical parameters, your cardiac output improvement by echo is something that will immediately tell you whether he's improving or not improving. If he's not improving, is not getting stabilized, what are the other options? Next comes your mechanical circulatory support, that is looking at some sort of a balloon, an ECMO, or a VAD in this patient. So that also is totally guided by your echo in this heart failure patient. So this hemodynamic calculation. Similarly, if you see something like this, if your patient comes back with a full stasis in the heart in one of the chamber, that probably indicates that he's deteriorating and going for a decompensation there. So once you decide for a mechanical circulatory support, whatever it is, a balloon or an ECMO or VAD, the need of therapy, whether he needs it or not, the choice of therapy, which type of therapy are you going to use in this patient. Like in this case, you see there is a severe biventricular dysfunction. Obviously, VAD is not going to work in this patient. So the choice of therapy is again based upon your echo guidance there. Then once you decide, yes, we have to go for this therapy, doing the procedure, like if you decided ECMO for this patient, right from the time your basic puncture to the cannulation to cannula position, everything has to be echo guidance in this. And once you initiate a particular therapy, maintaining, it is not just putting them, making sure this particular patient is stable and fit till you get an organ. Like you put them on ECMO, there's always a possibility of an LV distension. So you look for that, and once you see that, you find a way to vent the ventricle, surgically or cath lab, whatever the way it is. So this entire thing, need, identification, choice, everything is totally based upon your echo parameters there. Similarly, for a ventricular assist device, if you're looking at a temporary one, if the patient has any clots there or an aortic regurgitation, how is the other ventricle? If you're looking at a right ventricle support, how is the LV? If you're looking at a temporary LV support, how is the RV? The entire decisions are based upon what you see in the echo there. So to look at the decompensation episodes, it helps you in identification of decompensation, differentiation from sepsis. It helps you in optimization, your hemodynamic calculations, what you do there, and serially monitoring them. If you're not able to stabilize when it comes to the point of mechanical circulatory support, what is the need of it, what is the choice, and the process of initiation, and once you initiate maintenance, everything is totally echo-guided, and it has to be done bedside in this patient. So the entire pre-operative process, right from the time they first come, the initial assessment, then subsequently the decision making, then if they are waiting at the time they deteriorate, the decompensation episodes, everything is totally echo guides you in handling these patients. So before we go into how do we handle in the post-operative period, let us look at what is the importance of the echo when we look at a donor assessment. Donor assessment has to be thorough in a full way, but the cornerstone of your assessment is purely echo, especially in our Indian setting where getting a coronary angiogram is difficult. Your echo is the main thing. A lot of times you find it difficult to get a good images of transthoracic, so better to put a T probe and do that. Your assessment has to be totally thorough. Just because we get a 25-year-old male who didn't have any significant cardiac history doesn't mean that this heart we can just have a quick look and say everything normal. You have to do a thorough assessment from a structure, function, look at every valve and see how is the chambers there. A lot of cases which had asymptomatic findings, which are otherwise gross findings, have been identified when we are screening the donors. Similarly, any RWMA is a concern there, and practically getting an angiogram is difficult. So your more sensitive indicator of CAD in this patient is an RWMA or an LVH in a hypertensive patient where we should not be using the heart. If you go and do an echo in a donor, let me say, as I said before, a 25 years male, you expect you do see something like this, a brisk heart with a perfectly working LV and RV there. This may happen in most of the times, but this won't happen in all the times. It won't be a surprise if you see something like this, a stunning heart, where your LVEF has come down to 20% or less than that. This happens because of the stress cardiomyopathy. This we will be able to identify only if you do serial echocardiograms. So when it deteriorates from a point where it is 60% to a point where it is 20%, this can happen over a period of just 12 to 24 hours. What is important is, of course, we are going to reject the organs of this. What is equally important is know how to handle these kind of organs which are in between. When you see something like a 35 or 40% where the heart is just we try to optimize them. If they are really getting better, then only we can consider using that particular organ. Otherwise, if they are serially deteriorating or they do remain safe, taking organs from this kind of hearts, even though they come as a 35-40% EF, they may not behave well in the post-operative period. So similarly, an RV dysfunction in a donor is always a red flag. Whatever the reason, unless you have it clearly because of a bad lungs, where once the PA pressures are settled, the RV may become normal. If you see something like this, usually that particular donor heart is not usable. You have a dilated RA and septum shifting to the left side. That particular organ usually is not usable. Again, a common issue, what you see in donors where echo helps you is a mitral regurgitation. A lot of times these donors are managed with very high doses of vasopressors. Norad and vaso are the usually preferred thing, and you do see that MR of more than 2+ quite often there. So what is the reason for this MR of 2+? Is it a pathological MR? Does this patient has a problem with the mitral wall? Or is this just a high afterload which is causing that MR? Only a thorough echo assessment of your mitral wall looking everything in detail, optimizing the patient, repeating the echo subsequently to see whether this is settled or not settled. That only will tell you whether this particular heart is usable. I mean, that is just a physiological MR because of high afterload, or there is a pathological problem there in that particular patient. So then let us look at the post-transplant phase, that is both the intraoperative and the post-operative phase there. Intraoperatively, what is important is to check the anastomosis there. Usually you have an LA anastomosis, which is almost never a problem. Then you have an SVC, IVC, aorta, and PA. What you are seeing is the aorta and PA. Usually they are also not a problem unless there is a significant size disparity between the recipient and donor, like you have taken an adult organ for a pediatric recipient or where there is a weight of more than 1.5 times. There can be possible disparity. So you always check your anastomosis. These are the SVC and IVC anastomosis. You check and make sure that they are all, there is no turbulence in the flow across them. Then you do assess your ventricular function. As I said, even if you take from a very good donor, you expect the heart will work like this. That is a good biventricular function. But this may not be what you are seeing in a good number of situations. You may see something like this where there is an LV dysfunction. This may not be there in the donor preoperatively, and this may be a new finding what you are seeing postoperatively. Or you can have an RV dysfunction like you see what is there in the top. Or it can be a biventricular with RV and LV are bad. So if you see this, what is it? It is primarily means it's a graft dysfunction. The newly put heart is not working the way you want it. So it starts with what is the reason. You have both primary and secondary. Before we call it primary, you have to rule out your secondary causes. You look at the other secondary causes, but one we can look on echo is look back the anastomosis, whether there is any anastomotic issue which can cause a secondary graft dysfunction, especially if it is in a pediatric heart transplant. If not, you start with this. You identify that there is a problem or there is a ventricular dysfunction. Then it is called as primary graft dysfunction. There is a clear classification. For LV, you have mild, moderate, severe. And RV, you have just the dysfunction. This is based on both echo and hemodynamic variables. But what is important when we talk in context of echo is this one. One, it can happen in the first 24 hours. You have a good ventricular function inside the theater doesn't necessarily mean it will translate into a good function post-operatively. You can have a deterioration within the first 24 hours. This can be progressive. What you see a 40-45% can come down in the post-operative period, and always rule out secondary. And your work or your use of echo first starts with the diagnosis, in the sense that if you see a patient that who is having the ventricular dysfunction like you have seen in the previous slide, it starts with that. Once you identify that, you start using all the measures what you can to help this particular patient. If you are still in the theater, probably support them for some more time. Or in the post-operative period or in theater, try to increase your inotropes or inodilators or other measures to increase your cardiac output. You keep repeating your echo at regular intervals to see whether this particular measure has helped this patient. Is the heart getting better or not? Or if the patient is further deteriorating. So once, depending upon where you are, then does this patient needs anything more than this? Does he need mechanical circulatory support? All these questions will be answered only by your serial echocardiographies. So that emphasizes that in a patient when you're dealing post-operatively, you should have echo available there by the bedside in the entire post-operative period. So apart from this, you do see all this in a post-transplant patient, depending upon what you're dealing. It can be an isolated RV dysfunction, may or may not be a PGD, LV dysfunction, pulmonary hypertension, afterload mismatches will be there, pericardial collections and tamponates. You will be able to identify a particular problem and able to treat it specifically that you're handling this. Only if you have an echo and only if you get an idea of what you are seeing there in the echo. Like this patient had a severe RV dysfunction. The one on the right was supported with an ECMO there. The one here was a post-transplant where it has to be supported with a temporary RVAD there. So when the patient, as you keep monitoring, once you see that they are not responding, the point to initiate the mechanical circulatory support, and once you put on mechanical circulatory support like the RVAD there, try to stabilize them, and once you stabilize them, identify the right time to wean them. When are you going to wean this patient? That starts with the improvement in your right ventricle function there. So all these are totally echo guided. You keep a close watch on the echo in the post-operative period. And finally, coming to the rejection, which is the common trouble in the post-operative period. Let us look at 4 different case scenarios before we understand this. One, you have a patient who is perfectly normal post-operative course. Echo was perfectly normal and no symptoms there. On 10th day, you just do a surveillance biopsy that comes as a rejection 2 hours there before you ship the patient out of ICU. The second case, patient had some ventricular dysfunction. You had a clinical doubt, again around 1 week post-operatively. You do an echo that comes as, again, rejection 2R. You have a third patient who had a elevated PRA before the surgery, and there is a persistent RV dysfunction. You're not able to taper off inotropes post-operatively. You go ahead and do a biopsy. You are thinking of rejection because of ventricular dysfunction and elevated PRA in this, but you don't find any rejection in this patient. And a fourth one, who comes crashing. Transplant underwent a couple of years back, comes crashing to your place, to the ER, and then you see that there's a severe biventricular dysfunction. You do an echo that shows a rejection of 2R. So what does this mean? This shows the variations that can be there between your echo findings and the rejection that is gold standardly diagnosed by the endomyocardial biopsy. Before we look into practical aspects, what we need to know is rejection starts first with a pathophysiological thing, then there will be a subclinical, preclinical, then there will be an acute clinical deterioration. Echo is only, it can identify only in this phase. Anything before this, your echo will not help you in identifying that this particular patient is possibly having a rejection. So if you want to put it up as a practical points, how does echo help us in rejection? It is a screening tool. In the sense, if you have a patient who is transplant, whether it is immediate or in the post-operative long term, you keep screening them regularly to identify. If you identify any ventricular dysfunction there, you always think as possible echo there. So it is certainly a screening tool. A normal echo does not rule out rejection. A lot of times we do see that the echo may be perfectly normal, but you do biopsy there, you will see a rejection there. Then if you have a dysfunction, that is especially a new onset dysfunction, that always suggests the possibility that this patient is having a rejection. So you keep a close watch on both systolic and diastolic functions of the heart, keep it closely. The moment you identify that there is a deterioration or a dysfunction, then you go for an endomyocardial biopsy in this patient. So, and this is not a replacement for an EM biopsy. Certainly the gold standard for diagnosis or identifying is only the EM biopsy. Echo is only just a screening tool, and there is no association with the severity. A severe LV dysfunction on an echo doesn't mean patient is having a grade 3 rejection there. You can just find only a grade 1 rejection there. So how does it help? It helps us in these two. One, once you identify a rejection, like a patient comes crashing to you, you start your rejection therapy. This helps you in seeing the response to therapies, whether this particular patient is responding to your rejection therapies or not. If he is not responding, what next therapy he needs. For suppose the one which has come in shock, you give steroids. He's settling well and good. If he's not settling, you start thinking more even before your biopsy report comes. Is this an AMR which is crashing? Whether we need to give a dose of IV immunoglobulin there in this particular, or need a plasmapheresis, or is he responding to this or not? So that is one big advantage with the echo. The second one is handling crisis. Whatever the degree of rejection, whatever the pathophysiology, if your patient becomes hemodynamically unstable there, to start with the basic assessment, to seeing the response of your inotropes, or to the extreme extent that your patient needs a mechanical circulatory support to temporarily support till the heart recovers, it is only totally by your echo guidance what goes on. So this is how echo helps you in handling a rejection in the post-transplant phase. A lot of echo parameters have been studied in multiple studies there, like we do practice strain and everything in all patients post-operatively. But again, it is very variable. In the immediate post-operative period, at least for the first year, the strain may or may not be. Even there are scores that have been predicted in the literature. But what it is nothing has been consistently proven or associated or come to a point where it can replace a biopsy. So it is just only an adjuvant tool or a monitoring tool. It is not a replacement tool for a biopsy presently. So to sum up, this comes as an inseparable tool. The echo, when you're handling a patient in the perioperative period, it starts with your identification, optimization, doing your CAT study, analyzing and offering what you can possibly do for these patients, handling your decompensation episodes, and the entire episodes of how do you do mechanical circulatory support in this patient. Then similarly, the post-transplant PGD, identification management, and any low cardiac output handling, and rejection handling in these patients. Apart from that, donor assessment is also equally important. Thank you.
Thank you. Thank you, Dr. Murli. That was a fantastic overview. You really took us right from the point of the initial presentation with heart failure to donor optimization to the time of transplant, the immediate peri-op period post-transplant, as well as post-transplant surveillance for rejection. So thank you for that. As you correctly mentioned, echo is an inseparable tool from all the other wonderful diagnostics that we have readily. I would just like your comments on assessing diastology in the initial few weeks post-transplant. What has your experience been, and has that shown any correlation with your first few biopsies? You said you mentioned you do your first biopsy at 10 days, and I guess the next one at 30 days or something. Yes. So what has your experience been?
Systolic is something you can easily measure, but measuring diastolics is practically difficult. You may not get the good quality imaging. You want to do a full tissue Doppler, everything, you may not get that. But what will be striking is a certain set of your RV diastolic dysfunctions. I mean, LV you do see more than common than that is RV diastolic dysfunctions, where you do see that particular patient, if you just look at the RV, it may be looking small, it may be contracting well, but you measure the CVP or you look at your right atrium in your echo, you see that looks pretty full. So that's probably the diastolic dysfunction of RV, which is, I feel, is underappreciated, which has equal trouble in terms of your liver, kidney dysfunction, inotrope requirement, everything post-operatively. Correlation with biopsy per se as a marker of rejection in the immediate post-operative, difficult to comment. Diastolic dysfunction. Systolic, yes, certainly associated. If you have a new RWMA or a jerky kind of motion, yes. But diastolic dysfunction, yes, it can happen. Correlation with rejection in the immediate post-op, difficult to comment, but long-term it is clearly associated with that.
Yeah. So, I agree. Even as a cardiologist, looking at patients long-term, several years post-transplant, assessing diastology, LV diastology in post-transplant patients is always a challenge. The ASE, the European guidelines actually do not have specific cutoff or any criteria for assessing diastology in post-heart transplant patients. However, we know that the post-transplant heart behaves differently, right? It's a denervated heart, so its chronotropic response is completely off. So, a lot of the times you will see EA fusion. Even on tissue Doppler, you will see E prime, A prime fusion. You cannot rely on the IVRT, the relaxation times as well. So often, you have to go outside the guidelines, use your clinical judgment, and if this one is there, then maybe, get clues from that as well. So thank you.
Fantastic lecture.
Thank you, ma'am.
I wanted to ask you one question for my sake. Suppose there is a donor of 40 plus age, and we don't have time, and there is no history of any coronary artery disease or something. So can we get away by doing dobutamine stress echo and not going for the coronary angiography?
Ma'am, this has a lot of practical thing rather than what it goes by the guidelines. If we just go by the guideline, anything more than 40 or associated with risk factors has to have a coronary angiogram before we accept. Unfortunately, in Indian scenario, the practically that getting implemented is less than 10% without any doubt. Very difficult to get it done. So how to go about that? A dobutamine stress echo also has issues. A lot of times we do start inotropes, but what really happens on the donor bed end is that you have multiple teams there who have apprehension about the different drugs we use, especially the tachycardia or the associated fall in pressure. That may be associated with your improvement in cardiac output, but you find it difficult to convince the other teams. So dobutamine stress echo theoretically maybe yes, but we have not used much in a practical sense. You just try to have a very keen look at your echo to identify even a very subtle RWMA there in your patients who are having a risk factor, anyone more than 35. Having said that, so many hearts we have seen where the age more than 35, excellent ventricular function. Once you open and see, you see so many coronary plaques. That's just the same thing what is reflected in the society, so many undiagnosed CADs around with younger people. So the way of assessing and ruling out CAD is still not the perfect way in our setup at least. You just rely on your echo parameters, have a high doubt of suspicion based upon the history, especially the ones who are having a stroke as a cause of the donor there, rather than a trauma. So, and associated comorbids like a left ventricular hypertrophy or anything, there you have a very high keen on doubt. And you just open and physically see the coronaries. That's how it is crudely in most of the cases right now. But again, having said, there are centers where you will be able to convince and get an angiogram we should always try for that, but it all depends. We may not be successful there. Kind of.
And one more question, that advanced tools of getting systolic function, LV systolic function like GLS and all, whether it is applicable, can we do after transplant?
After transplant, at least in at least more than 50% of cases, you will have a disparity between the pericardial cavity and the donor heart. Most of the patients, unless you're dealing a complex congenital where the cavity might not have enlarged, you are all dilated cardiomyopathies, even restrictive cardiomyopathies where you have large atria. There's always a huge disparity between that. So the donor heart, if you see surgically, will be just in one small corner of your pericardial cavity. So getting a good post-operative image is technically very difficult, and we may get images which can able to assess you what is this function to make you take decisions. In the sense, PGD is there, how is the ventricular function, can I vena inotropes or do you need to go up? All this you'll be able to. But getting a very good clarity image like getting a strain there, you want to get all three views perfectly there, may not be practically possible in all the patients. But yes, maybe a week or down the lane, it starts coming. We keep monitoring that on all patients default. But again, it is shown that in the first immediate post-operative period, going up to 1 year, strain, a lower strain is reported to be normal. It's not that all of them will have 20 or more. 10, 15 strain also has been reported to be in the immediate post-operative period up to 1 year. What probably may be important is a serial follow-up. You just have something there, which you will be able to probably roughly around a week or 10 days from the post-operative, and keep a track on that, 15 days, 20 days, how is this coming down, or is the same? That probably you compare if you have a clinical doubt. That's how we can go with that.
Thank you.
In the initial 3 months, it's actually normal to see restrictive kind of filling,
Pattern,
T3 diastolic dysfunction. But beyond that, if your restrictive filling continues, then that's a marker of worse prognosis. In fact, if you look at one of the guidelines for one of the criterias for classifying severe coronary allograft vasculopathy, one of the things right at the end will say that a restrictive diastology is a cutoff, so is one of the markers. So it's beyond 3 months, having a steep LV filling is not good. That's what we know. But in the initial first few weeks, getting GLS and diastology is very challenging and may not really mean anything. The most important thing, as Dr. Murli said, is the trend. We never, even patients who are several years out with absolutely normal biopsies, absolutely normal cardiac functions, even on MRI, they rarely have normal GLS. They're generally between -15 to -20, somewhere in that range. Normal being, at least -21, depending on the vendor. Yeah. So.
Thanks. Fabulous lecture. No, just wait, don't go. There will be probably questions from there. Just a small question. You said, one of your lines said, normal echo doesn't mean no rejection.
Yes.
So, do you have any more mode of diagnosing it, like say imaging, cardiac imaging, MRI, cardiac MRI or something? How often do you use this in your practice?
Sir, again, the answer depends upon what period of time you're looking at. In the immediate post-operative period, like your main way of identifying is only a surveillance biopsy. The surveillance biopsies have been curtailed by the numbers in India, mainly starting with the practical issue of financial handling there. So the way you screen them in our place regularly is you do an echo without fail every day, do that everything. Even if you don't get a strain, you try to do that, just record and keep it. But again, that doesn't really rule out all of your patients. You're not 100% foolproof there. You look at your clinical parameters. Your PRA practically does not make any practical sense in Indian settings. And you look at your ventricular function, you see how quickly you are able to achieve your target immunosuppression post-operatively. Whether within 2 days, 3 days, have you able to achieve to TAC level therapeutic there, or for some reason, more common being the renal dysfunction, not able to achieve, or for some other reason, you're not able to give a second drug, that is myfortic, the patient has diarrhea. Like in this kind of patients, you always have a high index of suspicion. The way of doing it is only by biopsy. Echo will help you in identification only by biopsy. But as a general policy, no patient will be shifted out of ICU before doing a biopsy. The patient may be all good by 4th day, 5th day, all inotropes off, chest drains off, he may be just sitting in chair, but he'll sit in the ICU. for the concern that that unidentified rejection, which is not picked up on echo, can trouble if he goes to the ward. So that's not shifted out, that's one. Then if we look at in the general, like long term, when you're handling a rejection there, MRI is not in the immediate post-op, may not be practically, doesn't make much practical application there. In long term, now you have this different markers. How much each of it practically applicable, you have to see case by case basis. What is available here, we have cell-free DNA here. We have donor-specific antibodies. DSAs help you in identifying only the AMRs. cfDNA helps you in identifying the rejection much early than what you see in your echo or anything. But again, that has to be analyzed based upon caution. You have to look at multiple things there and see whether this is really going up or is that falsely high or falsely low there. So you have biomarkers, but they are also not come to a level where they can compete or take over. MRI long term is supposed to be a very good thing, but has not yet come to a level where it has been incorporated into the guidelines and say that fine, you do this, you can get out without doing a biopsy there.
I guess interpretation is what is very important in MRIs. Yes. So, any questions from the floor?
Liquid biopsy, I don't know.
So liquid biopsy is the same as the cell-free DNA.
Cell-free DNA, yeah,
Donor-derived
cell-free DNA,
cell-free
okay, yeah.
So it's freely available in India. Lal Path Labs is doing it across
lot
the
of them
country.
do.
There's several other independent labs who are doing
Tracks
with
are
their
there,
own
yeah.
platforms. I think MGM has presented its data. Even us, we've presented our data both in the local as well as ISHLT, and we have very good negative predictive value for cell-free DNA. We have very good negative predictive value, almost going above 95 to 96%. This is data from around, say, 60, 70 patients with 140 odd samples. But the positive predictive value specificity is not that great. So, I don't think we are there to the point where we can eliminate biopsy, endomyocardial biopsy, but in surveillance, it is a good kind of tool. It may help us reduce the number of biopsies rather than doing something invasive. If it's negative, then you can be rest assured then, that it's okay. I have yet to see a patient who's had a normal echo, a negative cell-free DNA and positive rejection.
Yeah, I mean, cell-free DNA is widely available. As I said, it's a screening tool. The practical issues, you cannot do it in the immediate post-operative period. And again, you need to analyze it from the practical point. What are the other, you compare, you just get the absolute value of the cell-free DNA, you compare it with the donor and recipient, donor-derived cell-free DNA, what percentage of it. So what are the other factors in this particular patient which are influencing either his own DNA values or the donor-derived, that is the organ-derived cell-free DNA values. That's the second thing you have to interpret. Like a post-biopsy you do, it is not supposed to be reliable. And again, I think after 4 or 5 years, it doesn't have any role. Once the risk of having a CAV sets in, at least according to the current CAV, it can identify the CAV, but with that underlying CAV, using it as an additional marker for rejection, as of now, you don't have any recommendation or guidelines from the society for that.
Yeah, okay. There are no further questions from the audience. Lina?
Thank you.
Thank you very much.
Thank you, Dr. Murli. It's always a pleasure to listen to your lectures. I request Dr. Sanjita Umbarkar ma'am to felicitate Dr. Murli Krishna, please. पुढे या, पुढे या. May I request Dr. Saurabh Tiwari to felicitate our chairpersons. Dr. Uday Gandhi, sir. Come in the limelight. You are in the limelight today, Dr. Saurabh. Dr. Miran, please, Dr. Saurabh, can you? President Director, Dr. Umbarkar ma'am. Okay, thank you, Dr. Saurabh. We move on to the next lecture. I invite the chairpersons for the next lecture, Dr. Vijay Shetty. Sir is the head of Department of Anesthesia and Cardiac Anesthesia at Fortis Mulund. Vijay, sir. Dr. Shailesh Kamkhetkar is a cardiac transplant anesthetist at Jupiter Hospital, Thane. Dr. Santesh Kaushik, sir, is a CVTS surgeon at Apollo, New Mumbai. Sir. So the next topic of presentation, what we have is how to prepare the patient for lung transplant.
So we are already running late, so on behalf of the chairpersons, Dr. Shailesh, Dr. Shantesh, I invite the next speaker, Dr. Unmil, to tell us about how to prepare a patient for lung transplant. Obviously, it is easily understood that unless a proper preparation is done, the whole purpose of the transplant is lost. So preparing a patient for a lung transplant especially is a big challenge, and we are fortunate to have Dr. Shah here to tell us how to go about it. Over to you, sir.
Yeah, so I think we are waiting for the laptop to come. So let's see, there is no laptop here.
In the meantime, Dr. Unmil, you can just tell us about yourself.
I'm transplant pulmonologist of almost like 6 years of experience in lung transplant, and currently we are operating we have an active program at HM Reliance Hospital. So today's talk is about how do I prepare the recipient for the lung transplant, and my focus is more going to be on the practical aspects of the pre-lung transplant evaluations, what we do. There are some 40-50 tests. I'm not going to touch all those 40-50 tests, but I will be highlighting the practical, the most important tests which definitely have influence on the outcome and have the prognostic, which help in deciding the prognosis and the outcome post-transplant. So let's begin. How do we prepare the patient for the lung transplant? So this was the news almost 3 weeks back, and it baffled the lung transplant centers across the world that this is a recipient himself, he's a pulmonologist himself, a doctor, had lung cancer and had liver mets. And he underwent a double lung and a liver transplant at Northwestern University at Chicago. And 6 months post-surgery, he is cancer-free. So this news just makes us think that whether really candidacy matters for the lung transplant, or you can transplant, anyhow, permutations, combinations, or really are there any absolute contraindications? But yes, practically if we see, there are absolute contraindications and the candidacy plays a very important role. But looking at this news report, I think it's a time where the horizons are going to be soon bigger and higher for the lung transplant. So principles, a full evaluation is necessary. As we all know, assessment of the lung disease severity, anatomy, nutritional status, degree of frailty, presence and severity of the comorbidities, psychosocial circumstances. But as pulmonologists, we see often that there is sometimes a turnaround time, a turning point along the course of the disease of an end-stage lung disease patient. It leads to a precipitous decline. The patient lands up on a ventilator or an ECMO, and then we get a referral for a lung transplant. Is it too late? Well, probably we don't know, but then at least in such cases also, every effort should be made to fully evaluate a potential candidate's eligibility as is in similar manner to other candidates. So what are the general candidacy considerations? As per the revised guidelines in 21, Lung transplantation should be considered for adults with chronic end-stage lung disease who meet the following general criteria. There should be at least more than 50% risk of mortality from lung disease, within 2 years if the transplant is not performed, or if there has to be more than 80% likelihood of 5-year post-transplant survival from a general medical perspective, considering all the comorbidities, provided there is an adequate graft function. As we know, double lung transplant has been increasing over the decade, and that goes without saying that it gives you a survival benefit as compared to doing a single lung transplant. Coming to the concept of transplant window, what is a transplant window? This is the phase along the course of the disease where if the recipient is referred and gets transplanted, he gets the maximum outcome or the benefit of the lung transplant. Doing too early is not going to help, doing too late will not help. So rapidly progressive disease, increase in oxygen dependency and increase in hospitalization, these are some red flag signs which every pulmonologist should look into it. Some recipients may have narrow windows, some may have broad, but it's very important to be vigilant along the course of an end-stage lung disease patient. Coming to the pre-op evaluations, or how do I go about deciding the candidacy, there are some battery of tests. I have highlighted few of them which I will be discussing. Blood tests, specifically the PRAs, which are the panel reactive antibodies, which helps us decide how allosensitized the recipient is. Cardiac evaluations, apart from echoes and ECG, we do the right heart cath and CAGs. Cardiac MRIs as well in select few. GI evaluations, very important because we are always wary about GERD or GERD. Lung perfusion scans, Dopplers, sonars, and obviously we need to evaluate the lung. So HRCTs, PFTs, walk tests, USGs, and ABGs. So let's come to specific tests, and these are going to be all practical points for evaluating the lung transplant recipient. We are very obsessed about the mean pulmonary arterial pressure, and hence the reason behind it is because it's a strong recipient risk factor for primary graft dysfunction. Primary graft dysfunction is basically a lung which after implant within 72 hours does not function well. We have ruled out all other secondary causes, and the pH in the recipient becomes one of the important risk factors for PGD. We know that echo sometimes can overestimate the real PSP by more than 10 millimeters of mercury in 1/3 of the patients. We don't get a window properly, or it can underestimate. This was a paper published in BMC Cardiovascular, and it showed that the echocardiographic PSP measurements were moderately discriminative to diagnose pH. The absence of TR does not preclude elevated PSP. And hence, in this paper, it was recommended performing routine RHCs or right heart caths to all lung transplant candidates, regardless of the echocardiographic estimation of a pulmonary arterial systolic pressure or presence of TR gradient. Again, coming back to the same question, why are we obsessed about the mean pulmonary arterial pressure? Because it has been found that the mean pulmonary arterial pressure was higher in patients who developed PGD at 72 hours as compared to patients which did not develop PGD. Also, it does have a prognostic value. The 1-year survival rate among patients with mean pulmonary arterial pressures more than 25 was lower than the survival rate among patients with mean pulmonary arterial pressures less than 25. So this paper again showed that the presence of the preoperative pH of pulmonary hypertension was also associated with an increased risk of postoperative complications. Coming to the next tool, which is important as far as the cardiac evaluation is concerned, is cardiac MRI. Helps in advanced end-stage lung disease patients with severe pH and RV dysfunction. Also helps in Eisenmengers, which are frequently referred for transplant. Helps to decide which patients would go for a combined heart-lung versus which would benefit with bilateral lung transplant in patients of IPH. There is a paper which has mentioned cutoffs where below the double lung transplant is deemed inappropriate, which may vary from 10 to 25% for the RVF and 30 to 50% for the LVF. The RV systolic function and dilatation are the hallmarks determinants of the outcome in PH, as we all know. So this is the pictorial diagram. We have picture on the A, which shows the typical MRI scan for a patient of PH. The RV and the RA are severely dilated, as we can see, and there is septal bowing towards the LV. And the picture B mentions or shows post-lung transplant status MRI, where shows both RV and RA have decreased in size. The RV has remodeled back, and the interventricular septum deviation is restored. This was a practical case. We had a 46-year-old female, scleroderma, a GP practicing in UK, which came to India for the transplant because the UK guys were not ready to operate. Scleroderma, ILD, end-stage lung disease, severe PH. We went ahead with the echo. The echo showed RA-RV dilated, TAPC of 20, RVSP of 112, LVF of 55%. We got the RHC done, RA mean of 6 mm, PS systolic of 104, diastolic of 40, and mean PAP of 61. Cardiac index was 2.1. Normal biventricular filling pressure, severe precapillary pH with moderately reduced cardiac output. We went ahead with the cardiac MRI. What did MRI show? Marked RV hypertrophy with dilatation. LV was severely compressed by hypertrophied and dilated RV and bowing of the IV septum to the left. Depressed RV and LV systolic functions with RVEF of only 18%, LVEF of 40%, and RA dilated. And there was focal intramural LG fibrosis noted at the insertion points. She went ahead with the combined heart-lung transplant, recently completed 1 year and flew back to UK. Coming to the gastro assessment, again, as I mentioned, we do go for this battery of tests, doing sonos, but what is more important as far as lung transplant candidacy is concerned is evaluating the presence of GERD or the GERD, and that is what we do it with the help of two tools, that is 24 hours pH-metry, impedance 24 hours pH-metry, and esophageal manometry. Why are we again worried about GERD? Because pre-transplant GERD is associated with worst early allograft function and survival. It is also the risk factor for increased risk of acute rejection, pulmonary infections, and CLAD, which is chronic lung allograft dysfunction. So this was a paper published, and if you can see on these Kaplan-Meier graphs, the double lung transplant with no GRD group fared better as far as the outcomes are concerned as compared to the double lung transplant with the GRD, vis-a-vis, again, if you compare the same subset with single and GRD versus no GRD. So we need to be aggressive about evaluating GRD and treating it. Esophageal manometry again helps us finding out, is a technique to determine the function of the esophageal musculature, and most often we pick up hiatus hernias on the manometries. And that hiatus hernias become one of the indications for doing anti-reflux surgeries post-transplant. So we have had few patients who have undergone lab fundoplications after the transplant, and that has helped in stabilization of the FEV1 post-transplant. So this is again a Kaplan-Meier graph which shows patients or cohorts with reflux did poor as compared to patients with no reflux as far as survival is concerned. Coming to lung perfusion, again, we were doing up till few months, now we have stopped doing it, but most of the time when we just do a perfusion scan on end-stage lung disease patients, we get a common finding of bilateral, small, large, variable, segmental and subsegmental perfusion defects, and depending upon the variability of these or the severity of the lobes involved. And you will get a differential perfusion data, right lung 36%, left lung 64%. But which lung would you explant first? So usually, I mean, I would just like to ask the audience if they can tell, can you raise hands, for the left lung, will the left lung come out first? Anyone for the left lung in the audience? Or anyone for the right lung in the audience? Yeah, so the right lung definitely would come out first because you are doing a pneumonectomy and then the patient is going to be on a single lung. Obviously nowadays we do all lung transplants on central VA ECMOs where this data or this perfusion finding does not matter nowadays. But doing transplants off pump, definitely this is one of the important tool to find out which lung would be explanted first. Coming to walk distance, again, pulmonologists, I think this is not something which is a rare tool. Pulmonologists love to do 6-minute walk tests regularly, and it has been validated and proven that it has been associated with the waitlist mortality in patients, those who are waiting for the lung transplant on the waiting list. And also, there have been various figures quoted. Some guidelines say less than 350, some say 400, but a walk test less than 400 meters appears to be a reasonable marker with regard to when a patient should be listed for transplant. And that goes across all the end-stage lung disease etiologies, whether it is bronchiectasis, whether it is IPF, whether it is COPD. Coming to another test, what we do, panel reactive antibodies to understand the alloimmunity and the allosensitization of the recipient, because that's very important. Significant elevation of PRA has been associated with worse survival post-transplant. And as we evaluate such candidates, it prepares the transplant team to devise a desensitization protocol perioperatively to minimize the risk of rejections post-transplant. Anything PRA above 25% is a concern. Even less than 25% PRA, if you get class 1, class 2, it's important to get the single antigen bid class 1, class 2 to find out which would help potentially correlate with the donor HLA. Coming to frailty, again, it's coming in a big way in transplant across all the multi-organs, and we are also evaluating frailty quite frequently nowadays in all our recipients. And this SPB, which is a scoring system, which is a short performance battery scoring system, which is a validated one, which we use it regularly, and I always tell my physiotherapists to include this in their assessment apart from the other assessment tools what they use. And SPB scoring has been associated with the increased risk of 1 year and 4 year mortality. So it's a very well standardized, validated index. Rehab, rehab, rehab. Nothing works without rehab. So whether you have a patient on a waiting list, whether it is a post-op patient, do involve the physiotherapist right from day one to go ahead with the pulmonary rehab, limb physiotherapy, because that's one of the most important interventional tools what we have seen, which makes a lot of difference in the recovery of the patient post-transplant. So this was again a Kaplan-Meier graph which shows in this study where the PRP or the pulmonary rehab control group did better in the short-term and the long-term survival as compared to the control group. So pulmonary rehab makes a lot of difference in the survival. Coming to other select evaluation aspects, BMI again. BMI more less than 16 becomes a relative or an absolute contraindications, where though we have done few patients of BMI 11, 12, they have done well. BMI above 35 becomes an absolute contraindication. So if you have a patient with BMI of 35, if they can lose weight, which is easily said than done, it becomes an absolute contraindication because it is associated with a lot of post-operative complications. Functional status and frailty, as I've already discussed. Psychosocial evaluation. We do CPAT scoring quite common. So I always speak to my psychiatrist and the psychologist and tell that we need a CPAT scoring, which is again a standardized scoring to evaluate the psychosocial and the mental health of the recipient. Infection disease, again, detailed evaluation. You send pan cultures, blood, urine, sputum. You also send various markers, whether it is CMV, EBV, and vaccinations, which are very important to be done pre-transplant when the patient is on the waiting list. So again, case 1, this was a 35-year-old female referred to us, IPH, seen for the first time in the OPD because she was going across the city with various pulmonologists. So IPH since 2015 with 3 syncopal attacks in the recent past. The PSP of 128 and RARV dilated was on Pulmonex, Ditor, Tadalafil, referred for lung transplant in Jan 22. Revil 2.0, which is a standardized, again, a scoring system for PH, and I would urge all of you to, all your IPH patients should be scored with this Revil 2.0 and the classification which the European Society of Cardiology and the ERS has given. And considering all this, was this a right transplant window when this patient was referred to us? Vis-a-vis a case 2, 56-year-old female, progressive fibrosing ILD, chronic hypersensitivity pneumonitis, which is by far the most common etiology ILD in Mumbai. Since 3 years, radiological progression noted, ABG showed mild CO2 retention, PA, no pH on the RHC, walk test was 2 centimeters, pulmonary function test, FVC of 25%. Was this the right time to refer? So if we go through the, again, those slides, case 1 probably was a delayed referral, already it was a suprasystemic pH, and case 2 was a referral in the right transplant window. So last 2 slides about various myths busters, which I would like to just point out. Multiple retrospective studies over the past 5 years have shown that patients with mild to moderate coronary artery disease or those who have undergone revascularization for coronary artery disease may not have worse survival compared to patients without. CAD again was not associated with worse survival for patients undergoing percutaneous coronary intervention with stent placement prior to transplant or doing CABGs at the time of transplant. And we have done a couple of them. Multiple studies have demonstrated that carefully selected patients with connective tissue disease or the autoimmune disorders have no difference in the survival or the allograft dysfunction compared to patients undergoing transplants for other indications. Studies of scleroderma recipients undergoing lung transplant at centers with expertise with this patient population have demonstrated that esophageal dysfunction does not appear to impact outcomes. Nevertheless, it is always prudent to keep monitoring the GERD if they have. While MDRO organisms are no longer universally considered an absolute contraindication, several pose substantial risk, specifically the Mycobacterium abscessus in the NTM category and the Burkholderia species. Review of the most recent literature demonstrates that although up to 45% of the lung transplant recipients have undergone previous cardiothoracic procedures, no survival difference. So if you have a past history of pleurodesis, it's not an absolute contraindication for doing a lung transplant. So take home message, rational judicious approach for a preoperative assessment. We have gone through various preoperative factors which can influence the outcome post-transplant. The pulmonologist should be aware of such factors. Be vigilant about the transplant window along the course of the disease, so had to be referred to a transplant clinic. A patient who is referred to a transplant clinic or undergoes an evaluation does not mean lung transplant. I mean, that's a common myth or misunderstanding in the community that, okay, I've been referred to a transplant and the transplant will happen. No, there is a lag between a referral and a listing. The societies have clear-cut outlined the criteria for referral and for the listing as per the etiology of the end-stage lung disease. And rehab, that's something which is very, very important, and I my team works in close association with the physiotherapy department right from day one. Thank you.
Yes, excellent talk, and I think summarized everything perfectly. One conundrum which we always have is, suppose there's a recipient who, you have listed the recipient, he's ready, you're choosing a donor lung. Now, in the donor lung, all the criteria are fine, except your secretions have grown an organism. So, because this is a very common situation, so what are your criteria to determine whether that lung should be taken or not?
Yeah, so that's a very practical question. Now, one thing I think we need to understand that all the donors are on ventilators. So, moment you intubate a patient, you will have some micro aspirations happening, and patients have anyways 3 days ventilation minimum to sometimes 10 days of ventilation, what we have seen. And definitely when you do a bronchoscopy in such patients, you may find purulent secretions, or you may just do a lavage and the gram stain may show something, on the gram stain, predominantly the GNB is what we commonly come across. But it's very important to, just not focus on the gram stain or the bronchoscopy finding, but also correlate with the various clinical parameters, that is, look into the procalcitonin, look into various other cultures, whether the donor is really septic or not, whether also if you have a CT scan available, if that most of the time now in Mumbai and Maharashtra, we do have as a protocol undergoing a CT chest. So you correlate with the CT chest. Now CT chest sometimes, and we have seen that after the COVID era, where during COVID it became mandatory to do a CT chest. Before pre-COVID era, it was like going all on X-rays. So on CT chest, we definitely find out of 10, 8 CT chest where you will find some collapse consolidation, or you will find some tree inbird, or you will find some infective bronchiolitis. But it's very important that there is a paper also published that whatever gram stain you get in the ET secretions or on the tracheostomy secretions does not always translate into the post-transplant pneumonia. So organisms are going to be there. There is no escape. But presence of organism does not indicate that the lung is going to be the source of infection or the donor is septic. We need to correlate with the clinical, microbiological, radiological, and sometimes practical to see, understand, and then take a call. Sometimes we also, as we assess the lung, my surgeon opens the chest and, they palpate the lung and see. You can do manual bagging. Sometimes it's just a collapse or atelectasis, which is visible on the radiology as a collapse consolidation. The radiologist has referred. You do manual bagging and the lung opens up beautifully. So it's not a consolidation at all. So it's very important to correlate with all these parameters and then take a call. Do not reject the organ just on the basis of that you have a gram stain positivity.
Yeah, basically like in the urine, it's asymptomatic bacteriuria versus invasive. So,
48 to 72 hours on ventilatory support, something is going to grow.
Thank you. Again, next question, like when for preoperative evaluation, when you do in every patient's chest volume calculation for CT scan and any CT scan parameter, you have to be like in perfect match for the donor, like in pulmonary vein and pulmonary artery. The specific sizes wise, you keep it ready.
So we don't do that. The volumetric CT scans, if you have the facility available, well, you can do it. But if you have an in-house donor, then you can do all those things. If you have a donor somewhere else, it's impractical to do all that.
For the recipient, will you keep it ready?
So recipient, we have the volumes calculated, because that is what our radiologist always does it, because they have a transplant protocol, so we do it. But to get a donor volumes also, it's very difficult unless until you have an in-house donor.
So many times the donor center also have the same specific calculation. If you tell the radiologist, he will keep ready for the things what you require.
But I think it's the most important again would be to, if you have the luxury of getting volumes on donor and recipient, well and good. Otherwise, you have the predicted TLCs, formulas available where you can calculate. But we have seen that those calculations are more of Caucasian based formulae, where it doesn't fit into the Indian subset, where we see that even if the predicted total lung capacity of the donor and the recipient comes to around 0.9 or 1 also, there is still a significant size mismatch when you implant the lung. So definitely those formulas are still there to guide us.
Last couple of quick questions. You said that you stopped doing the perfusion scans, if I heard that. Why is that?
Right. Because nowadays we do all transplants on central VA ECMO. So once we do a patient on central VA ECMO, then usually doesn't matter because then we don't have so much of hemodynamic or any hypoxic changes or hemodynamic fluctuations happening. It's more of a cruise control. But off pump, whenever you do, definitely that's something which is very important, that we need to know which lung to explant first.
And in your practice, which are the patients who were referred to you initially for a lung transplant, but then they ended up getting a heart-lung transplant? So you could just enumerate in your experience.
So heart-lung indications have gone down dramatically now. I mean, worldwide and even in our program also. So only 2 indications what I can see where we think about doing heart-lung. One is obviously you have a Eisenmenger with a complex congenital heart disease, or you have a end-stage lung with an end-stage heart. Now, one important caution is like if you have a IPH patient who has been listed for a bilateral lung transplant, and as we know in Bombay, there is the donation rates are very, very poor actually. So you have a long waiting time, and it shouldn't happen that that IPH patient, the pressures have gone up now. You did an evaluation in Jan, now it is September or October, no organ available, and if you forgot to do any repeat evaluation, and it shouldn't be that now he's a candidate for a combined heart-lung transplant. So I think IPH patients, patients with severe RV dysfunctions, those are the patients where we need to be very vigilant, provided if there is a long waiting time.
Thank you. Any more questions or comments from Dr. Murli?
Thanks, Dr. Unbil. Enjoyed your talk. I just have one. Very often we do see patients, and as I said, won't come in the right time. Let me say someone who is undergoing an ATT or a non-mycobacterium non-tuberculosis drug, or let me say any fungal infection there, molds there. So what is your call there? A patient who is already sick, oxygen dependent, you still suggest to wait 6 to 9 months till they finish the course, have a total clearance, or at some point you think that considering the risk or chances of them living, you leave?
Right. So that's a very, very important question. Now, it all depends upon, as you mentioned, the severity or the sickness of the recipient. Now, if the patient is just on the oxygen support, but doing absolutely fine, we treat the infection. Getting the sensitivity, how drug resistant is that infection is very important, because if you don't have much options to give or to treat that infection, post-operative again is going to be a challenge. Mycobacterium abscessa or Burkholderia is not an absolute contraindication. Some of the centers keep doing it. We have also done it. Fungal infections, again, we need to prophylaxis them with the azoles, what we do it early on, pre-operatively. If it's a very sick patient, a delayed referral sick patient, NTM, and there are no other absolute contraindications, and we are confident that I'm going to able to control this infection post-operatively despite the immunosuppression. We discuss with the family, tell them that this is going to be the risk-benefit ratio. If the patient is very sick, probably on vent or ECMO, and if the family agrees considering the risk-benefit ratio, we do go ahead, but definitely need to have a good infection control. Depending upon the susceptibility or the sensitivity pattern is very important. We should have the confidence to treat this infection post-op. That's very important, because most of the time lung is a source of infection. We are removing the lung out. So it's like debulking the sepsis burden. But whatever residue remains, whether it is in the blood, urine, or in the native trachea or the native bronchus, needs to be cleared. So should have confidence to treat such infections post-operatively. If you are confident, you have those multiple options available. It's not a pan-drug resistant drug. It's a case-to-case basis call. Nothing is, as per the guidelines, very clear-cut about it.
So you do a detailed evaluation, you start looking for, because any extrapulmonary presence of it, obviously you're going to find it hard to handle it post-operative. It's only in intrapulmonary you're going to just probably lucky enough to get it out with the donor organ being
so extrapulmonary means where is the focus? Now suppose you have, abscesses in the liver or abscesses in the spleen, or you have the lung, then it's a very difficult choice. Then definitely we would not go into the transplant. So it all depends upon the infection burden. If it's just a lung, which is a source of infection, blood culture is negative, urine negative, no inotropes, patient is doing absolutely fine, no fever at all, just that repeated sampling grows, that NTM keep coming again and again, or the fungus, then we definitely think about it, considering risk-benefit ratio, because such infections are not absolute contraindications, but they have to be decided on case-to-case basis.
Hi, we have worked together for almost 2 years, so I know the pre-planning and all. So just one question, because for example, if we have some donor who has had hanging cause of death or poisoning as a cause of death, so these are not a complete contraindication for lung, but have you had any successful hanging or poisoning as a cause of death and still taken lung? For example, drowning we do not take, but what about hanging and poisoning?
So at least, in Mumbai in the last 3-4 years, we have not taken anyone. not come across.
Because international data
but yeah, I mean,
suggests-
poisoning, I mean, one has to be very careful about, whether it is an OP poisoning, which is the most common cause of, the poisoning what we see.
have you
And it
accepted
does
any?
have effect on the lung as well, the OP organ. So it all depends. Sometimes you get paraquat poisoning, which is also very common. We have done paraquat poisoning recipients undergoing lung transplant, but not the donors actually. So basically,
Dr. Murli also, I wanted to ask this question.
Actually, I mean, hanging, we had few donors in India, but I'm not sure whether poisoning cases have become donors.
yeah,
I
no,
don't
there are some donors, but rarely it comes a scenario where you see a hanging or a poisoning where it is the lungs are preserved, but there is something in the brain or anything. But very rarely, I mean, we have come across donors with non-specific etiology. I mean, where they have ruled out toxicology, urine, nothing has grown. There is a suspicious poisoning. The cause of death is not very clear. So those are some rare subgroup of patients where we have to be careful.
A lot of states still, the rule is
Right.
wherever you have that ambiguity of MLC, that goes for that forensic
MLC
autopsy.
clearance.
Forensic autopsy.
Yes.
It doesn't come to your
Yes.
in harvesting and the autopsy post-harvesting. And they won't.
Right.
Your ambiguity usually comes when you have a donor with unexplained cause of brain death.
Right.
Whether that is some viral infection which you have not picked
So
up.
that also becomes an MLC actually, because it's an unexplained cause of death.
We have used 2 patients. We have done 1 heart transplant with a hanging
Hanging,
donor
yes. Hanging, yes.
and
But
1 lung patient also for hanging.
Hanging,
Both were
yes.
successful. No issues in the intraoperative or post-operative.
No, hanging, yes, but poisoning donors.
Poisoning, I don't think.
Yeah, that's what
are a
I have not
candidate
come
for as a
across the
donor.
poisoning. Hanging also, at least my team in Bombay, at least we have not used it. But yeah, I mean, we can still use it. That's not a contraindication.
Okay. I think with this, I'd like to end the session. Before that, I just want to thank all the delegates would notice that each team will have somebody who's pushing the program. So you can look at Dr. Unwil, you can look at Dr. Murli and Dr. Thalla, that they put in a lot of effort in making sure that the program runs well. And if young people who are watching need to develop and walk on this path and develop the same dedication to bring out the same outcomes that we desire in most of our patients. Thank you, Dr. Unwil. That was an excellent talk.
Thank you, Dr. Unmil. I request Dr. Santesh Kaushik sir to felicitate our speaker, Dr. Unmil. I request Dr. Sanjeev Jadhav sir to felicitate our chairpersons. Dr. Vijay Shetty sir. Dr. Shailesh Kamketkar. And Dr. Santesh Kaushik sir. Thank you, sir. We move on to our next lecture. I invite chairpersons for the session. Dr. Sanjeev Jadhav sir. Sir is the cardiac heart transplant surgeon at Apollo New Mumbai. Dr. Vishwas Sathe, Secretary Actor Mumbai and Chief Cardiac Anesthetist at MGM Hospital Panvel. Dr. Bhumika, I think she's not there. I request Dr. Lakshman to chair the session on her behalf, please. For the next lecture, I invite Dr. Khushbu Dharmani. She is a cardiac and lung transplant anesthetist from Navi Hospital, and her topic of presentation is peri-op management of lung transplant.
So, hello everyone. Before the laptop sets in and it's the last lecture, So I hope everyone is not sleepy and bored, and especially the topic of lung. Now that Dr. Urmil, he's been my colleague some years back. So I think he's given a very insightful talk and detailed talk about a very well workup of a pre-transplant workup of a lung transplant. But now I think majority of us here as anesthesiologists, what do we want to know? And as rightly pointed by Shetty sir, that we have to take a lead, and how important it is in lung transplant to take this lead. We'll just So I have put this as perioperative management, not just anesthesia management. The reason being that anesthesiologists, this should be actually my first slide, because very importantly, the most important guideline, that is the ISHLT guideline, has now put a recommendation that anesthesiologists have to be involved in the preoperative, intraoperative and the postoperative phase of lung transplant. This has been a recommendation. So all of us who are planning or in lung transplants, we have to really buckle up, because lung transplants cannot be done with a complete leadership and complete taking onus in every part, that is preoperative, intra and postoperative phase of lung transplant. So all the principles of anesthesia, like just the technical aspects and basic cardiovascular physiology is a part, but what we need to know more is a part of pulmonology, surgery and everything, especially in these kind of transplants, because it is not just the intraoperative phase that we have to be completely active, because it is the preoperative and postoperative, because all of this is most important to avoid the most dreaded thing in lung surgery, that is PGD. I think Dr. Urmila has completely spoken about that. That is primary graft dysfunction. The surgeon, the pulmonologist, everybody is just concerned about one important thing in lung transplant, that is primary graft dysfunction. So all our maneuvers, all our things that we are doing in the perioperative period have to be completely regulated around this primary graft dysfunction. And this starts from the preoperative phase itself, and that is where we have to start looking for it and start managing it. Certain of the slides where there is a pre-transplant workup, we will go fast because it has already been covered. So why we need to know the survival? Because I think whatever procedure that we are doing, we should believe in that. We know how much heart transplant patient is living, at least tentatively. But lung transplant, it's very important for us to know how much is the survival. Yes, it is around 6 years. Around 6 years, and the data that suggests in Indian scenario is also around 6 years. So this is the rough period of survival. All the transplants that we know have a longer survival. This is one transplant, something like a bowel transplant, which is one of the most complex transplants, and understanding its survival and outcomes is very important. So if we see in the eras of transplant, the ISHLT has divided into 4 eras, and the recent era is one where we are trying to optimize and bring out increased survival. So our main aim is avoiding a short-term aim, that is avoiding the primary graft dysfunction, and the long-term aim is to increase the survival such that the patient live longer. So majority of the transplants now are bilateral lung transplants, as we can see with the increased registry data, that is majority are bilateral lung transplants. So 1 year survival is around 85%, and 5 year survival, if you see, is around 60%. Data from India, this is the data from India, I think is published by my colleagues from Hyderabad only, that is 84 to 70% is the survival. Roughly seeing what are the types of transplant that we do a single lung, double lung, lobar and living donor. Mostly is the bilateral lung. And whom do we transplant? We already saw who are greater than 50% risk of dying are transplanted. So indication are various: obstructive, suppurative, vascular and interstitial. I'll not go in details of that. But the most common reason in the transplant program listing is IPF, that is idiopathic pulmonary fibrosis. Knowing all this is very important, because etiology specific management of these patients is very important when managing them intraoperatively, their lung strategies and ventilation. So why this slide? It's important to understand, as he said, that early referral and selection of an appropriate candidate is very important before placing a patient on table, and it is the onus on us to see how the patient has been referred and at what stage he is being referred. There are certain absolute contraindications like any other transplant, which is listed below here, not very different, and patients which are substantially at an increased risk. What we are seeing here is that what he rightly said, frailty is an important characteristic that we are seeing in our patients. Before, it was considered as a transplant for younger patients, like only younger patients will do well. But no, if we are seeing a drastic increase in elder patients who are posted for lung transplants. So understanding their phenotype, understanding their frailty is again very important for our ultimate aim, as we know, avoiding the graft dysfunction and a longer survival. So yeah, again, what is our aim? To avoid PGD and the technical complications. So the data suggests that avoiding technical complication is very important because, for example, a patient of scleroderma, like Dr. Urmil said, scleroderma are one of, we had done one patient, scleroderma only, one of the most difficult intubations. The whole team couldn't intubate him, and we had to go an elective tracheostomy for a very long period. So understanding specific concerns and what are our anesthetic concerns related to them are very, very important. So technical complication and avoiding PGD are said to be the most important factors in the outcome and survival of lung transplant patients. So anesthesia divided broadly as every other thing in donor management and recipient management. But again, our responsibility here in the donor period increases a lot because lungs are lungs, like the heart, are a very sensitive organ for being damaged with ventilation parameters or inotropes or many other excess fluid. So balancing ventilation and balancing and maintaining the graft is very, very important. So at the donor procurement, what do we do there? So of course, after a proper checklist, consent, serologies, which is basic, which we do after arriving there. So this is in 2005, the lung allocation score had come, but that is not valid in India. It is a US-based score which deals with the waitless survival and transplant benefit, which is again changed to a composite score. But understanding what kind of donor it is very important to completely manage that. For example, a protective lung strategy is very important for managing a good donor, how much volume has been given, what settings are being made. So actively interacting with the donor team, or if there is a trained anesthetist from our side can go to the donor side, is very, very essential for protecting the graft function. So this is the strategy which is suggested, ideal good tidal volume with a good defined PEEP, keeping balanced CVP if the donor has a central line, and giving lung protection drugs like steroids and thyroxine replacement. So these are various established goals like the heart transplant, which we have to fulfill so that the donor is optimal and good to preserve the graft function. So if we do not maintain this, there are many donors that get wasted. There is a lot of wastage of organ which really happens, and many times we see the donor is actually just a 18 to 20-year-old male or a female and having good lungs but not completely optimized. So optimization in these organs is very, very important. So like I said, this is the data which suggests out of 875 deceased donor, 191 were retrieved and many of them were rejected. So this data to understand is very important. So what is important is to take judicious care of these donors. So acceptable lung criteria is, as I have put, a non-smoker, good PF ratio, all gram negative, no other history, is one of the best donors. But obviously, as previously commented, we don't usually get a completely the best donor. There are obviously some sort of aspiration, some secretion, some organism. So point is to optimize them completely. We need to understand what are the donor steps. So how we are going to excise the lung step by step, and at what stage the surgeon is giving the pneumoplagia, what solutions are used, because each of these steps, our understanding is very important because it has an impact in the intraoperative as well as in the postoperative period. So this is, I think, low potassium dextran solution, as we all know. This is Perfadex, which is used for preserving the organ. The ischemia time is 6 hours, roughly around 6 hours. We tend to extend that in lung, but safe period for ischemia is 6 hours. This is the EVLP machine. I think some people have actually seen it also. So this is for optimizing the donors. As we have seen, many of the donors are getting wasted. So this is the new perfusion technique in which there is a circulation as well as ventilation, where we are, I'll just show you a video if you can see. This is what we are doing is ventilating the lung from outside and perfusing at the same time. So this helps to optimize certain of the donors which would otherwise get wasted. So this is the Toronto lung ventilation protocol and perfusion protocol for the EVLP. Reasons to decline would be depending on the team, depending on the ischemia time, but roughly unacceptable PF ratio, a completely de-recruiting lung despite good ventilation, good PEEP, it's completely collapsing after surgical opening. If the lung is collapsing completely, full of secretion, or unknown cause of, like we discussed, the donor death is a reason to decline. So as for recipient, after a complete battery of checkup and complete tests that are done, we go for assessment. So at this assessment, our onus is to educate the patient, correctly select the patient at what stage they are, and plan for protocols to give them a complete ERAS protocol, like an enhanced recovery. Just because it's a lung transplant doesn't mean that he just has to have a lung and survive. We have to plan his post-operative early recovery, which can be with a good, we have to plan for a good thoracic epidural or blocks, or how we are going to manage his nutrition. Like Dr. Urmil said, pulmonary rehab is one of the most important, and it is important for us also because checking their nutrition levels, checking their good 6-minute walk test is very important, because that's how we are going to plan our recovery protocols in the postoperative period. So these are a battery of tests that we get done, as he had pointed out. So some important considerations are frailty, obesity, hypoalbuminemia, pre and post pulmonary rehab, GERD. So each of them have been independently associated with decreased survival and increased postoperative complication. So noting them in the preoperative period is very essential. A complete consultation review with every department is very necessary. The final decision is a multidisciplinary meeting, because every team has a meeting in which we decide when, how, and the patient has to be posted for lung transplant, because everyone has a complementary approach towards the patient. So on the day of the surgery, very important, not that the patient has been seen 2 months back. Like rightly pointed, IPF patients may have not been seen and they may develop pulmonary hypertension. So on the day of surgery, assessing the patient thoroughly is very, very important. Getting the scans, getting the blood work. We have a complete panel which we get done on the day of surgery. So these things are very, very important on the day of surgery to manage and reduce complications intraoperatively. So this is one patient, just to discuss a O-positive patient, who a 59-year-old male with interstitial lung disease. He was on 2 liters of oxygen. This is the chest X-ray. These are just to show how a patient undergoes a lung transplant surgery. This is the preoperative HRCT. This is a cardiac cath, as Urmila rightly said, that we get it done in every patient, and it is a recommendation now to see the PVR. How much is the PVR? If the PVR is high, there is a pre-existing pulmonary hypertension. It is one of the most important factors for a PGD, for developing a primary graft dysfunction. So you already plan what all you need to do. A 6-minute walk test to know how good your patient was in the pre-op, or was he oxygen dependent, bedridden, etc. Pulmonary function test, what is his actual defect. The lung scan, like he rightly pointed out, we do the bad lung first. But the era has shifted to ECMOs, even we do it on ECMOs, so we do not usually get this scans done, but managing patients on one lung ventilation when the patient is done on an off-pump surgeries, nevertheless off-pump surgeries are still done, so getting these scans are very, very important because the bad lung is to be removed first so that the good lung will tolerate the one lung ventilation. Again, PRA, HLA, we have to get it done in the pre-op. Albumin levels are very important. So albumin levels are independently associated with higher morbidity and mortality. So at times when we have a lower albumin, we actually feed the patient, or we actually completely optimize the patient nutrition-wise to develop the albumin levels, because it is an independent marker for bad outcomes after lung transplant. This again investigation is TAC metabolizer. I think this was not mentioned, but TAC metabolizer is what we do in our institute, is for knowing how the immunosuppression is to be managed in the post-operative period. So if the patient is a poor metabolizer, we can manage our TAC doses. So these are the medication usually what the patient is on. So this patient underwent a bilateral lung transplant. This was an off-pump surgery. So this is just to show you how the EtCO2 looks like in TROP, how's the PA pressure on one lung ventilation. So how much hypercapnia has to be tolerated. If there is hypercapnia, you have to manage with your blood gases. You have to manage it with the ABGs. So this is the diseased lung, as we can understand, bad lung coming out. This is the good, nice, bright baby pink lungs that we see. There's a video, I think. Yeah, so this is the back table donor preparation that the surgeon is doing, identifying the various vessels for anastomosing. So this part is very, very important. As we can see, the bad lung is replaced with a nice pink baby lung. Important to notice, just see the lung is so nicely inflated. So the lung is to be nicely at a mid-inflatory level so that it is not in a collapse state. That will be problem once you are ventilating in the recipient. So this is the, once the surgery is done, this is how the post-operative picture looks like. There is some grade of PGD. Some grade of PGD, it is said that usually there is there in the patient. But so you see the further x-rays, the patient was good, extubated later and very good on post-operative day 10. So, and what are the approaches to the transplant? There is a single lung which is done in lateral, and the double lung which we use the clamshell technique. This is how usually done. In the West, they take anterior incisions for thoracotomies, different techniques. This is the most commonly done clamshell technique. And how do we do it? It is off pump, on pump or ECMO. These are the ways which we do the lung transplant. Recent is we do it on ECMO because we don't, we expect very less hemodynamic disturbances on ECMO. Again, on CPB is another option, but anticoagulation is one very big problem. On pump, we have to maintain higher ACTs. On ECMO, we get away with lower ACTs. So intra-op, what is our concern is the induction, the managing the ventilation, the hypoxia management. Obviously a patient who's already 70 saturating, you're going to give GA, you're going to give one lung. So there will be a lot of hypoxia managing that. The hemodynamic support and MCS, when to initiate and how to initiate, fluid management and reperfusion. So this is the monitoring and the ISHLT guidelines on what is the consensus to put what monitoring. Every center has different. The percentages given are the consensus by the ISHLT for what lines have to be used. So for example, art lines, the TE probe and the bronchoscope and ECMO are one of the major recommendations, whereas cardiac output and cerebral oximetry and dynamic markers of preload for fluid management have a agreed consensus. So induction, as we know, is going to be very, very crucial because these patients may have a pulmonary hypertension. So they may have an RV dysfunction. So the RV may suddenly go into failure, or there may be arrhythmias, there may be a sudden cardiovascular collapse. So managing the hypoxia is important as well as the hemodynamics. So it's very crucial and it requires a very fine balancing of the cardiac output and the PVR here. This is the induction what I use. This is a basic, but again the article which says, the guideline says that anesthesia management has to be such that there has to be no primary or minimal primary graft dysfunction. Doesn't matter what agents you are using. Sometimes it can be a complete narcotic based or high dose narcotic based or etomidate based, etc. But it has to be completely which avoids a primary graft dysfunction. Heparin, again, it depends on off-pump or on-pump surgery. It's very important because higher anticoagulation means higher need for transfusion, higher chances of primary graft dysfunction. Maintaining a basic, like any other cardiac surgery, maintaining normothermia is very, very important. Antibiotics, we take, protocol is to be patient to patient basis. Induction immunosuppression is our domain, so we have to be very careful what kind of immunosuppression we are giving. For example, as we discussed, ATG or basiliximab. So you have to be carefully timing it with the incision and planning and when the graft has to come, or if we are doing a plasmapheresis. For example, if a patient is PRA positive and we are planning a plasmapheresis and you have given induction immunosuppression prior to that, so everything is just plasmapheresed, it's just washed off. So knowing when to give your induction immunosuppression throughout, and knowing, that's why knowing your patient pre-op, post-op is completely very, very important. Steroid doses, that depends completely different protocol of different centers. Thoracic epidural, we do not put, but there are centers who do put lung transplant pre-op thoracic epidurals because we do it on ECMO. So, so the timing of heparin is not sure. So one lung ventilation in these patients is achieved by many methods, either a double lung or DLTs, which is the most oldest and the commonest technique, or the blockers. So what nowadays which we use is EZ blockers. These are one of the most on the board for avoiding many complications in the postoperative period are the EZ blockers. These look like that. In the X-ray, if you can see, there's a nice placement of the blocker. So it's a single lumen tube through which you put the blocker, and it sits in both lungs, and it is completely blocking each of the lungs that you want. So there are different indications in which you can use it or not, but broadly, like from my colleagues in Ohio, they have almost started completely doing transplants on blockers. So it shows that it has a good quality of outcome and lesser postoperative complication, because our aim is to avoid the primary graft dysfunction and reduce as much as possible any technical complications. So ventilatory strategies in these patients have to be again tailored, etiology specific approach. For it's going to be different for suppurative diseases, it's going to be different for obstructive diseases, it's going to be different for fibrotic diseases. So main aim is to maintain SATs, maintain a tidal volume with the adequate PEEP, and avoid any dynamic hyperinflation. Like we discussed, a busy slide with lot of what has to be done when, but understanding the principles of which kind of disease it is in the preoperative period is very important to manage in the pre, intra and the postoperative period. So once the patient is on one lung ventilation, it's important to see whether the patient is tolerating that, because the whole cardiac output is going to shift. So many a times, this is one of the times when the patient is going to desaturate, have a RVD. So what comes handy here, very, very important, it's a strongest consensus of the SHLT guidelines that the lung transplant anesthetist has to be very good at the echos. So this is where, if you see, the RV is nice in the B picture and it suddenly starts dilating. So this is when, but the hemodynamics may look good temporary to you. So TE would be the first indicator that you need to shift to a alternative support, that is intraoperative MCS. Either it can be an ECMO or to go on pump, or you may have to start some pulmonary vasodilators, nitric oxide, etc., balancing your cardiac output. But this is a very good picture which tells you how your TE is going to come handy when you're going to manage these patients intraoperatively. So it's a visual assessment, and completely you get an idea how the patient may respond to clamping. Again, understanding surgical steps is very important, because if we don't know steps, what the surgeon is going to do would be just, it's not just your technical steps which are important in lung transplant. So the three major anastomosis that is done, to summarize, is the bronchial anastomosis, the pulmonary artery, and the vein anastomosis, in which the left atrial anastomosis of the donor is done with the pulmonary veins in a form of a cuff. So, and these are the three major steps. And what are the steps where there are going to be problem with the hemodynamics? The three critical phases are: once the pulmonary artery is clamped for doing the transplant, when it is released, when we are going to perfuse the graft, and third, when we are clamping it again for the second lung, because then the whole cardiac output will be shifted to the new lung. So these are the three critical phases where we are going to have lot of hemodynamic disturbances, irrespective if the patient is on ECMO. if the patient is on ECMO, we have much lesser disturbances, but nevertheless, there are going to be ups and downs. So ECMO is a preload sensitive circuit. It's going to completely depend on the preload. So managing that preload is also on the anesthesiologist, because the perfusionist cannot keep giving volume here, because we have to manage the graft function. So volume status has to be carefully balanced even if the patient is on ECMO. So intraoperatively, you look for, as discussed, chamber dilatation, RV, TAPSE. It has to be completely your assessment, completely how you are comfortable seeing when the patient needs an intraoperative support or no. So unclamping, yeah, this is the most important period. It is necessary. There's a clear communication between all the people of the team, the surgeon, the anesthetist, the perfusion. Very close vigilance is required, because this is the period when there will be a sudden hypotension, and at that time we give certain boluses of calcium, adrenaline, or some vasoactive infusions. Boluses of fluid or albumin may be given with good understanding how much has to be given to the patient, not ending up the patient in edema situation in the postoperative period. And again, after this is done, protective lung ventilation of the newly transplanted lung. So there are different guidelines on how much and when to ventilate, but most important is it depends on the donor weight. It can be managed according to the donor weight. The recent guideline again shifts it, not really according to donor weight, but protective lung ventilation as for a lower tidal volume, optimal PEEP, a good PF ratio, and the most less FiO2 requirement of the new lung. A higher FiO2 again may cause a very high chances of PGD. A higher PEEP may cause again inflation. So it has to be a very protective lung strategy. Intraoperative ECMO, as we discussed, sudden RV dysfunction, collapse, increasing PA pressures, prolonged ischemia time. If the organist come from within the city, the ischemia time is lesser. So you expect a little lesser hemodynamic disturbances. If the organist come from somewhere far, where your ischemia time is going to increase, there is higher chances of the patient going in PGD. So this is where you may anticipate. So anticipation is very important, where you're going to require a MCS, a mechanical support. And again, intraop ECMO is an institutional practice. Previously, most of the institutions, in fact, even international data now suggests doing majority of patients on ECMO. Advantages, as we discussed, a good hemodynamic stability. It has a centrifugal pump, unlike the routine CPB roller pump. So there is a lesser disturbance of the coagulation factors, lesser inflammatory response, lesser heparin requirement. And again, it can be continued in the post-operative period. So it's a good advantage, giving, it's called as the rest to the lungs. So the data suggests in every way that it reduces any sort of PGD at from the beginning to the 72 hours. So it's better to do it on ECMO. These are the different types of MCS, that is VA ECMO, VV ECMO, and CPB. So the patients may be preoperatively on ECMO, like the COVID patients and patients who are deteriorated. We may put them on VV ECMO. So, or after the surgery, there is only hypoxia, there is no hemodynamic disturbance. So we may shift the patient from a VA ECMO to a VV ECMO. So understanding which type of support is required for the patient is also very, very important. Post-operative ECMO, again, as we discussed, it is very good tool. Some centers practice it as a regular norm to continue it in the post-operative period as a rest to the lungs. Fluid management, again, it is a very important role in reducing the graft dysfunction. So it has to be, so lungs are one of the largest reservoirs for volume. So it has to be very well balanced, not to keep the patient underfilled or overfilled. So it has to be a very fine balance of managing volume in these patients, because the lung is now having no lymphatic drainage. It's only the arterial and the bronchial anastomosis that is done. So the lymphatic drainage of the neo lungs is gone. So managing fluid in these patients is very challenging, and understanding their physiology is important for a good graft function in the postoperative period. So reperfusion, which we discussed, the reperfusion phase where the newly lungs will be now flooded with the metabolites and the pulmoplegia, which was all given. So reperfusion is again a very important phase. So de-airing at this time is very important, and this is where TE comes very handy, because the right coronary may get, there may be an air emboli. So de-airing is very, very important. Watching for RWMAs, the anastomosis is important in the intraoperative period. from the bronchoscopy point of view, watching for the anastomosis, the blue lines that we can see are the surgical sutures. So watching them, any one of them has come out or there is loose leaks or anything can be known on the bronchoscopy. Optimal recruitment and all can be done after the newer lungs are implanted. So post-transplant we assess for the, as we discussed, the pulmonary veins. So we have to assess the, ideally it has to be done in the pre-op again. When we are taking the patient inside, you have to check for all the flow velocities in the pulmonary veins, and in the post-operative period we have to check for the anastomosis and any obstruction, kinking, thrombosis. So it's very important to get a Doppler of the pulmonary veins. These are the various views where we see good pulmonary vein flow. The recommendation is to see for any increase in the flow velocities or decrease in the diameter. Any decrease in the diameter or increase in the flow velocities are an indication that you need to inform your surgeon that there is a problem with the anastomosis. There is a pulmonary artery anastomosis which we need to see. Then the pain management is important, like we discussed. The ERAS protocol has to be followed in lung transplant patient. So seeing them in the preoperative period as for whether he needs whether the patient needs an epidural or blocks is very, very important. We go for plain blocks in these patients because they are much safer and they provide good or a decent level of pain relief. Also, they have lesser chances of hematoma and relation to anticoagulation. Post-operatively, managing good allograft function and protection is important. Avoiding PGD as we discussed, hemodynamically maintaining, and a good physiotherapy and nutrition is also in our forte. Immunosuppressive regimens, understanding this is important because what induction immunosuppression for a robust T cell response we are giving is the interim part, the first part, but the later maintenance phase drugs what we are giving are also necessary to understand because they may have a decrease in the urine output or a multi-organ failure. So what exactly drugs we are giving in the post-operative period, like the heart transplant, is very essential to know, and managing the rejection. So this is the immunosuppressive protocol that we follow at our center: pre-operative, intraoperative, and the post-operative protocol. Again, the neo lungs have to be, as discussed, with a lung protective strategy, good tidal volume, minimal FiO2, and a decent PEEP. So primary graft dysfunction, all the way that we are talking about this PGD. So what is exactly a PGD? Is it a rejection? It's an immune response, or what is it? So basically, it's a non-immune response that occurs. It's a form of ischemia reperfusion injury, which happens because of many donor factors and many recipient factors. Recipient factors, as we discussed, pre-existing pulmonary hypertension, etc., which we'll see further. Donor factors like a longer ischemia time, smoking history. So these are all the variables which will affect the new lungs, that is the graft function. So primary graft function is basically a non-immune mediated lung injury which occurs in the first 72 hours of the lung transplant. If you deal with it very nicely in the 72 hours, less likely that it is going to continue in the post-op. So an indication of higher grade of PGD in the initial period means the chances of BOS, that is CLADS, lung dysfunction in the longer term are higher. So ischemia reperfusion, as we see, which can occur because of many factors, pre-transplant donor factors and the the recipient factors. All of this will lead to pulmonary edema and deterioration of the graft function. This is what PGD looks like, a complete whiteout, and if you can see lot of pooling secretions, and still, but there will be lot of blood and edema and reddish in the post-operative period. So this is the criteria by the recent ISHLT for the grading, what kind of PGD is there. Again, grading is important because if it's in the initial phases, like if it's a grade 1 or 2, we can manage it with nitric oxide or a lung protective strategy, or maybe by increasing the FiO2. But if it's a grade 3 PGD, we need to plan something more, like going on ECMO or going on mechanical support like a VV ECMO or a VA ECMO. So something has to be done for a grade 3 PGD. So what are the risk factors? As we discussed, the donor factors and the recipient factors. So there are plethora of factors which are described, which will all lead to the primary graft dysfunction. And we can see the statistics that patients who have had a primary graft dysfunction because any of the variables have a decreased 1-year mortality. Complications can be surgical, infectious, rejection, and neoplastic. Surgical can be leaks from anywhere in the anastomosis, vascular complications, any injury to the nerves like the phrenic and the recurrent laryngeal, some hemorrhage, and donor size mismatch complications. So these are certain surgical complications. Rejection, any sort of ACR, that is usually it doesn't happen because we give a good induction immunosuppression, but yes, a chronic rejection can happen in the later periods, which can be seen as edema or dyspnea or increased airflow obstruction. These are the prophylaxis which we give later from the second day of the transplant: antimicrobial, antifungal, PCP, and CNM prophylaxis as any other heart-lung transplant. Future biopsies are painless. They are done under minimal sedation. It's a transbronchial biopsy that is done, and that is also where our role is very, very important, because managing these patients who are newly transplanted, they come to you again for biopsies. So managing them, their secretions, how they behave for biopsies is again very challenging. So these are certain of our cases. It's a multidisciplinary management, and it has to be done together with a meticulous planning and a coordinated approach. It's a very comprehensive topic, but I've just tried to highlight certain important things.
Thank you, Dr. Khushbu. Very detailed presentation. Just one quick question, that if you continued ECMO after surgery, do you use the same central ECMO and close the chest later on, or convert it into the peripheral ECMO?
So depends. Usually we try to convert it to peripheral, like axillary. We put a axillary cannula, we place a graft. But certain times, if it is very inconvenient, like one of our patients, we remember she had a very small, the surgeon was unable to convert to, we needed a VA ECMO and he was unable to convert it. So we kept the patient on a central, and then we shifted, and then we again took for closure, and we had to do this. But as much as possible, we try to convert
peripheral.
it to peripheral, yes.
Okay. And any idea what is the cost of your surveillance biopsies?
Yeah, so surveillance biopsies, these are, depends center to center again, but I think it is around, Urmil can tell better, but I think it is around...
Urmil or Murli, anybody can answer.
I think 40,000 or 40,000 is the price that is...
Okay. Thank you, thank you. Any questions from the audience? Thank you, Dr. Khushbu.
Thanks.
Thank you, Dr. Khushbu. I request Dr. Vishwas Sathe to felicitate Dr. Khushbu. Thank you. I request Dr. Vijay Shetty, sir, to please felicitate our chairpersons. Dr. Vishwas Sathe. Dr. Sanjeev Jadhav, sir. Dr. Lakshman. Thank you, everyone. So we move on to the next session. I request Dr. Saurabh Tiwari to moderate the next session, please.
Before that, I would like to invite Dr. Sachin Sanger to please felicitate Dr. Leena Pawar.
के पैनल डिस्कशन अभी करना है ना. हाँ मैम. कहाँ गया IT का? IT वाले क्या है? क्यों नहीं जा रहा है? नहीं, ये PP पेन ड्राइव पे.
So it was a brain tiring session. I can say that all 3 transplant one day. I can understand it's very exhaustive for the brain. So we are coming to the last part of the session, where we'll be going to a panel discussion to discuss better outcomes for all the transplants. And to encourage our students and our consultants, we have a small case scenario presentation. We'll try to be quick and finish them all. For the panel, I will invite Dr. Sanjeev sir, Dr. Gunadhar sir to please be on the stage. Dr. Lakshman sir, please. Dr. Shailesh. And Dr. Rohan sir for the liver team. Please come on the stage. To get all the transplant team on a one day at a one stage is very difficult. I'm thank you for all the kidney transplant and liver team to devote one Sunday for this discussion. Without wasting a time, let's go for the brief questions. So we have got a very good transplant team. We have done more than 500 transplant at our institutes, and all our with the support of the management and our great surgeons, we are able to do with the best outcomes. So let's focus how to get better outcomes from the transplant surgery. Dr. Urmil was very concerned about the organ donation, and he was saying that the number of organ donation is decreasing day by day in Mumbai. So I would like to ask Dr. Sanjeev sir, how can we increase the organ donation and what is the role of ZTCC in this process?
I think in 2015, I'll just go back in the history. When we were doing the first heart-lung transplant of Maharashtra, the ZTCC was not practically existent, and whatever ZTCC was existent was doing only liver and kidney cadaver donations. After the first heart-lung transplant in Maharashtra, ZTCC's role has expanded. From 2015 to 2024, you can see ZTCC has played an exceptional role in cadaver donations. So, and rules, regulations, SOPs has also increased over past 9 years. And considering the largest and population in the country stays in Mumbai, Navi Mumbai and Pune belt, and I understand the amount of organ donation what supposed to occur in this belt is not happening, and that discrepancy is always there any part of the world. Even in USA that discrepancy is there, but considering ZTCC's role, year by year it has gone exceptionally well.
Okay. Coming to the extended donor criteria, Dr. Rohan and Dr. Shailesh, can you elaborate that which donors can we include for the extended donor criteria, as we have got a long list nowadays for the transplant?
Many times, like in it depend on the patients and ZTCC criteria. Even like suppose an age is one of the criteria. So after like in 35 to 40 age of group, ZTCC by default declares and it is an extended age donor for the heart, because kidney or some other issues, many a times we can't do the coronary angiography. Yeah. But still even the heart is good. As patient is, donor patient is labeled as an extended criteria, many a times people and the teams, various patients deny to take the heart or the other vital organs. So at that time the role of the anesthesiologist, which is very crucial, to go and assess, reassess, because many times in just an echo which has been done by the cardiologist or the intensivist, it is in 10, 12, 15 years hours prior to what you have been shared in the actual on echo. If you go personally to visit the donors, all the investigation, reassessment and optimization will help and will achieve the goal to achieve the maximum number of the organ to be retrieved from the donor.
Dr. Rohan would like to add something.
The extended criteria is basically for lack of donors availability and scarcity of organs. Age is the most important criteria. For heart lung, the cold ischemic time less than 6 hours is another important criteria. And infection like Dr. Rohan said, hepatitis C or B. And there are multiple other criteria, presence of coronary artery disease or ASDs. All these are extended criteria where in spite of these, you can still go ahead and do the organ transplantation. The 5-year survival in these patients, donors, after transplantation is around similar to the donors which are otherwise normal.
So you might agree that in the case when we go for a donor retrieval, and in the OT, there is always a chaos between all the surgeons and the timings and everything. So donor retrieval, Dr. Shailesh can elaborate how to coordinate between all the surgeons, the timing, and so that everybody gets an optimal organ at a proper time.
Happy to give the answer of this question. It is always in chaos when it is in donor management. Many times it is very difficult to get the proper anesthesiologists or the senior anesthesiologists to have a proper management for the donor retrieval side. Many of the hospitals on-call junior residents or the other people, those who are managing, it is very difficult for them because they are not trained in many times in cardiovascular anesthesiology. Even taking the lines for these kind of hemodynamic unstable patient is very difficult for them. So need a proper senior consultant along with them, having a TA assessment, echo machine available, USG machine available for them. It is very essential to important, and apart from that one, the single person is available to coordinate all 6 or 8 teams which is involved in the transplant, including the renal team, liver team, the heart team, the lung team. Most of the time this job is done by the hospital's transplant coordinator, but for him to share the technical knowledge to the prospective teams, like where the cross clamp time is happening, when to keep the corridor, like a green corridor to keep ready, when first team going out of the hospital. It is always in chaos and it is very difficult for the hospital to manage this kind of thing. So key person who can do this job personally is a good anesthesia team. It is not a single one job again, not just one single consultant, because there are need 2-3 people who actually should manage the patient also and actually should coordinate with the other teams which are coming from the outside of the hospital and taking the organs to the different organizations with their specific goals and the timing, along with the green corridor.
Yes, as you came for the green corridor, I would like to ask Dr. Sanjeev about the safety practices following the green corridor. Organ retrieval is always like an adrenal rush. There was an incident where we had an accident, and we were lucky to be safe, and we could take the lung transplanted back to Chennai. It is always an adrenal rush. I remember for the first heart transplant, and Dr. Santeshwar, myself, Dr. Sachin were there, and we left the operating surgeon in so hurry that while retrieving the organ, we were so hurried to go back to a hospital that one of our surgeon was left in the hospital. So it is a case of adrenal rush, but we should be always in senses, and we have to follow all the safety practices. And Dr. Sanjeev shall elaborate about the incident, how we could be safe and keep our own team safe.
Safety is most important, whether it is surgery or otherwise. So looking at his picture, this was a horrible experience that we had. But luckily, none of us were injured, and we could go ahead and did what we were supposed to do. But safety, I agree, safety is very important. The safety issue should be dealt by the institution for which the surgeons or anesthetists and doctors are working for. Some kind of insurance should be there for transplant surgeon. This suggestion should be implemented either by the government, state government, or the institute for which the surgeons are doing. So all the team members for transplant, especially going for retrieval, should be insured. This is one of the most important. Otherwise, the risk, we can't reduce the risk of travel, and insurance is the problem.
I agree to it because our liver team also in a chartered flight, they had an accident where they skidded off the track on a rainy day, and it was they had a very life-threatening incident. But we had a talk with the management and other people. Like I was in Toronto for observership for heart transplant program. Their team is properly insured, and it is seen that the safety is not compromised. The green corridor is followed. But in India, it is always India chalta hai attitude does not. It is always taken very lightly. So it should be stressed, and even ZTCC should have a major role in ensuring safety of the team which is going for donor retrieval. I would like to ask the question to how to manage the rejection to Dr. Lakshman and Dr. Gunadhar. They are the pillars of our successful transplant program. Dr. Lakshman is our ID specialist. He always takes care when we are in problem. And to manage our ICU patients, Dr. Gunadhar is always there.
Yes, good evening everyone. So it's very important to manage the balance between rejection and infection, because once you're trying to manage the rejection by increasing the immunosuppressants, you are going to increase the risk of infection. So how do we detect the rejection? Obviously it is through the biopsy, and it depends, the treatment of rejection depends on what type of rejection it is. Whether it is a cellular rejection or whether it is an antibody mediated rejection, and what immunosuppressants needs to be given. I think Dr. Gunadhar will take you through that. But it is important to remember that once when we treat the rejection part of it for the patient, we have to make sure that we do not increase the infectious complications. Because there are certain infections like PJP, CMV, even some latent tuberculosis which may come to the forefront when we are trying to increase the immunosuppression. So that is the reason why we need to maintain this net balance of immunosuppression so that we maintain between rejection and infection.
So yeah, like Dr. Lakshman told, so it is very important for us to identify whether it is a rejection or infection. Most of the times, most of the symptoms and signs are overlapping. And particularly in a cardiac transplant, the rejections are very silent. Most of the times we don't realize actually. So that is why we have devised a protocol particularly to know, like we are regularly sending the immunosuppressant levels and also the recent immunohistochemical markers like CD4, CD8 ratio and lymphocyte markers to know actually. And the ratio sometimes help us to guide whenever we are in doubt. And whenever like we feel that it is a more like a rejection and not infection particularly, we increase the dose of the immunosuppressant, but opposite is the way when you suspect that there is a infection and particularly we need to go down on the immunosuppression, we decrease the level of the immunosuppressant and try to maintain with minimum immunosuppressant as far as possible. Because cardiac patients particularly, they don't give overt signs, like they only give minimal signs. Particularly you may find repeated LV dysfunction or RV dysfunction or sometimes right heart dysfunction. So these are the subtle signs, and picking them early is very, very important, because the more delay we make, the infection can sometimes so flare up that it is very difficult to manage the things.
Dr. Gunadhar, can you add on the ICU post-op challenges and for the follow-up, how you go about with the patients?
So the ICU course is basically the immediate and the delayed. So the immediate is within the first 48 to 72 hours, where the most important challenges are the primary graft dysfunction, the right ventricular failure, the rejection, and sometimes the infection, or the infection can be mostly the donor-derived infections. Also there is sometimes the ventilatory failure, sometimes there is a weaning difficulties. The patient may require a ECMO support after the patient comes from the OT. Successfully we have till yet come to get rid of all these dilemmas, particularly in our centers with all the successful heart transplant program, and till now we even didn't, like most of our patients, none of our patients had even required the ECMO support. But we see to it that we have kept everything on the proper standby, like ECMO and circulatory support devices. And also the other dilemmas are like the physiotherapy, the nursing care challenges. Most of the patients, they develop proximal myopathy because of the steroids. The nutrition is a very important challenge because they need a higher protein and calorie, and the muscle wastings are very, very common. And also the managing the heart failure part, the right ventricular failure part is very, very important. Sometimes hemodynamic management, giving adequate fluid, timely vasopressors, milrinone support, and we start nitric oxide to prevent the right ventricular failure, the severe pulmonary artery hypertension and right ventricular failure. We also optimize the milrinone and we guide as per the tapering dose as per the patient once he gets better. Nitric oxide has actually helped us a lot in our most of the patient management, and because of that all our patients have been successfully discharged actually, and with follow-up also they are doing pretty well.
Yeah, especially post-op, we have to watch out for infection. So typically we make a timeline of infection. So we divide the patient post-transplant, first 1 month, then from 1 month to 6 to 12 months, and then post 12 months. So when you're saying immediate post-op in the first 1 month, the infections are usually, it can be donor-derived infections, it can be reactivation of the recipient infections, and the most common are usually the nosocomial infections, because patients usually have the lines, tubes and everything. So they have a higher risk for developing CRE, MRSA and those infections. And of course, we also have to watch out for any surgical complications. If during surgery there has been some anastomosis issues or other issues, that can also be the reason why there can be immediate post-op infections. But later, more than 1 month to 6 months, it's usually the infections such as PJP, CMV, tuberculosis, because patients are on immunosuppression and these opportunistic infections can reactivate. And when we talk about post 6 months to 12 months infections, those are usually community acquired infections, or they can be latent infections such as reactivation of CMV. So in this timeline, we diagnose the patient, how the patient presents with, and what are the possible infections that can occur.
Dr. Rohan, when he had just shifted from Delhi, and whenever there is a patient who is waiting list, and when his number comes, and then we are struggling to arrange his finances. So it is not the headache of a doctor, but here even Dr. Sanjeev sir will agree that whenever we have a patient who is on list and who is coming for a transplant, again we have to go for crowdfunding for the non-affordable patients. So in this Indian scenario, what's the role of the crowdfunding, and how can we work for more patients to get the benefit?
Milap, Impact Group and Keto did a very good job, and last year we could raise funds in 44% of our patients. Somewhere institution donations by Tata Group and Transplant Health Foundation and CM Fund. So yes, it is an important part, and we can help poor patients. And it is very important also for equitable distribution of organs.
And the funding is required in the post-op period also. I have seen patients who have undergone transplant, but because of the non-availability of fund in the post-op period, even the immunosuppressants are very costly. So we have to see that there are sustainable part even in the post-op period. It is not that the transplant is done and the job is done. These patients need immunosuppression sometimes for a long time. So we should make sure that that is taken care in the post-op. Dr. Gunadhar has, I know, worked very hard to arrange funds, and we, for the first 2-3 patients, even for now, we see that when the patient is coming to follow-up, he's taking his tacrolimus or not, and that follow-up has to be done. So I would like to ask this question to Dr. Sanjeev. Do we have world-class technology? Do we get whatever is required for the transplant? And what more can be done for it?
The underlying meaning of your question is it possible to do a successful story in India? I would like to say that success of heart-lung transplant is all depends upon the experiences of your team. If your team is experienced, you will likely to get success in heart-lung transplant. Especially lung transplantation, a person who has already done a huge amount of lung surgery should only venture into a lung transplantation. And similarly, heart transplant, a person who has got excellent results in heart surgery should venture into a heart transplant. Otherwise, we have seen itself in Mumbai, there are many centers who started heart transplants, but initial results were very poor and they stopped the program, even lung transplant. So it all depends upon your surgical experience, your performance in the operation. If you do very well surgery, the chances of ICU heroics will be less. So that patient will not give you much trouble in ICU if you do a proper job in surgery, during surgery. And patient selection is one of the most important aspect of it.
Yeah. I agree to it. It's always a team effort. Dr. Shailesh, I would like to know your experience about a combined lung organ transplant like a heart and kidney or heart and liver. You had a recent experience. So is it advisable and what care should be taken?
We have recently tried for the heart and kidney transplant. It is a dual organ transplant. It is a huge multidisciplinary team involving cardiology, surgeon, nephrology, urologists, intensivists. We've taken all kind of precautions, everything. And we have explained all the risks to the relative because this patient was primarily of the renal dysfunction. So he was requiring, he was on continuously alternate day dialysis. So requiring, because of renal kidney and all these things, he has a cardiorenal syndrome leading to the right heart failure also. So after doing the angiography was normal. So it is like an uremic cardiomyopathy leading to the severe RV as well as an LV dysfunction. So cardiologist has decided that he is not the right candidate for going for the individual renal transplant because heart will not take the heat of any kind of surgery because of severe RV dysfunction along with an LV dysfunction. So ultimately the patient landed up with the option of having cardiac and the renal transplant. For going through this dual organ transplant, you need to involve all the team, multidisciplinary is very essential. Even we have not kept a single loop of issue to be not discussed with the patients or the relative because finance is a different issue and having the safety of the patient because patient was doing fairly well with the dialysis, though patient is dyspneic and not relieved with just a dialysis ongoing. So he has decided for taking the risk and the chance, but ultimately it's a decision of the whole team and the hospital to decide his safety. So we have completely decided for the single and we have mainly given a chance to and we have detected a patient is doing fairly well not to take the heart now or the kidney because it's ultimately a high risk surgery. Maybe Dr.
That is why I said it is very important to involve experienced doctors. Many of, we have done a large amount of kidney transplants also, especially when coronary angiogram is normal and patient is young. Patient is likely to have a uremic cardiomyopathy and you just do, even if it is risky, just do a kidney transplant. I have at least had 7-8 patients whose kidney heart function was 15-20%. And after kidney transplant, it became normal within a year. So it is important for the team member, especially cardiologists, to understand that this is a uremic cardiomyopathy rather than a morphologically diseased lung.
In our case, we have done the cardiac MRI to rule out that is there is no viability. So we have ruled out the possibility of uremic cardiomyopathy, which is a reversible one. So it is in many of the patients with the renal transplant do have the uremic cardiomyopathy. Once you do the proper dialysis and metabolic balances sets in, their cardiac function regain, as Dr. Sanjeev said.
So we are coming to the last part of our panel discussion. I would like to hear from all our panelists what best practices you can follow for better outcome. You can just summarize in a one point. I will begin with Dr. Sanjeev, sir.
Proper selection of the patient and proper preoperative workup and good job in operation theatre.
So for me, I think lower complication rates and lower infection rates along with the best surgical practice translates into the best outcomes in liver transplantation. What is best surgical practice is of course the proper patient selection. So in the last decade we have learned that optimizing the recipient to his best level prior to transplant and not directly going ahead with transplant once the donor is available has improved outcomes in very sick patients like patients with renal dysfunction and heart dysfunction. So for me, I think all these factors translates into improved outcome.
Now, for me, actually, as rightly told by sir, actually, so the most important thing is my job is 50% over if my good anesthesiologists and good surgeons, they are doing their good preoperative patient selection and doing a good job. Rest of the things, I think, adhering to the best standard of care, or you can say the standard guidelines, actually helps me to improve my patient outcome.
Yeah, I also agree proper patient selection is very important, but on the other hand, we should remember the organs are very precious. Just because if we suspect minimal infection is there, we should not reject that organ.
Yeah.
We know that post-op we can always treat that particular infection, and we need to follow good infection control prevention guidelines. That is very important we should do.
Along with the, like in many times it won't be possible to have a right candidate for you. So you have to insist on the proper optimization of each and every patient, and they can then take a proper decision. Along with selecting a proper window of the patient when patient is well optimized to get into the transplant. And second thing is the teamwork. Get involved every team. Don't just neglect even the ENT, because we have come across one incident in heart transplant that when patient is given heparin for the heart transplant, he was bleeding from the nose just because of rise tube like a hell. And he required blood transfusion for the nasal bleed rather than the major heart surgery.
That's what experience is. So I want to say that for the future is bright. We will having drones for our donor transfers in future. We will be having DCT transfer where we can increase the donor pool, increase the transplant volume, and this is the new thing which is going to come into the future. And again, I would like to stress that the survival rate is going on, it is picking up in all the transplants because of the excellent research. Immunosuppressant use with the better research, we can decrease the immunosuppressants if we have got a good clinical data how to support. The use of biomarkers to identify viable organs in the future is very important, so we can pinpoint which organs we can take, and it is always a team approach. I always remember our heart transplant first patient and how we worked coordinated with all our teams so that we can give best results, and this is the crux for the success story. Thank you. Thank you. I would like to tell Dr. Sanjeev sir to felicit Dr. Gunadhar sir. Dr. Day, you can come for the next case scenario discussion. We will have brief case scenario discussion for all the transplants, and they will tell you about the experiences and what difficulties they have faced during the transplant.
Good afternoon, everyone. So, I would like to talk about presentation of tacrolimus toxicity in the early postoperative period after heart transplant. So, we had a 30-year-old male gentleman who had dilated cardiomyopathy with a EF of 15 to 20%. He had a history of alcohol consumption in the past. He underwent bicaval orthotopic heart transplant, which was done on 17th of March 2024. He tolerated the procedure well, and he was shifted to the ICU on supports and ventilator. On post-op day 1, patient was hemodynamically stable with good urine output. He became conscious. However, he had a low TAPC and a mildly elevated PA pressure. So we decided to keep him ventilated for at least another 24 hours. On post-op day 2, we started, as per our protocol, we started him on tacrolimus 1 mg BD, and his beta-D glucan also had come positive, so we started TAP fluconazole. The PA pressures normalized and the TAPC also improved, so on post-op day 3, we had extubated the patient and kept him on high-flow nasal cannula. But slowly he became disoriented and drowsy. Although he was arousable and he was obeying commands, the hemodynamics and urine outputs were unaffected. The disorientation persisted over to next post-op day. He became agitated. We were suspecting CVA, encephalopathy, or we were also suspecting was he still on alcohol, was he having alcohol withdrawal. We sent the TAC level, which came out to be 13 nanogram per ml. So we considered that it was drug-drug interaction between TAC and fluconazole, which caused the very high levels of tacrolimus, and we stopped it and we started on him on injection micafungin. On post-op day 5, even after stopping TAC, his TAC level went up to 18.2. His CNS problems persisted with disorientation, although he did not suffer from any seizures. The creatinine was also normal to our great relief, and the urine output was also unaffected. Over the next few days, his mental status slowly improved. The TAC levels came down to 6 nanogram per ml on POD9, and we restarted him on TAC of 0.5 mg BD, and we discharged him on post-op day 18 without any remnant CNS symptoms. So tacrolimus is a calcineurin inhibitor, which has significantly contributed to the increased survival in post-transplant patients. In most studies, tacrolimus exhibits higher patient and organ survival rates than other calcineurin inhibitors. Moreover, tacrolimus leads to lower rejection rates and longer freedom from rejection. It is metabolized mainly by cytochrome P3A4, 3A5, PGP, and ABCB. The adverse effects which come, the first adverse effect we see in tacrolimus is nephrotoxicity, and the nephrotoxicity is such that we try to delay on starting tacrolimus by 2-3 days. So we use basiliximab as an induction agent. But then comes the CNS toxicity, which is early calcineurin inhibitor-induced neuropathy, whose clinical manifestation range from mild tremor to severe syndromes defined by confusion, agitation, altered level of consciousness, seizure, psychosis, focal symptoms, coma, even status epilepticus has been reported in studies. There is also reversible encephalopathy reported, brainstem lesions, blindness, liver failures, and also infections, as with any immunosuppressant. The target blood levels after heart transplant for within 3 months is around 9 to 12 nanogram per ml. For 3 to 6 months, we can bring it down to 8 to 9. For the rest of the first year, we have to keep it till 8 to 9. And after first year, we target it around 4 to 8. Now, for tacrolimus, the most important thing that we have to understand is the drug-drug interaction. Any inhibitors of cytochrome P will cause an increase in the tacrolimus level and will cause its toxicity. Like, most important is azoles, fluconazole, voriconazole, itraconazole, macrolide antibiotics, erythromycin, clarithromycin, glucocorticoids, antiretroviral drugs, ritonavir, and there are a few others. Also here we should mention drug inducers, the CYP inducers, rifampicin, because we might need to use rifampicin if the patient is TB furon positive or patient develops a tubercular infection later on in the post-operative period. And there we will need to monitor the TAC level because the TAC levels will drop down in these patients. Now, specifically with fluconazole, oral fluconazole has a more significant impact on drug interaction than intravenous. And specific to mention here, very special mention here, for a homozygous cytochrome P mutations are present. So patients harboring cytochrome P3A5 and ABCB1 mutations are at greater risk of such interactions. The patients homozygous for the G allele designated as and the T allele for ABCB1 are termed as non-expressors. So they do not express those enzymes. So here in these patients, the tacrolimus is only metabolized by cytochrome P3A4. Now, if this patient receives a drug like fluconazole, which is an inhibitor, his TAC level response will be very high. So to identify these subset of patients is also very important. That is why I think someone was saying about the TAC assay, TAC gene assay to be done. And the plasma TR of fluconazole is approximately 30 hours after oral administration, suggesting that the inhibition of cytochrome P may last for around 5 to 7 days after its discontinuation. In a study, Toda, Menes and Kuppers found that the dose of tacrolimus needed to be reduced by almost 50%, 38.5 to 56% to keep target concentrations. In conclusion, we can use the gene screening in organ transplant recipients, which help us in preventing the drug-drug interaction and facilitating tacrolimus dose adjustments, vigilant approach, and obviously the prompt identification by our ICU team and our infection disease specialist, sir, which helped us diagnose this case. Thank you. Any questions? Who is the next one?
Thank you, Dr. Arnav. I know we all are tired enough, but these case studies help us to grow more experience. I would like to invite Dr. Gunadhar to please felicitate Dr. Arnav De. Thank you so much, sir. Thank you, Dr. Arnav. Very quickly, we go through 2-3 case scenarios. I would like to invite Dr. Sameer for the next case presentation.
Good evening, everyone. So this is anesthetic management in an unusual case of photosystemic shunt. A 25-year-old female admitted with history of hemoptysis, no past significant medical or surgical history, including coughs or pneumonia, no history of foreign body or any trauma. On evaluation for hemoptysis, all lab parameters, including coagulation profile, were normal. Chest X-ray was done, which was suggestive of enlarged bilateral pulmonary arteries, and there was no abnormality detected on bronchoscopy. 2D echo was done, which was suggestive of ejection fraction 60%, no regional wall motion abnormality. PA pressures were around 42 mmHg, which were higher than its normal limit. IVC was mildly dilated. On right heart catheterization, cardiac output was around 5.4 liters per minute. PA pressures were 44 mmHg, and pulmonary vascular resistance was 640 dynes, which was more than its normal value, that is around 280 to 250 dynes. On further evaluation, CT scan was done, which was suggestive of extrahepatic photosystemic shunt, and a diagnosis of Abernathy malformation was established. So, Abernathy malformation, congenital extrahepatic photosystemic shunt. There are two types of Abernathy malformation, type 1 and type 2. In type 1, there is absence of intrahepatic portal vein, and there is end-to-side shunt. Type 1 is subdivided into type 1A and type 1B. So SMV and splenic vein drain separately into inferior vena cava in type 1A, whereas in type 1B, superior mesenteric vein and splenic vein form a common trunk before draining into IVC. In type 2, there is patent intrahepatic portal vein, and there is side-to-side shunt, which leads to partial diversion of portal blood into IVC. So as we can see normal anatomy in this diagram, and this is type 1A where splenic vein and superior mesenteric vein are directly draining into IVC, whereas in type 1B, they form a short pulmonary vein and portal vein and drain into inferior vena cava. In type 2, there is side-to-side shunt which drains some part of portal circulation into IVC. So management, orthotopic liver transplant is the surgical management in type 1, whereas in type 2, shunt closure is the surgical management. So this patient presented with pulmonary hypertension and was medically managed with tadalafil, macitentan and propranolol initially. And then after detailed evaluation, patient was posted for shunt closure. So intraoperative management, in this patient, a thoracic epidural at T9 and T10 level was inserted for post-op and intra-op analgesia. Standard general anesthesia was given. Right radial arterial line was cannulated for intra-arterial blood pressure, beat-to-beat monitoring. Right IGV central line catheter of 8.5 French, 4 lumen was catheterized for GTN and milrinone infusions as well as NORAD and vasopressin. Right PA catheter of 7 French, TE probe was inserted for intraoperative cardiac imaging. This is a diagram of PA pressures. So these were intraoperative PA pressures. Initially at the start of surgery, they were 64/30. As we can see, after the shunt closure, they started reducing. At the end of surgery, which lasted for 6 hours, the PA pressures were around 47/27. Surgery was uneventful. Total blood loss was around 300 ml. So there was no requirement of any blood or blood products. Patient was extubated in ICU 2 hours post-op. PA pressures were around 46/28 on post-op day 0 in ICU. Patient was on milrinone and NORAD infusion. Patient was in ICU for 3 days. On third day, PA pressures were around 40/20. So we can see there is a gradual reduction in the PA pressures. PA catheter was removed on post-op day 3. Patient was shifted to wards on post-op day 4. And thereafter stabilization, patient was discharged at home. Thank you.
Thank you, Dr. Sameer, for this interesting case scenario. I would like to invite Dr. Kalpana Thathe to felicitate Dr. Sameer.
Hello, check.
Thank you so much. Now I would like to invite Dr. Pinky Kaplani for an interesting case discussion.
Good afternoon, everyone. Okay, so I'm going to present a case of hepatopulmonary syndrome. Okay. So we had a kid, a 8-year-old female. To give you a gist, hepatopulmonary syndrome is hypoxemia due to dilated intrapulmonary vasculature, which is there in the presence of liver disease or portal hypertension, even if liver cirrhosis is not present. It has a triad. The criteria has partial pressure of oxygen should be less than 80 mmHg while breathing on room air, or there can be pulmonary vascular dilatation, which is proven by contrast echocardiography or lung perfusion scanning. And third is either there should be a portal hypertension, cirrhosis may or may not be present. So our patient was an 8-year-old female, 22 kgs, known case of Budd-Chiari syndrome. She was diagnosed at the age of 7 months and was under follow-up for 2 years. And after that, we had lost follow-up. Then she presented to ER with a complaint of breathlessness and cough since 2 days. On evaluation, her room air saturation was found to be 67 to 70%, which improved to 90% with oxygen support of 15 liters per minute with non-rebreathing mask. Clubbing was seen. Her auscultation revealed fine basal crepes bilaterally. Otherwise, she was conscious, oriented, and other vital parameters were normal. She was admitted to PICU and started on antibiotics, nebulization for lower respiratory tract infection, and on oxygen therapy. Since the hypoxia was disproportionate to the degree of the infection, okay, till we get the laptop. I'll read, no problem. So, she was admitted in PICU and started on antibiotics, nebulization for lower respiratory tract infection and oxygen therapy. Since the hypoxia was disproportionate to the degree of the infection, and also she is a known case of Budd-Chiari syndrome, we started evaluating her for HPS. So, for HPS, her chest X-ray was normal. Her room air saturation in ABG, supine position, supine position was 65 SpO2 with a PaO2 of mere 35 mm of Hg. So sitting ABG room air showed SpO2 of 73 and PaO2 of 40. We performed a contrast enhanced TEE, and the appearance of bubble was seen in the 6th cardiac cycle, which confirmed that there were intrapulmonary vascular dilatations. Then we performed a CT pulmonary angio, and it showed dilated main pulmonary artery, branches of pulmonary arteries, and intrapulmonary lobar and segmental arteries were all dilated with focal dilatation of left lower segmental arteries. There was no other pleuroparenchymal abnormality like consolidation or effusion or anything. Then we performed a technetium 99M labeled mass scan, which showed that this is to quantify the shunt fraction, like how much of the blood is getting shunted. So it showed that the shunt fraction was 54.9%, almost 55%, indicating that more than half of her body blood volume was getting shunted. With this, we started evaluating her response to nitric oxide and oxygen therapy because she was posted for transplant, and we wanted to see how she will react intraoperatively. Before taking her on table, we wanted to know whether she will tolerate the procedure or not. And for that, we admitted her to PICU, secured an arterial line, and then started evaluating her on various levels of oxygen and nitric oxide. So these were some of the data. So here we have that in supine position, room air, her PaO2 was 35 mmHg. In propped up position, it was 40. In supine position, with a FiO2 of 60%, her PaO2 improved to 45. And then in propped up position, with the same FiO2 of 60%, we had a PaO2 of 49. Then we went in for the maximum FiO2, that is 95%, which we can get with high flow nasal cannula, which is as good as comparing it to 100% FiO2 on ventilator. So with that, in supine position, we reached a PaO2 of 56.2, and in propped up position, we had a PaO2 of 56.5, not much difference. And then we started introducing inhaled nitric oxide to the system, and with FiO2 of 95, and inhaled nitric oxide 5 parts per million, we had PaO2 of 100. And in propped up position with the same setting, we had a PaO2 of 102. So with this, we posted her for transplant, and it was a living donor liver transplant. Her pre-op parameters were lab values HB of 8.9, WBC of 3,140, platelet count of 38,000, bilirubin levels of 1.17, direct 0.9, indirect 0. SGOT PT levels were 87 and 43, INR value of 1.2, and albumin of 3.4. Her RFTs were normal. Her pre-op chest X-ray, ECG and 2D echo was normal. No pulmonary hypertension was seen. Her PELT score was 6.1 and child pug score was A. So here you can see, and normally when you see a MELT score or a PELT score, it does not have HPS or a saturation value in its scoring system. So even with a severe degree of HPS, like 60% saturation on room air, the patient had a child pug score of only 1. And you know, this, she would not come up on the MELD or PELT score list because HPS is not included in that criteria. But she was very sick and she needed a transplant immediately. So we confirmed the NVM status and wheeled her to the OR. Standard monitoring was applied. Her room air saturation on the day of surgery was 70% and BP was 90 by 62. ECG was normal. Pre-oxygenation was done with 100% O2 for 5 minutes. SpO2 improved to 90% with that, and induction was done with routine fentanyl, thiopentone, and rocuronium. On reduction of FiO2 post-intubation to 60%, the patient's saturation fell to 82 to 83%. And then we decided to introduce nitric oxide intraoperatively at this point with a FiO2 of 60%. With this, we got a SpO2 of 94% intra-op. The patient was maintained on CO and Atra infusion. The inhaled nitric oxide requirement was shuffling between 5 to 12 parts per million to maintain a SpO2 of more than 92% and a partial pressure of oxygen of 65. A left radial artery line was secured for hemodynamic monitoring, and triple lumen central line or 5 French sheath was secured in right IJV. Target map of 60 was maintained throughout the surgery with norepinephrine infusion, and the PaO2 was always targeted above 65 mmHg with 60% oxygen plus 40% air plus inhaled nitric oxide, which fluctuated between 5 to 12. Now the patient received 200 ml of PCV and 1250 ml of crystalloid, 200 ml of 5% albumin, and the total urine output in the surgery was 450 ml. And her total blood loss was 300 ml. The anhepatic phase lasted for approximately 45 minutes. Reperfusion was achieved and the BP fell to lowest was 65 by 38 mmHg 1 minute post reperfusion, which was stabilized in the next 1 minute with ephedrine and norepinephrine infusion. Now, the FiO2 was prophylactically shifted to 100% during the reperfusion phase, and we had a successful intra-op course. The patient was shifted to ICU on mechanical ventilation with 100% FiO2 and NiO2 of 12, and her vitals during shifting were SpO2 of 97, BP of 108 by 60, with NORAD infusion of 0.02 mg per kg per minute, and her heart rate was 102. She was gradually weaned off ventilator and extubated next afternoon, and she was taken on high flow nasal oxygen post extubation. With FiO2 of 80% and inhaled nitric oxide of 15, she maintained SpO2 of 85 and a PaO2 of 58. Her NiO2 requirement increased to 20 in a couple of days, and later on it was gradually reduced from post-op day 4. So NiO2 was gradually tapered and she was off inhaled nitric oxide on post-op day 11. She was off O2 on post-op day 13 and comfortable on room air with saturation of 80 to 85%. She had an episode of IC bleed in the post-operative period with seizures, and she was taken for levetiracetam for the same, and she was discharged on post-op day 31 with a room air SpO2 of 98. So the thing is, the unique pathological feature of HPS is gross dilatation of the pulmonary precapillary and capillary vessels. These dilated capillaries induce ununiform blood flow, and there is ventilation perfusion mismatch, which emerges as the predominant mechanism of the hypoxia. HPS is classified as mild if a PaO2 is more than 80, moderate if it is between 60 to 80, and severe if it is between 50 to 60, and very severe if it is less than 50. Now, various medical therapies had been tried in the past, like garlic capsules or pentoxifylline, which were not successful, or proper data is not available regarding the benefits of these drugs. So, liver transplant is the only established effective therapy for hepatopulmonary syndrome. A shunt fraction of more than 20% on mass scan has been found to be significantly increase the mortality in patients, whether they are going ahead with liver transplant or not. So these findings suggest that the presence of HPS is an independent predictor for increased mortality after liver transplantation, particularly in the setting of severe hypoxemia. Now, severe hypoxemia was once considered a contraindication for LT. The institutes would not take up a case with such low PaO2, like our patient's PaO2 was 35. But with increasing expertise and a multidisciplinary approach, large numbers of patients with HPS have reported favorable outcomes post-liver transplant. Thus, it appears that even severely hypoxemic patients can be safely transplanted with excellent short and long-term outcomes if they are evaluated, optimized, and approached with a formulated plan. So, we have a happy donor and recipient pair. This April, we complete 1 month to this transplant. Thank you. Any questions?
Thank you, Dr. Pinky. Thank you, Dr. Pinky. With this, the last case scenario of our DNB student, Dr. Shinsu, very sweet and short.
Good evening, everyone. So I'm here to present a case which we have done in our OT. 52-year-old male patient, non-case of type 2 diabetes for 3 years, hypertension for 3 years, end-stage renal disease on hemodialysis thrice a week for 2 years, ischemic heart disease for 1 year, with poor effort tolerance. Weight was 57 kg, pallor on examination, pitting bilateral pedal edema. Respiratory, CNS and CVS examination were within normal limits. His regular medications were these: Achova, Flavidon, Isolacin, Ecosprin, Linagliptin and Renolog. So investigation-wise, his HB was 8.8, serum creatinine was 4.2. ECG showed T inversions in lateral leads. 2D echo showed an ejection fraction of 15 to 20%. Regional wall motion abnormality amounting to severe global LV hypokinesia, grade 3 diastolic dysfunction, severe pulmonary hypertension with a PASP of 70. Coronary angio showed a triple vessel disease. PFT showed severe obstruction with good reversibility, and HRCT showed moderate right pleural effusion and mild pericardial effusion. So it was case of a diabetic or hypertensive nephropathy which led to end-stage renal disease. So the question was, should we go ahead with transplant in this patient? So the topic for discussion is low ejection fraction and renal transplant. So coming to the pathophysiology, this slide shows the basic functions of kidney, and in ESRD there occurs the disorders of electrolytes: sodium, calcium, magnesium, phosphate, potassium, fluid overload, uremia, normocytic, normochromic anemia, anion gap, metabolic acidosis. So chronic kidney disease, the risk factors traditional, non-traditional and dialysis causes, cardiomyopathy and arteriomyopathy. Cardiomyopathy, myocardial fibrosis, LVH, systolic, diastolic dysfunction leading to arrhythmias, cardiac failure, sudden cardiac death. Same, the insult on arteries, atherosclerosis and arteriosclerosis together contribute to ischemic heart disease, cerebrovascular disease and peripheral vascular disease. This is a diagram depicting it. Myocardial alterations in CKD. So uremic cardiomyopathy hallmarks left ventricular hypertrophy and myocardial fibrosis. The LVH in CKD mechanisms are afterload related factors, preload, and non-afterload, non-preload related factors. So afterload related factors, abnormal arterial stiffness, increased systemic arterial resistance and systolic hypertension leading to an initial concentric LVH, continuous LV overload, maladaptive changes and cardiomyocyte death leading to an eccentric hypertrophy, leading to left ventricular dilatation, systolic dysfunction and reduced ejection fraction. So preload related factors, expansion of the intravascular volume in CKD causes volume overload and length extension of myocardial cells leading to eccentric or asymmetric LV remodeling. Non-afterload, non-preload related factors include intracellular mediators and pathways contributing to progressive LVH. Essential mechanisms are activation of peroxisome proliferated activated receptors, stimulation of small G proteins, the mechanistic target of rapamycin pathway, metabolic changes such as decreased fatty acid oxidation. Cardiac fibrosis in patients with CKD is characterized by diffused collagen deposition between capillaries and cardiomyocytes funneling into the maladaptive ventricular hypertrophy with subsequent dilatation of the heart. Furthermore, there is epidemiological collinearity of the prevalence and incidence of CKD with aortic and mitral valve disease, calcification of cardiac valves, in particular the aortic valve. So risk stratification. Prevalence of left ventricular systolic dysfunction in patients with ESRD is high, estimated 16 to 18 of ESRD patients affected in the literature. Of these, 60 had presumed non-ischemic cardiomyopathy as diagnosed by the absence of myocardial ischemia on perfusion imaging. The pathophysiology of left ventricular dysfunction in end-stage renal disease is thought to relate to the uremic milieu, leading to alterations in cardiac structure and function. The risk of uremic cardiomyopathy increases with the time spent on dialysis. Patients with end-stage renal disease also have a high prevalence of coronary artery disease, which predisposes to the ischemic cardiomyopathy. Although there is no cutoff value of ejection fraction, patients with left ventricular systolic dysfunction and end-stage renal disease are often considered poor candidates for renal transplant because they are at high risk of perioperative complications. So 5-fold increase in cardiac mortality and a 2-fold increase in all-cause mortality, and a 70% increase in post-transplant cardiac complications with left ventricular ejection fraction less than 45%. However, guidelines. So all guidelines have a consensus opinion that symptomatic patients warrant further evaluation. Similar heterogeneity is seen in screening for coronary artery disease because retrospective studies did not suggest a mortality benefit with the cardiac stress testing or coronary artery assessment and intervention before kidney transplantation. It is not surprising that that how to proceed once abnormal echo findings have been identified is not clear, and how to identify which patients would benefit from the transplantation in the setting of a depressed ejection fraction remains a topic of debate. So this is a study, effect of kidney transplantation on left ventricular systolic dysfunction and congestive heart failure in patients with end-stage renal disease. This study demonstrates that kidney transplantation is associated with a substantial improvement in LVH in end-stage renal disease patients with systolic heart failure. Even patients with severely compromised cardiac function, that is pre-transplant LVF less than 20%, were able to successfully undergo the procedure and derive a significant benefit after kidney transplantation. The investigators also observed major recovery in patients whose heart failure include blocked or narrowed heart arteries, a condition known as the ischemic heart failure. A longer duration of dialysis in this patient may result in progressive and ultimately irreversible myocardial dysfunction. Therefore, the patients with ESRD and systolic heart failure should be encouraged to undergo kidney transplantation as soon as the diagnosis of systemic heart failure is established, preferably from a living donor, to avoid the current wait for deceased donor kidney transplantation. Coming back to our case, cardiology and pulmonology fitness given with high risk, discussed in detail with patient and family, plan to go ahead with the transplant surgery under general anesthesia with invasive monitoring. Live donor versus wife. Patient was having left HD catheter in situ. All the invasive lines were secured before induction. Artery line left femoral 20 gauge under local anesthesia. Central venous catheter right subclavian under local anesthesia. Induced with fentanyl 100 mcg, etomidate 10 mg, vecuronium 5 mg. Maintenance was with sevoflurane. MAC was maintained around 0.7 to 0.8. Non-anesthetic medications used were solimetol 500 mg, Simulec 20 mg, albumin. Post-transplantation, Lasix given 40 mg stat and 40 mg over 2 hours. Baseline BP was 148/64 and heart rate was 69. NORAD single strength started at 1 ml per hour preemptively. Dobutamine started at 0.5 ml per hour and requirement went till 2 ml per hour. Nicorantil was started at the rate of 2 ml per hour. Heart rate was maintained within the range of 60 to 80. BP was maintained systolic between 140 to 160. Range and diastolic 60 to 80 with a map of 90 to 100. CVP monitoring done. Baseline CVP was 8. CVP during anastomosis between 12 to 15. Fluid management was done according to CVP. ABG was done intraoperatively, which showed no acid-base imbalance, and ABG was repeated before extubation. Total surgery duration was 4 hours. Total blood loss was 200 ml. Total input was 1450 and urine output was 500. Patient was reversed. Patient extubated, was conscious oriented after extubation and was complaining of mild pain for which pentosan 15 mg was given. Patient was then shifted to ICU. SpO2 100% on 4 liter O2. BP was 136/58 on NORAD 1 ml per hour, dobutamine 1 ml per hour and Nicoran 0.5 ml per hour. Patient intake output vitals monitored in the ICU. Nicoran, NORAD, dobutamine tapered and stopped. Started with immunosuppressant, tacrolimus, antibiotics and other prophylactic treatment. On discharge, patient was hemodynamically stable and serum creatinine settled at 0.8 mg per deciliter. So 2 years after this transplant, the patient had amputation for the right great toe gangrene. During the pre-op workup, ECG showed the same findings of T inversions in lateral leads, which was there during the time of transplant also. But the 2D echo showed a significant improvement. The ejection fraction, which was 15 to 20, went up to 40, and regional motion abnormality was there, but mild global LV hypokinesia, grade 2 diastolic dysfunction, mild LVS, and no pulmonary hypertension with a PSP of 28. During the time of transplant, he had a severe pulmonary hypertension with a PSP of 70. So that's it for today. Thank you.
Thank you so much, Shinsu. I would like to invite Dr. Pranali Patil to felicitate Dr. Shinsu. Shinsu is also actively involved in all the backstage preparations, so we must appreciate for her efforts.
With this, we come an end to the academic session. I thank you all for patiently waiting till the end, and I would like Dr. Sanjeev sir to felicitate Garima to smoothly conduct this session. It was quite heartening for all to encourage our students which are working all the day and they prepared for the presentation. So we said we will not cut off this session and we should felicitate them also. Dr. Garima, please. I would like to give big thanks to all my organizing team who have tried all the last months for making this program success. I would tell Dr. Sanjeev sir to felicitate Nishma. Dr. Deepali. Amartya. He's working day and night for the success. He's the backstage hero. He sent invites to all the chairpersons. Dr. Anju. Dr. Shruti also, you come on the stage. Thank you for helping us. I would like to thank our sponsors who have made this program successful: Edwards, Fresenius, Neon, and if I'm forgetting any name, thank you all our sponsors. And Mr. You will get to know the quality of photographs. Mr. Ravish, who is clicking our photographs effortlessly, I would like him to please come on the stage. His team has worked. We'll see the results. Dr. Ravish and team. Please give them a big clap. Our LED team under Dr. Vaibhavi. Martin, can you please come on the stage? Thank you for the effortless performance, Martin, or anybody from the team for the LED. From there, the smooth function was possible. I would like to invite Dr. Vikram, our chairperson, to please conclude and say a vote of thanks. Dr. Vikram is our coordinator, and with his all help, we could manage our functions.
Thank you all for being here and making this CME a success. And I hope we all have learned something new from the knowledge and experience that was shared by all the speakers. And I hope it's a well spent Sunday today. Okay, thank you.
I would invite everybody to please come on the stage for the group photo, please. Our housekeeping team has also helped us tiringly. I would like to thank them also and our management. Please, everybody come on the stage. Thank you. Thank you.